Declare open this hearing of the Community Affairs Legislation Committee into the 25-26 supplementary budget estimates. I begin by acknowledging the traditional custodians on which we meet today and pay my respects to the elders past and present. I extend that respect to the Aboriginal and Torres Strait Islander people that are here today. The committee has fixed Thursday the 29th of January 2026 as the date for the return of answers to questions taken on notice. The committee would appreciate if senators could please provide any written questions on notice to the Secretariat by Thursday the 11th of December 2025. The committee's proceedings will begin with the Department of Health, Disability and Ageing, whole of portfolio and corporate matters. The committee will be conducting today's hearing in person and via teleconference. Understanding Order 26 of the committee must take all evidence in public session. This includes answers to questions on notice. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and I remind committee members such action should be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. The Senate has endorsed the following test of relevance for questions at Senate estimates hearings. Any questions going to the operations or financial positions of the departments and agencies which are seeking funds in estimates are relevant questions for the purpose of estimates hearings. I remind officers that the Senate has resolved that there are no areas in connection with the expenditure of public funds where any person has a discretion to withhold details or explanation from the Parliament or its committees unless the Parliament has expressly provided otherwise. The Senate has resolved also that an officer of a department of the Commonwealth shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions for asking explanations of policies or factual questions about when and how policies were developed. Witnesses are reminded of the Senate order specifying the process by which a claim of public interest immunity should be raised. I incorporate the public interest of immunity statement into the Hansard. I remind senators of their obligations under the Behaviour Code for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. An officer called to answer a question for the first time should state their full name and the capacity in which they appear. I remind committee members and witnesses who are appearing by teleconferences who are not speaking to mute their microphones. A live caption shall be enabled for the entire duration of today's hearing. The feed will be displayed on selected video conferencing monitors at the witness bench, in the back of the room and in the waiting room. We ask witnesses to please inform the Secretariat if at any time during the hearing they are experiencing any issues, and they will endeavour to troubleshoot them as quickly as possible. I welcome today Senator the Honourable Malarndirri McCarthy, the Minister for Indigenous Australians, representing the Minister for Health, Disability and Ageing. Minister, do you wish to make an opening statement?
Good morning, Chair. I'd just like to also acknowledge the traditional owners of this land and just pay my respects to elders past, present and emerging, and pleased to be here.
Thank you, Minister. I also welcome the Secretary from the Department of Health, Disability and Ageing, Mr Blair Comley, PSM. Mr Comley, do you wish to make an opening statement?
No, thank you, Chair.
Great. I will now call officers from the Department of Health, Disability and Ageing in relation to the whole of portfolio and corporate matters, and I invite questions. I will share the call to the Coalition to start. Senator Ruston.
Thank you very much, Chair. So just wondering, Mr Comley, when the department's intending to answer the 28 unanswered questions on notice from the last estimates?
I will pass to Ms Balmano.
Rachel Balmano, Chief Operating Officer.
Sorry, the 28 questions I put on notice last time. I understand others did as well, but just the ones I asked.
So some more of those were tabled yesterday. So
yes.
we've now tabled 40 of the questions that you asked, with 20 outstanding.
Okay, so there's another 8 since I looked at it last night.
Yes.
Yep, plus 8. Okay,
so they may not have shown up on the website yet.
Yep, okay, so when are the final 20 going to be made available? Because the information that's contained in those 20 is probably the more serious and important information. So when will we see them?
So it depends on which of those you're most interested in.
I'm interested in them all, Ms Balmano.
Yes, so we received 1,750 questions on notice for the portfolio for these hearings, so we are working through all of those. We've tabled 380, and I'd note that most of those questions were received after the due date for submissions of questions, so we are working through them all as quickly as we can.
None were received after the due date from me.
I understand, Senator, but it's in the context of a short window between last hearing and this hearing.
Sure.
And a very large volume of questions overall.
So I just wondered, do you give any priority to the Shadow Minister for answering questions, or is it just free-for-all, just do it in the order you feel like?
So well, it's not whatever we feel like. We take all the questions from senators equally seriously. They're questions on notice from estimates. They are allocated to different areas of the department to do responses, or to the different portfolio agencies, and they are all responded to as quickly as they can, and they all go through a clearance process to ensure that the responses that you receive address the question and are accurate.
Yep. So unfortunately, we sort of the problem now is that I'm going to have to re-ask a whole heap of questions that I wouldn't have to re-ask. The other thing is, Mr Comley, in response to a usual practice that I and many other senators do, we write to you to ask for certain information to be made available prior to these hearings, so that we don't waste your time, so you know what we're after. And you wrote back to me, you wrote back to the chair, of which a copy was provided to me, saying that we, and I assume we, you mean the department, consider it more effective to focus our efforts on preparing for a comprehensive discussion during the hearing itself. I just wondered, what the basis was that you thought that your views were more important than responding to a request from a Senate Standing Committee to provide information.
Well, thanks, Senator. We received the request from you. I replied to the committee on the basis that we certainly take our obligations to this committee seriously. If we received a request from the committee, then as a whole we would prioritise that. But in terms of dealing with the quans that are outstanding through the normal process and any other information we've required to provide, we've prioritised those quans rather than an information request from an individual senator, which I won't go into others, but you're not the only individual senator who put forward information requests for this hearing.
Yep. So did you provide the same letter to all senators?
Those that asked for requests, we provided the same response back to the committee chair and copied to that senator.
So how many requests did you receive?
I'd have to check. I think we got 2 requests.
Two. So you got from numerous senators was 2. Yep. So some of the information that I requested, which obviously you've got in my original letter, can you assure me that all of the information that I requested will be available today when I ask for it again?
Well, we have taken into account your request. We're here with the officials to try and answer those questions. Obviously, some of those questions might be information that we either don't have or there are other confidentiality reasons, but we will certainly endeavour to do our best to answer all those questions.
Okay. All right. Well, so are there, is any of the information that I asked available for me?
Well, we're not...
Because the purpose of asking you for that information is to save time and enable us to interrogate the particular information. So I'd just be keen to know whether any of the information, because I've asked about, information in relation to the bulk billing incentive, the practice incentive, support at home, aged care, and outstanding requests in relation to that. I still don't have an answer to a question that was outstanding for a request from the previous estimates in relation to the 70 reviews that the department mentioned its incoming
Senator,
government.
that one
brief.
has been tabled.
Okay, we do have that one. Okay.
So we have prepared to answer the questions. So when you answer the questions, we'll do our best endeavours
Yep.
to answer those questions.
So can I just ask you, is it your intention to, in the future, not provide information before hearings? Or is it just because of the short time frame between this hearing and the last one?
Look, my intention, and I took some soundings around, different committees have different practices on this question. So my intention would be to, if the committee as a whole provided requests for information to the department, we would seek to provide those in advance if it's possible. But generally we would rely on the fact that these hearings are here to provide that information.
Okay, well, we might take this to the floor of the Senate because I think withholding information that's been requested by legitimate members of this committee is and that you made a unilateral decision after the practice of many, many years that all of a sudden you weren't going to provide the information because you decided that's what you were going to do, I don't think is good enough, but obviously it is the case today, so we'll move on. There's recently been media reports in relation to a 5% public service efficiency analysis. So I'm just wondering if you can confirm whether you've received correspondence from either the Department of Finance or the Department of Prime Minister and Cabinet or their necessary officials or ministers concerning the 5% efficiency analysis that has been reported in the media and is also the subject of an order for production of documents which has been refused.
So the Australian Government has asked all portfolios to review existing expenditure and consider what is still aligned with priorities and what could be reprioritised to meet future spending pressures. This is consistent with the usual approach of expecting agencies to identify offsets for new expenditure as required under the budget process operational rules. I understand that questions about this exercise should be directed to PM&C or the Department of Finance.
So in terms of a 5%, I can't quite remember the exact words that you just used for the 5%, what does that amount to in terms of a number, in terms of your budget? Which part of your budget does that apply to?
Senator, we don't typically talk about budget processes, but if you were talking about a prioritisation across the whole portfolio, that refers to both administered and departmental expenses.
So I'm just trying to understand, are you required to look at 5% of the total budget of the Department of Health and Aged Care and Disability, or are you only talking about the departmental funding as opposed to the programs funding?
It's total budget.
Total, but 5% of the total budget.
Well, we've asked for a prioritisation exercise, and I said further questions should be directed across the total.
Okay. Just quickly circling back to the previous question, Ms Balnano, my staff have just advised me that there are still 28 questions outstanding on the website.
I'll check and get a list for you, Senator, because we believe that there are 20. There are only 20.
Okay, well...
They may not all be on the website, but that's not within our remit.
There can be a gap between tabling and publishing. So Ms Balbana is referring to the tabling of the responses, which is when it's with the committee.
We can get copies of those if they're not published, the ones that have been tabled.
Could you do that? That'd be great, thank you. And the other thing is, we're about to go in a couple of minutes, or not a couple of minutes, in a few minutes, into aged care. Is there any information that I requested in relation to aged care in terms of, numbers, packages, beds, etc.? Is that available?
We'll have officers at the table to answer your question, Senator.
Okay. Okay, thank you. So, in terms of this budgetary target that you've received correspondence about, was there a time frame in which that needed to be undertaken?
So first of all, I just want to, I said the questions around this exercise should be directed to PM&C or the Department of Finance, but I don't think it would be correct to use the language of target. I think this is an exercise in thinking where reprioritisation could occur, not necessarily a target.
Reprioritising it, do you have a time frame? I mean, I'm actually interested in the Department of Health, Aged Care and Disability. I'm not interested in the whole of government. Well, I am interested in the whole of government, but particularly I'm asking about this department. So I'd be really interested to know what the quantum is in relation to that reprioritisation and when that is expected to be done by.
So we wouldn't answer questions on quantum in respect, because that's part of the budget matters between us and the centre of government, which are part of the budget process, which is confidential. I can seek to take on notice or see if we can have an answer as to when the information was requested by, because that would be consistent with our standard practice to talk about whether we provide information, not necessarily the information that was provided at that time.
Yeah. It strikes me it will be a very big number for the Department of Health, and transparency about that would be really useful. So can I ask about a series of contracts that the department
Yes.
has entered into? Is that for you, Ms Barnard?
Is it contract numbers, or do you have
Okay, yep, I have the contract numbers. It's CN 4201912. That's PBS, Government Advertising Services.
Yes, that one is me.
Yep. So why was this offered under a limited tender and not a full tender?
The actual advertising services goes through the whole of government arrangements for government communication campaigns. So that's their panel arrangements, including for the actual purchase of advertising services through Universal McCann.
Okay, so there was no...
there are no open tender processes for those.
Okay, thank you. In relation to CN 4202589, prostheses list contract.
That would be outcome 2. Do you want us to try and get that information before then?
Oh, it's fine, we can do that outcome 2. Okay. I just thought it was whole of portfolio.
We can, but the witnesses who know about that contract will be here for outcome 2. We can try and get the information earlier for you if you like.
Yep, sure. No, that's fine.
Do you have any specific questions on it?
I just want more information about it.
More information?
Yep. So if that...
Senator Ruston, can I just interrupt for 1 second? There are media present in the room, so I'll just read from the script. The media requested permission to film, take photos of the proceedings. The committee has agreed to this. I remind the media that this permission may be revoked at any time, and the media must follow the direction of Secretariat staff. If a witness objects to filming, the committee will consider this request. The media also reminded that they're not able to take images of senators or witnesses' documents or of the audience. Media activity will not occur during suspensions or after the adjournment of proceedings. Copy of Resolution 3 concerning the broadcasting of committee proceedings are available from the Secretariat. Thank you.
So contracts CN 4202085, and is that outcome 1 or 2?
I'd have to know what the contract, who it's with, what it's about, Senator.
It is a government advertising services.
So that's us. It's the same as, so we run that through corporate. That's the same arrangement, the whole of government panel arrangements for advertising.
Okay. So what was it for?
We will check and see if we've got that contact number handy.
It just says
no.
public relations.
We can get that for you though. We can find out which campaign it was related to.
Okay, and CN 4201556.
1556.
Yep, which is bulk billing for Australian Public Relations.
So that would be related to the bulk billing campaign.
Okay, so if you could provide us some more detail on what was involved in that particular campaign. CN 4198960 and CN 4196916. These relate to fleet services.
To what, sorry, Senator?
They relate to
fleet
management services. What would that be for?
That would be our vehicles.
Yep. So could you give us some more detail as to what they actually were? I mean, they're...
Yeah, we have a small vehicle fleet in the department.
It must be very small.
It is.
Okay. So that's all that is? Okay.
But I can find out exactly what those contracts were, but that's what it would relate to.
That'd be great. Thank you. And then CN 4191884. It's for, it just says graphic web design. What's that for?
So I can find out what topic it was for, but self-explanatory in terms of it being for web design services.
But what web design?
Yeah, I will find that out for you, Senator.
Yeah. Medicare website?
I'm pretty sure we did that one in-house.
Okay. So CN 4198180 says Macquarie Dictionary subscription.
I will check, but it's not one I'm familiar with.
$28,000 for a dictionary subscription. CN 4198175 says for a campaign evaluation. What campaign was evaluated?
Yep.
CN 4198170 says it's for Specialist Creative Agency Government Advertising Services.
So that would be part of the, I can find out what campaign, but that would be part of the actual the ad development, the creative agency work.
For what?
I can find that out for you. Which ones?
So, all right. Well, if what time frame do you think you'd be able to provide that information to me, Ms. Bowen?
So we should be able to do that this morning.
Thank you. All right. That's all I've got for whole of government at this stage. Chair.
Thank you. I think Senator Ormond-Payne just wanted to check that she was in the right section to ask some questions.
Yes.
So, Senator Ormond-Payne.
And actually, the more that I look at it, I think I know what you're going to tell me. But I've got questions about preventative hospitalisations and the interrelationship with aged care. Should I be asking about those now in outcome 3 or in outcome 1 or outcome 3 and 1?
I have genuine sympathy for you in terms of which outcome that would be in. I wonder whether you might ask the question and we can work out whether, because it could be cross-portfolio because of the link into those things.
Yes, that's kind of what I'm thinking potentially.
So maybe go ahead and then we'll see whether it needs to be redirected.
All right. Yep. Thanks very much, Mr. Comley. I've noticed there's been a number of reports recently about significant numbers of people who are in long-term hospitalisations due to aged care rationing. So we know that we've got older people causing bed block in hospitals. And my first question, I guess, is does the department know how many people are currently in hospital who are not there because of their health needs, but because they can't actually be moved into either support at home or residential aged care?
Yeah, I'll ask Ms Stewart to comment in a second. And the only caveat I'd put on is we would not definitively know, and the reason we don't definitively know is there is no national definition of what is a delayed discharge older person. There is currently a Commonwealth State process being worked through Health Ministers' meeting and then through Health Chief Executives to try and identify a uniform and common definition of what a person in that circumstance is. And so at the moment, states and territories do collect information on that, but they don't use a common framework or definition for determining what those numbers are. Okay. So we have an indication and we work very closely with states and territories, but we wouldn't put hand on heart and say that we have a clearly understood definition of that as to who fits that category.
Is there a ballpark figure that's come from the states and territories? I mean, I know there's been a lot of media coverage where we've got state and territory ministers, you know, giving us numbers of people that they say are in hospital because of aged care rationing.
Go ahead.
Sonia Stewart, Deputy Secretary of Ageing and Aged Care. So in terms of a ballpark figure, for the reasons that the Secretary has stated, we don't collect a figure at that level because there is inconsistencies in how state and territories define delayed discharge of older people.
Yep. Okay. Does the department do you have an understanding of what the total cost this year is associated with people in long-term hospitalisation due to people not being able to be moved out of hospital?
Yes. As a flow-on from the definitional issue, we don't have a figure because we don't have the definition in terms of we don't have a common definition, so we don't have an agreed to number and the way that is quantified. Okay.
South Australian Health Minister Chris Picton has put the national cost on his estimate at $1 billion. Is he in the ballpark?
I couldn't confirm that. I will say, though, I think it's important to note that there are clinical decisions that get made around discharge, and that older people, as you would appreciate, Senator, like any other person and citizen, are entitled to good quality health care. So I think that's important to say, and also that not every older person who is discharged from hospital goes into a residential aged care facility. A lot of them return to their homes, or if they're already in a residence, they return there.
All right, but we do know, does the department and the government accept that there are high numbers of older people right now who are not sick, who are in hospital and can't be moved from hospital because there is not adequate either? I'm not saying they're all going into residential aged care, but they either can't get a bed in residential aged care or they can't get support at home. Does the department accept that that is currently the case?
We would accept that there are people at the moment across Australia, older people, who are waiting for a placement in a residential aged care facility.
And support at home?
I wouldn't accept that as a broad proposition as much as I would with the residential aged care, because if they are assessed as needing urgent and priority care, that happens in a relatively shorter period of time.
Okay. Look, I think it's fair to say that it's a massive issue. We've recently seen health ministers nationally vocally commenting on this government's lack of action on the growing number of people in long-term hospitalisations due to the government's chronic underfunding of essential aged care, disability and social care. If I quote the South Australian Health Minister Chris Picton, he recently said, and I quote, "These people are effectively homeless, living in a hospital bed. Many of these patients are stuck like this for months, some even years. It's a national tragedy." Another ACT Labor colleague, Health Minister Rachel Stephen-Smith, said, I quote, "The number of older people in hospital waiting for placement in residential aged care homes is impeding the ongoing viability of public hospitals to provide acute care to those in need. We urge the Australian Government to take immediate action to resolve this aged care bottleneck and restore capacity to our hospitals." And I guess this is a question to the Minister. Minister, how do you respond to your own Labor colleagues raising concerns about the viability of the public hospital system due to the continued rationing of aged care for older people?
Thanks for the question, Senator. I would say that irrespective of the political persuasion of any state or territory government, our government is deeply invested in the health of all Australians. And I know that Minister Mark Butler is working through the negotiations with the department in regards to each state and territory health minister.
Minister, in the words of those health ministers, they themselves have said this has been dragging on for months. Why is the federal government not taking their concerns seriously and resolving this issue? Bed block is being caused by people who can't get aged care. That is a federal government responsibility.
Well, I refer to the previous response in that the minister does take this seriously, Senator Orman-Payne. He is negotiating with the states and he will come to a conclusion in terms of that relationship with the state and territory ministers.
Are you able to tell me when the next health ministers' meeting is scheduled for to progress those negotiations?
Sure, I'll refer to the department.
The next health ministers' meeting is on the 12th of December.
Mm-hmm. Okay. How am I going for time, Chair? Okay. We've recently seen the Growth and Drivers of Australian Public Hospital Costs and Prices report published.
My understanding is that this report was commissioned by state and territory treasurers to inform negotiations on the next National Health Reform Agreement with the Commonwealth Government. That report specifically highlights the rising costs associated with public hospitals due to services that should be funded by the Commonwealth. The report notes that, and I quote, "There is an absence of any coordinated policy between primary health, acute care, aged care, disability and social care. This failure of policy disproportionately impacts individuals and the public hospital system, resulting in suboptimal care being delivered at a premium cost to the system." The second recommendation of the report is to, I quote, "ensure national accountability for interface services and stranded patients," stating that the Commonwealth must take greater responsibility for system interface failures, including funding and delivery of aged care. Has the department been made aware of this report?
So the department has been provided this report. I do wish to highlight the point you made. This was a report commissioned by the states and territories, and in fact, if you read the foreword to that report, it talks about the report having been reviewed and endorsed by the states and territories. So I'm not saying everything in that report, is inaccurate, but I am saying that it is a report in the context of a Commonwealth state negotiation that is ongoing. There's a range of things in that report that do take a particular perspective without taking other factors into account.
Okay, so has the department considered the recommendations of that report?
We have considered the recommendations of the report, and they're part of our input to the process of advising government and negotiating with states and territories.
Okay, has the department carried out any modelling on increasing the availability of packages and the impact of this on preventative hospitalisations or long-term hospital stays?
I will ask Ms Stewart to comment on that, or Ms Street. I think I'm not sure we'd have done, and look, I'm not hedging, it's just many people mean different things by modelling. Obviously we do analysis of what the implications of having more or less packages are, but there's a lot of factors that would feed into whether you have a package or whether someone ends up in hospital or ends up in residential aged care.
Well, I guess then has any analysis been done in that regard? Because it would seem to me a false economy that if we're putting off giving people early preventative in-home care that we know is leading to unnecessary hospitalisations.
So, Senator, was the question about have we done distinct modelling on... do you mind repeating the question?
Yeah. So has the department carried out any modelling or analysis on increasing the availability of support in the home and the impact that this would have on preventative hospitalisations or long-term hospital stays?
We haven't done that specific modelling.
Okay. In relation to the report commissioned by the states, this is a question I would imagine for the Minister, and noting Mr Comley's response in relation to that report. Again, yes, accepting that this is a report commissioned by those state and territory treasurers, many of whom are your Labor colleagues. Can you tell me whether the government will give any weight to those recommendations, or is it just going to be framed as the states did it, therefore we're not taking into account the things that report has actually found?
Perhaps I could answer. I know you've directed the question to the Minister, but I have actually read the report. So we have read it, we've analysed it, we've taken it into account. It's feeding into the conversation with the states and territories at the moment.
Okay. Minister, will you be discussing the findings of the report during the next meeting of Health Ministers on the 12th of December?
Well, I just refer to Mr Comley's response in that Senator Allman-Payne, that this is obviously a consideration for the Minister. It's quite serious, the relationship that we have with each state and territory minister, and there is no doubt this plus others will be part of the conversations.
Okay. Given that we have we already know that the wait lists for aged care, both for people waiting for an assessment as well as people who have been assessed and are waiting for a package, given that we know that those numbers are far higher than the number of packages that have been slated to be released in this 12-month period. I think it's 83,000 are being released, is that correct? We already know that's over 100,000 people who need that care. Given that the state report recommends greater funding for aged care services to help reduce the number of people in hospital unnecessarily or blocking beds, how much more evidence does the government need to show that rationing of aged care is not working? And that's a question for you, Minister.
Well, Senator Allman-Payne, as I've said already, that we recognise the significance of having these relationships with the state and territory governments. The Minister is meeting with them in just over a week's time to work through these issues. I mean, we have been very aware of the needs for our elderly across Australia. That's why we introduced the reforms that we did recently in the Australian Parliament on aged care. We know that there's a way to go, and this is why the Minister will continue those discussions with the state and territory ministers.
On the 17th of November, the news reported that Prime Minister Anthony Albanese had written to states telling them to rein in their hospital spending. If the Commonwealth Government provided greater access to aged care, would that not decrease hospital spending?
Senator, I'm not commenting on that particular letter because as far as I'm aware that letter is not in the public domain and there are many aspects to that letter, but it is true that if you expanded in some cases aged care expenditure, it's also true if you expanded primary care expenditure, you would have an impact on hospital expenditure. The system is linked together. But the government, as a matter of policy, has to then make decisions as to what the total quantum of funding is and exactly where it's allocated. So there is not a limitless amount of money that the government can provide to health in general. And it's probably true across the whole portfolio that you could point to areas of additional investment that many people would like in systems, and the government has to make those clear prioritisation decisions on the way through.
Maybe the government could show some courage and ask those 1 in 3 big corporations who aren't paying tax to actually pay some so that we could afford to fund those services. I guess question for the Minister, would you say in the context of the report showing that 8 to 10% of public hospital bed days are now occupied by patients awaiting discharge to another setting, would you say that the PM's comments are in fact misplaced blame for issues that the federal government needs to fix?
I will say to you, Senator, that we do recognise the importance of the aged care sector and our elderly across Australia, and that's why the Minister is preparing for the negotiations that are going to take place on the 12th of December.
Okay. Now, along with the Coalition, we did try to put some questions in on notice ahead of the hearings, but were told that we could get that information today. Could I maybe ask for some information on notice? Could we have the average number of people in long-term hospital stays waiting for an assessment? Could those averages be broken down by state and territory and per month over the last 2 years? Could we also please have the average number of people in long-term hospital stays waiting for a package to be available? And could those averages be broken down by state and territory per month over the last 2 years? And finally, has the department carried out any modelling or analysis on the transition from home care packages to support at home and the impact of that on preventative hospitalisations for long-term hospital stays? And I'm happy to take those 3 on notice. Thank you.
Thank you, Senator Allman-Payne. It seems that we are now at the end of the whole of portfolio corporate matters, and I hope that we continue this trend of being ahead, folks. And I thank my colleagues at the desk for their efficiency. And we will take a short suspension while we wait to welcome our next witnesses in Outcome 3, Ageing and Aged Care. Call officers from the Department of Health and Ageing and Disability in relation to outcome 3, ageing and aged care, and invite questions. I'll go to Senator Ruston first.
Thank you very much. In my letter of request, Mr Comley, I asked for a series of information in relation to, and I'll read it out so that the officials who might have this information can make it available. A breakdown by state and territory and by federal electorate of supported home packages, formerly home care packages, released since the 1st of November 2025, including the number of packages released at each support level, the number of packages assigned and allocated to an individual at each support level, the number of individuals who were approved for a package at one support level but allocated a package at a lower support level, broken down by approved level and allocated level, and the average waiting time between approval and allocation for these individuals, and also a breakdown by state and territory and by federal electorate of the 20,000 additional supported home packages, they were actually home care packages, referred to in the Minister's press release, 20,000 fast-track home care packages delivered of the 30th of October 2025, including the number of packages released at each support level, the number of packages assigned, allocated to an individual at each support level before the 1st of November 2025, the number of individuals who were approved for a package at one support level but allocated a package at a lower support level, broken down by approved level and allocated level, and the average waiting time between approval and allocation for these individuals. So is that information available?
So, Greg Pugh, First Assistant Secretary of the Access and Home Support Division. Senator, we do have most of the data that you've requested, but not all of it, so I'll go through the data that we have.
No, I don't want you to go through it. I want you to table it.
Table it? Okay.
Would that be possible to do that now?
I have it electronically, so I can try and arrange.
Mr Comley, you didn't think that it was a useful exercise to actually have the printed data that I asked for. Mr Pugh's just admitted that he has much of the data that I asked for, but we don't actually have it in any physical form. Did you not think that that would be a useful thing to happen today?
Well, we stand ready to answer questions, and so we don't necessarily typically table lots of data through the course of a hearing. So
no,
Mr.
because
Pugh's
usually
got the data.
you table it before the hearing, but you've chosen not to do it this time. So could I ask, in the interests of not wasting Mr Pugh's time and everybody else's time going through that amount of data, if he could provide as soon as possible that information in a physical form, so that we were able to interrogate that data. So if you could just email it to the Secretariat so they could print it, that would be great. Thank you.
I've got it.
So we will look at what form it's in that can be provided, because it may be embedded in Mr Pugh's briefing notes, which is a separate thing. But we will see what we can provide in writing while this hearing is on.
Mr Comley, can I just put on the record, I find this manifestly unhelpful. You were well aware that we wanted this information. This is very serious information. It goes potentially to broken promises by the government in terms of commitments, and you do not have that information in a format that would allow me to interrogate it. So I find that quite disrespectful to this committee. So could I ask how many people are on or were on the MPS as at the 31st of October 2025?
As at the 31st of October 2025, there were 107,281 people on the National Priority System.
How many people who have been assessed for residential care were waiting for a place on the 31st of October 2025?
I don't know if I have that individual piece of data, Senator. I can try and get it and wrap it up into the bit that we'll try and table as part of the session.
Okay. How many people who have been assessed for a CHSP were not receiving services on the 31st of October 2025?
Yeah, we'll get that one as well, Senator.
How many people who have been allocated a home care package or a supported home package have not received that package on the 31st of October 2025?
So in relation to the home care packages, a person is allocated them and then they have 56 days to take it up. So all of the packages that were rolled out as part of the home care packages program will have been allocated at that date, and then it's really dependent on the time frame in which that person has elected to take up their package with the provider.
Okay, so how
I don't have a specific number.
Okay, so could you find me the number of people who have been allocated a package but haven't received it?
I can take that on notice, yes, Senator.
Okay. What is the number of people waiting for an assessment to receive aged care services as of the 31st of October?
Sorry, bear with me while I find it in my notes, Senator. I do have the answer, but I don't have it directly in front of me. I might just pass that one over briefly until I can grab it, and then I'll provide it as part of this hearing. Sorry, Senator.
How many people are not receiving the level of care they've been assessed as needing, i.e. those who have a lower level of care service provided than have been assessed as needing?
Yeah, I think it's the same answer as the one from about 3 questions ago, so we'll find that one and put it as part of this hearing too.
I'm sorry?
Is that the same question around people who've been approved at a certain level and receiving a lower level of service?
No. One of them was in relation to people who have been allocated a package but haven't received it. This is about the number of people who have been assessed as needing a package, have received some care, but not the care at the level that they have been assessed as needing. They're not the same question. I have not asked that question before.
Okay, we'll grab that one and put it as part of the rest of the pack, Senator.
So do you have any idea of the total number of older Australians today who are waiting for the care level that they have, that they need?
I believe that is wrapped up in the same set of questions, and we will provide that as part of this hearing as well.
Okay, well, what sort of timeframe do you think you'd be able to provide me with that data? I mean, it's
I'll try and do it as part of this hearing.
Part
today.
of this hearing.
Yep.
Is it possible to have it by lunchtime?
Yes, quite possibly. Yep.
Okay, well, I will ask you just before lunch.
Yep.
In 2024-25, my EFO, there was a budget budgeted for 83,000 new home care packages in 25-26. What was the total expenditure budgeted for these packages as part of the MyEFO process?
I don't have that figure directly in front of me, but I can again find that and provide that to you as part of this hearing.
What was the planned monthly or quarterly release schedule for the packages, those 83,000 packages over the 25-26 year?
Well, we've got the release schedule, so we've got the 20,000 that rolled out in the deferral period. We've got the 20,000 additional.
In MyEFO. We now have subsequently changed that, and I'll get to those questions in a minute. In 24-25, there was a budget allocation in MyEFO. I'm keen to understand what the planned monthly or quarterly release schedule was that applied to the decision and the budgeting from 24-25 MyEFO.
I don't have that detail in front of me, Senator.
So how am I supposed to question you around budget? These are a budgetary estimates process, and I have no capacity to question you at all about matters as they relate to the budget because you can't give me any information about the budget.
I'll take those questions and get them back to you as part of this hearing, if I can, Senator.
Okay, so we've been told by providers that supported home packages allocated since October some are only being funded at 60% of their approved classification level, or referred to as interim packages. So can you confirm what percentage of new supported home approvals since October have been allocated as interim funding rather than full funding?
93%.
93% have been interim.
Yes, Senator.
Okay, and that was at the 60% of full package?
yes.
Okay. What's the average time or duration that an individual will be on an interim package?
10 weeks.
So that's a standard amount. So basically, you're on it for 10 weeks and then you move straight off there. It's an automatic 10 weeks.
Yeah, and a couple of caveats. One, if you're assessed as urgent or end of life or restorative care, you go straight to full funding. And if you're in an urgent classification, you receive your full funding within a month.
So the maximum time period that somebody could be on an interim funding package before receiving full funding is 10 weeks?
No, that's the average.
Okay, so could you give me the scope?
Between 3 and 17 weeks.
3 and 17 weeks. So basically just under a month or up to 3 or 4 months. Okay, so the department's website says when an individual transitions from an interim to a full funding, the amount is not backdated. Is that correct?
Correct.
So their notional account is only accredited for 60% of what their total annual funding would be for the period they're on an interim package.
Correct.
So if you were on a level 4 package, which was about $32,000 a year, and you had a quarter where you only received 60% of that, is it reasonable to suggest that you would only be receiving in an annual period 90% of your funding?
Sorry, what was the last part of the question? Sorry.
You'd only receive in an annual, on an annual basis, 90% of the funding that you're actually supposed to be allocated?
You will receive 60% of your total allocation for the average period of time, and then you will move to the full funding allocation. How that works out on an annualised basis will just depend on how long you are on the interim funding level for.
So if an individual is not receiving 100% of their package, and I'm quite good at maths, and that would mean on that basis they've got 60% for 1 quarter and 100% for 3 quarters, they would be receiving 90% of 100%. So if an individuals are not receiving 100%, in the 24-25 financial year, how much has been saved by the government on the basis of issuing or allocating interim packages rather than full packages?
Nothing. $0.
So what did you originally budget for?
So that comes back to the question that I've taken on notice around what the package allocation and funding itself is. The reason that we've moved interim funding is so that we can manage within the appropriation. And, we've had unprecedented levels of demand for places under the Support at Home program. Interim funding has always been a feature of the program, and it's a way of making sure that we can get more people into packages and waiting less period of time for some level of care. But there's been no savings attached to that.
So you were, at the direction of the Senate, earlier, a couple of months ago, there was a direction of the Senate as part of the passing of the Aged Care Amendment Bill that required that 83,000 home care packages were released in the 25-26 year, and they were to be released in a particular way. And you haven't released those packages, you've released interim packages as opposed to the full packages. Do you think that there was any expectation in the passing of that legislation, and I know Senator Allman-Payne was part of that as well, that they were only going to be issuing interim packages, that 60% of the total packages that were assessed as being needed?
So the slight distinction, Senator, is that the 20,000 packages that were brought forward into the deferral period that were released as home care packages, they were fully funded. The remaining 83 additional thousand packages, some will be released as full, some will be released as interim, and that's a way of managing our appropriation.
So now my question is, have you looked at the legislation and the amendments that were passed in the amendment bill, and do you believe that the requirement for the packages to be released, that you are within the letter of the law in terms of those amendments.
Yeah, I can get
to have been releasing interim packages.
So, yes, and I can get the exact wording of the legislation and the ministerial determination. The legislation allows for places to be released on an interim basis, and there are a number of stipulations that the minister must provide advice around when that has happened and the time frame for which you would expect to move from interim to full, and that's happened through our communications. It happens as part of the letter of advice to participants as well.
But I'm asking,
so am I comfortable if it's in the legislation? Yes.
In terms of the amendment that was moved in relation to releasing of the packages?
Yes.
So I know I can't ask you for a matter of opinion, so maybe, Minister, you can answer this. So when the Senate made the determination that 83,000 packages were to be released in the 25-26 year, and that was voted on in the Parliament, do you think that the average Australian would have thought that they were only going to be released at 60% of their full value?
Sure. Thanks for the question, Senator Ruston. I can certainly say to the committee that we are complying with the Act in terms of amendments to the Act, and certainly in terms of our focus on the 83,000 new places this financial year.
I'm not sure that answered my question, but...
well, I do believe it. I'll beg to differ.
Okay.
Senator Ruston, just curious whether we can, maybe if that's the block of questions you've got for now, and I can come back to you. I know that you've got lots and we're here all day.
Yeah, no, I was just going to say, I've just got a couple of questions on the trigger mechanism for this, and then we can...
And then I'll shift the call to Senator Olmapane.
So I'm just interested to understand what the specific circumstances is a decision made to allocate interim packages rather than full funding. The department website states this occurs when demand exceeds available funding. We had no new packages released from the 1st of July to pretty much to the 30th of September, so you had the full savings of that. 93% of the packages that have subsequently been released have been released as interim packages at 60%. So what is the methodology or the threshold used to determine when demand exceeds available funding?
Thank you for your question, and I might ask if Mr Day is here or someone who can talk about the new legislation prescribes new roles in terms of the system governor and in terms of decisions that get made, noting that this is a demand-driven application. So I don't know if...
Can you unpack that for me, Ms Stewart? A demand-driven application. Explain that to me.
Well, it's based on needs, so we understand that there's needs for these services. We understand that with the demand, and we understand how much we have, and then in terms of the management of different categories of packages and support that people need. Are you able to talk about this?
But just to be clear, it's not demand-driven in the same way that MBS
or
PBS is, that has an uncapped appropriation. There's a capped appropriation which then requires optimisation of the packages. I think that was what you were
so I think,
to.
Ms Stewart, that was quite misleading in relation to demand. This is far from a demand-driven system. This is a rationed system of care that the government has actively sought to even strangulate further the rationing of care.
So, if you
No, sorry,
yeah, I didn't mean to speak over you. Sorry, I do have just the wording around the legislative basis for the trigger, if that would be helpful for your previous question.
Yep, please.
All right, so the Aged Care Act requires the Minister to prescribe a method for determining how many places will be allocated in support at home for a financial year. Doesn't require the Minister to prescribe how many, but rather the method for determining the number of places that will be available to be allocated. No restrictions on the nature of the method. The legislation requires the following factors to be included in the prescribed method, though, and that includes forecast demand and cost for support at home, the fixed appropriation for the support at home program in the given financial year, the target average wait times for individuals entering support at home at each level of the support at home priority system, and then it specifies that the system governor will administer the system and make decisions around place allocation with respect to the determination made by the Minister. And so the legislation, the rules and the determination are all publicly available.
Okay, so it's very difficult for me to prosecute any of this until you give me the information in relation to the MyEFO budget allocation. So can I ask, how many people were receiving a home care package on the 30th of June who were not eligible for grandfathering arrangements?
Yeah, we'll take that on notice and put it as part of the rest of the pack, Senator.
So if you could add to this, how many people received a home care package or a new home care package or a reallocated home care package between the 1st of July and the 30th of September who were not grandfathered? And how many home care recipients were not grandfathered on the 31st of October?
Yes.
Yep. And can you, in the Minister's, I think as you might have been the Treasurer, in making the announcement for the delay of the Act from the 1st of July to the 1st of November, said that there was a $900 million cost of the delay in the Act. Could you break down what that $900 million was in terms of the costs?
That will be announced as part of MyEFO, Senator. So I can't do that as part of this hearing, but I can do it when the MyEFO is announced at whatever point that it's announced.
Okay. So back to the trigger mechanism in relation to interim packages. Who makes the determination? Is it the department or is it a ministerial decision?
So the Minister makes the determination, and that's done in consultation with the Minister for Finance around the method by which it's applied.
Yeah. Was this determination in relation to interim packages made before October?
It was made before the 1st of November, yeah.
Okay. Would you have a date of this determination for me, Mr. Pugh?
Not on me, but I can find that. I feel like it's pretty easy to find, sir.
Okay. So I'm just interested to understand the date so we can understand why there was no mention of interim packages at the time. So in 24-25, how many packages were released on an interim basis?
In 24-25, as in the 30th of June 2025, that financial year, none. Yeah.
But just to be clear, that was because it's a home care package system, not a supported home system. Under a home care package system, it was not uncommon for people to be assessed at a particular home care package, but allocated at a lower level until such funding was available or number of those packages. So it's a different mechanism of doing something where people get a stepped entry into the aged care system, but it's a similar concept to was under supported home with interim packages.
Okay, so could you provide me with, I think I asked you the question earlier on that. So can I just say, if you could make some attempt to provide me with that information that I've asked for with some speed, because every single question I want to ask you is based on that information. I have repeatedly asked for this information. I asked for the information to be made available before I got here today, and it would be very, very useful in order for me to be able to interrogate what has happened in relation to the budgetary elements of this program if I had that information. Thank you, Chair.
Thank you, Senator Ruston. Senator Owen-Payne.
Thanks very much, Chair. And a number of my questions to start off with also relate to wait times, and like Senator Ruston, this was information that we asked for in advance, so I'm hoping that you'll be able to answer those questions now. My first question is, what is the current average wait time for an assessment?
Just waiting for my colleague, Ms Blackwood, to come to the table.
And I will make the observation that we ask this question at every estimates. So I would have thought it would be really quick and easy to give us an answer to that question.
Yep, so the overall median wait time for an aged care needs assessment in October was 30 days.
Okay. So is that up from previously, you said it was 27?
Up from 24 days in September.
Okay. All right. OPAN's 2023 to 24 Presenting Issues report found that wait times for ACAT assessments were a key issue. In their report on page 40, they said, and I quote, "These issues appeared even more severe in this financial year with excessive wait times for clinical assessments. By the end of the fourth quarter in 2024-25, OPAN network members across Australia reported that some older people were waiting up to 10 weeks for initial contact from an assessment service, only to be then told that they needed to wait a further 2 to 9 months for an assessment or reassessment." In addition to being highlighted by OPAN, this is something that we are regularly hearing from older people. And so given that the department has told us previously that the average wait is 24 days, now 30 days, what we're really trying to understand is why what we're hearing on the ground and from organisations like OPAN seems not to align with that average wait time. So I just want to dig into it a bit more to see if we can find out where the discrepancies are. Are you able to tell me the current average wait time for an assessment, excluding assessments that occur within a hospital setting? So if we take out all those people who are in hospital getting an expedited assessment, what is the average wait time for everyone else?
Uh, 53.3 days.
Thank you.
Can I just ask a question? Sorry, Senator, you mentioned the OPAN report. Did you say the 23-24 year?
Sorry, it was the 2024-25 report.
Yeah, okay.
Yep. Are you able to tell me the average amount of time to receive an appointment for an assessment? So we know that we've got the time it takes to get an assessment from the time that you're given an appointment, but we're also hearing now that people are being asked to wait weeks, maybe even a couple of months before they can even get an appointment. So are you tracking the average time to get an appointment?
We haven't got that one available, Senator.
Is it something that I could get on notice?
You can get it on notice, yes.
All right, yep. So, and could that average be broken down, please, per month since 1 July 2025?
Yes.
What is the average amount of time that it's taken for a person to undergo the assessment process? So that is from the assessment meeting to the assessment outcome.
Okay.
Rachel Blackwood, Assistant Secretary, Access and Home Support Division. So if you're talking about I might just outline the 5 steps in the assessment process to give a little bit of context to this answer. So a referral is issued, then an assessment organisation accepts the referral. The referral is then triaged by a clinically trained staff member in an assessment organisation. Then the assessment is booked and an appropriate assessor, either clinical or non-clinical, is assigned. Then an assessor conducts the assessment and then an assessment delegate approves the support plan. So for that part of the process that you just asked about, the period between the actual assessment meeting and the approval of the support plan, which is the conclusion of the process, the average amount of time for that stage of the process in October was 2.1 days.
Okay. And does that include people who are getting assessments in hospital?
I don't believe it does. I will confirm that with my team.
Okay, thank you. How many people are currently waiting on an appointment for an assessment?
We've got the number of referrals on hand as at the end of October, which my system has just frozen, was 113,150. That's total number of referrals on hand for aged care needs assessment. So that will include people who are waiting at each of those stages of the process before the support plan is completed.
Okay. And can you tell me then how many people are in the process of receiving an assessment? So that's how many people, I guess, have had their assessment conducted and are waiting on approval?
That will be the average in that 2.1 day period. So I don't have that number to hand, but I can take that on notice.
If you could take that on notice, and if you could break it down, please, monthly since 1 July 2025.
Yep.
I think Senator Ruston may have asked this question, but I'll just double check. So the number of people currently awaiting a support at home package.
I don't know if I've got that in front of me either. I can grab that as part of the broader request.
Okay, well, if I could please get the number of people who are currently waiting on a support at home package and the number of people who are currently waiting on residential aged care, and the average amount of time to receive each of those separate things, and if I could have the monthly breakdown since 1 July.
Yeah, we can take those on notice.
Also, do you have the monthly cost of the previous assessment system before we moved to the single assessment system versus the monthly cost of the single assessment system what am I trying to say? So I'm interested to understand what was the cost per assessment under the old system and now the cost per assessment under the single assessment system?
We can take that on notice. The difference will be that under the old system you'll have costs for ACATs, costs for the RASs, and then also for the ANAC assessment workforce, and obviously we've rolled those three together under the single assessment workforce. So we can provide, but there'll be the usual caveats around why it's not necessarily like for like.
Yeah, if you could provide that on notice, that would be great. And have you done any forward modelling or analysis of the single assessment system and what you expect ongoing costs to be?
Yeah, we took that on notice.
Okay. How am I going for time, Chair?
You've got plenty of time. We're here all day, Senator Green.
Okay. All right.
At your disposal.
Okay. Well, in that case, I want to interrogate the no worse off principle, because we're certainly hearing from people who were expecting that they would be no worse off that they believe they are. So I guess my starting question is, are there any limitations currently in place on increases to provider fees?
Senator Susan Traynor, Acting First Assistant Secretary, Residential Care Division. It's, I think, really important to make clear what the no worse off principle does and does not capture. And what it does capture is a person's out-of-pocket costs in terms of dollars. And it's calibrated to ensure that they do not personally pay more than they were before, and the government fills that balance. It does not cover other things around service prices.
Okay. Was that made clear to older people before the transition to the new system? Because they're certainly very shocked.
It was certainly the case that it was always described in all of our communications products that it was about how much the person can expect to pay towards their aged care costs.
Okay. Was there anything in there that explicitly told people that the amount of services that they could obtain under their package may decrease due to an increase in prices? Was that made clear to people?
We'll have to go back and recheck all of our communications. There's been no shortage of communications around the application of the no worse off principle into the support at home program. So some of the products that I'm thinking of there was the support at home program manual. The no worse off principle was featured in there for a long period of time. All of the consumer user fact sheets. We've got our Your Aged Care weekly newsletters. We've had a range of webinars, consumer forums and the like. So the application of the no worse off principle will have been very well communicated to the general public.
Well, could I give you some feedback based on the old people we're talking to? And we had a town hall on Monday night with 88 older people. I've had reference groups that I've been talking to, and to a T, they are saying it was not made clear to them that if they were on a grandfathered home care package, that the amount of services that they can now obtain under that package would be significantly decreased because prices have gone up. That is the feedback coming from the people who are receiving those services. I think you've answered my earlier question. In terms of price increases, so we've got a case study shared with us. Actually, I might come back to that. these are the questions that we tried to put on notice, so I might see if I can get an answer to them today. Can you provide the methodology or the modelling used to determine how those transitioning from the home care program to the supported home program would be no worse off?
I can't provide modelling today, Senator. What I can do is describe the three mechanisms by which we do ensure that a person is no worse off in terms of the dollars that they pay out of pocket. The first of these is that co-contribution rates were set to keep the amount that those translated into dollars for each package level below what a person of that equivalent means would have paid as an income-tested care fee, which is how we've arrived at the 0% for full-rate pensioners through to 25% for self-funded retirees in the no worse off principle. It's also why there's no difference between the independence and everyday living categories for people in the no worse off principle group. The second way that we provide for this no worse off principle is that for those who were approved for a package or in a package on or before 12 September 2024 continue to be only assessed based on their income. So we know that under the new system, we look at people's income and assets for support at home. For that group, we continue to not consider their assets to deliver that. And then the third way is in the case that a person has a very unusual package mix, that means that they have an unusually high number of services that do attract a co-contribution. Services Australia has in their system a dollar cap at the fortnightly amount that person would have paid income-tested care fee before the transition. And if they do, in a rare circumstance, reach the stage where they go above what that would have been, that cap comes into play and the government feels what the gap between what their co-contribution rate and services used indicate they should pay and what they actually pay.
Okay. When you were going through the methodology and the modelling looking at this no worse off principle, was it considered at any point the impact on an individual's relative purchasing power if prices for services went up?
No, because as I've said before, Senator, the no worse off principle was about their out-of-pocket costs and it didn't consider service prices or purchasing power.
Okay, but it wasn't made clear to people that their service level may drop if the prices went up.
I disagree with that, Senator. Per my previous statement, there was no shortage of communications that was out there. I take your point that there are case studies of people that were saying that they were not aware, and that's unfortunate. But we can provide.
It's more than unfortunate.
It's
Older
very
people
unfortunate.
relied on your community.
Can we just let the official finish
Sorry,
his
my apologies.
answer to his question, if possible? Thank you.
And
Thank you, Senator.
unfortunate was probably a very poor choice of words, so my apologies. But I will just reiterate that there was no shortage of communications, and if we're hearing feedback around people that weren't aware, we would like to be aware of that and work out the best way that we can address it.
Yeah, and I guess the issue now is that it's after the fact, and these are people who thought they could rely on a certain service level. I might see if I can get one of the case studies that I've been provided by a provider to table for you in the next round, where it's very clear that people's service levels have decreased by 10 hours a week and they can't afford anything more. Okay, thank you.
Thank you, Senator Orr-Payne. Senator Stewart. Cool.
Thank you, Chair. Just got some questions. I suppose in a similar line to my colleagues, and I do welcome the interest in the experience of older Australians and what the government is doing here. And apologies, feel free to tell me if you've already responded to some of these questions. I might have been distracted when you answered some of these questions for Senator Ruston or Senator Orr-Payne. Can you tell me how many individuals were on the national priority system as at October 31?
I can, Senator. So that was one of the ones that we asked answered earlier, but at the 31st of October 2025, there were 107,281 people on the national priority system.
Thank you. Apologies for the double up. And how many older people were approved for home care as of the 31st of October 2025?
Sorry, can you repeat that?
How many older people were approved for home care as at the 31st of October 2025?
Well, in October 2025, there were 21,237 home care package approvals. I think we can grab the total number for you at that point as well. There were also, at that point, 328,014 people who had been allocated a home care package, which is the highest number ever, and we had 299,016 people receiving care at that time.
And this kind of goes to your comment. What is the greatest number of approvals in a quarter, and what quarter was that?
We're just grabbing that number for you. It will have been the most recent quarter. We've just got to get the actual figure for you, Senator.
Mm-hmm.
Just, while we're finding that one.
Yep. On the 3rd of September, Minister Butler and Minister Ray announced an additional 20,000 home care packages would be released prior to the 31st of October this year. How many of these packages were released by this date?
As at 31 October 2025, all 20,000 of those additional home care packages had been released.
Great, 100% strike rate. And I'm asking the question, Senator Ruston. You've had your time. And what happens post 1 November? How many packages will be rolled out between the 1st of November 2025 and the 30th of June 2026?
So we'll have an additional 20,000 places rolled out under the Support at Home program by the 31st of December 2025, and that's from the commencement date of 1 November 2025. Sorry to answer that question backwards. And then we'll have an additional 43,000 places released between the 1st of January 2026 and the 30th of June 2026. So that'll be an additional 63,000 total places released under the Support at Home program in this financial year.
Thank you. Can you tell me more about the new Support at Home program and specifically how it will support older people to stay in their home and in the community for longer? We know this is something that older Australians want for themselves and for their families.
Yeah, I mean, there are plenty of benefits to the Support at Home program. I know that we get a lot of questions around its implementation and some of the issues that people may or may not be seeing arise. But, you know, at its core, Support at Home is going to improve access to services, it's going to improve access to equipment and home modifications, and its overarching goal is to help older people remain healthy, active and socially connected in their community. So we're moving away from a home care packages program that's got 4 levels of care into something that's got 8 ongoing classifications. We've got higher budgetary amounts ranging between $11,000 and $78,000. We've got new short-term pathways, including the restorative care, the end-of-life pathway, and also the assistive technology and home modifications scheme. And we've also got quarterly ongoing budgets with the ability to carry over $1,000 or 10% of the budget to meet changing needs. So look, there are plenty of benefits to the Support at Home program. We're about a month and a couple of days in, and we're really looking forward to the program maturing over time.
We know that more and more Australians are living longer, and my sense, and be good to hear a bit more about it from you, is that we want to make sure that quality of life as people get older is really there, and it'd be good to get from you kind of how it is this goes to kind of ensuring that quality of life for older Australians.
Yeah, sure. So in addition to the 8 classification levels where people can get increasing levels of funding to match their care needs, probably the other point to really look at in relation to the benefits of the Support at Home program are those additional pathways. So if you look at the restorative care pathway, for example, you can receive up to 16 weeks of allied health and or nursing services, and that helps you to regain or maintain function. And this is double what was previously available under the short-term restorative care program. Each of those restorative care episodes provides funding of up to $6,000, and you can actually get a second round of funding during an episode if you're eligible to do so. The restorative care pathway, you also get 20,000 places, and that's up from 20,000 available per year. and that includes 13,333 available for the first year of the program, and you get that funding for restorative care immediately after you receive an assessment outcome that says you're eligible for it, and that really helps with those early intervention and restorative care principles. I can go into further detail on the end-of-life program pathway as well, because that's also a really important feature. That helps our older people who have been diagnosed with 3 months or less to live. Those clients can receive $25,000 per person over a 12-week period, and that can be expanded to 16 weeks as well if there is funding remaining available. And again, you can receive that funding immediately under the end-of-life pathway. There is no wait list for that. So really the sum total of the program plus the additional pathways is really our primary method of ensuring that people can meet their preferences to age and in some cases pass in place and reduce any of the pressure on our residential aged care system.
It sounds like it was something that was done with real thought and care for the experience of older Australians. And the other thing that I was thinking about as you were responding to that, to my question, was I suppose the load that it might take off lots of Australian women who often have the caring responsibility for their older parents. The changes that we've made to aged care, I would hope ease some of that load for lots of women
absolutely
around the country. And as somebody who's a family therapist, the other thing that I think about is the pressure and comfort that might be there for families. Do you have any sense of, I suppose, the kind of stress that might get alleviated for families when their parents or older Australians are able to access these supports?
Yeah, absolutely. So, I mean, at its base, we're seeing an additional 63,000 places put into the program in the first year of its operation, and that's increasing to an additional 300,000 over the first 10 years of the program. So obviously with more of those places opening up, people can access the care and support and services that they need. There is a very real alleviation of the pressure that it's placed on family members, and as you say, in particular women who are, statistically far more likely to take on those caring roles within the family. So that does it will be doing a very good job in terms of alleviating some of those pressures.
I imagine so. It sounds like it's kind of... I'm going to ask some questions in a second about older First Nations Australians, but sounds like I can kind of frame up kind of broadly those responses as kind of being about more care, more people, more quickly for older Australians. So I'm really pleased to hear those things. I'm just checking in with the chair, make sure I'm not getting the eye here. I'm aware that some First Nation stakeholders, such as VATCHA in my home state, the Victorian Aboriginal Community Controlled Health Organisation, and the Healing Foundation, have called for the government to take a different approach to co-contributions and means testing for Aboriginal and Torres Strait Islander people, and for payments under state and territory redress schemes to be treated the same as other kinds of redress payments, especially for members of stolen generations. So I know that you'd be aware of the concerns that have been raised, as am I. More of a statement than anything else, but I am keen to understand from you how it is that aged care is being made more accessible for First Nations people.
Thank you, Senator. Emily Harper, First Assistant Secretary of the Market and Workforce Division. I might pass to my colleague, Ms Tadipater, who has just...
Sorry, I can't see your tag because it's behind some glasses on the table.
Sorry.
Thank you.
So just to be really clear on the question, just some of the initiatives to better support older First Nations Australians?
Yeah, so it's about how we're making it more accessible.
Yeah, no worries.
Yeah, okay. Chanel Taddypatter, the Assistant Secretary for First Nations Aged Care Branch in the Market Workforce Division. The government continues to invest in culturally safe aged care for First Nations people, particularly in First Nations specific initiatives. So we do have the National Aboriginal Torres Strait Islander Flexible Aged Care Program, which is about working with the changing needs of Aboriginal and Torres Strait Islander people and their communities, both in a resi and home care aged care setting. We also look at increasing and prioritising Aboriginal and community-controlled organisations and First Nations providers in aged care, trying to ensure that we're working with the sector and building their capacity in aged care service delivery. We also are building the culturally safe aged care workforce as well through initiatives like our Indigenous Employment Initiative and our Elder Care Support Program. And we're also introducing First Nations assessment organisations as part of the single assessment system and ensuring that there are also, targeted culturally safe training resources available alongside working to strengthen the aged care quality standards under the new aged care reforms. We're also looking at working to improve the system accountability through the Aboriginal and Torres Strait Islander aged care framework that is outlining a number of actions that the department is working with critical partners up until 2035 to improve the aged care experience for older Aboriginal and Torres Strait Islander people.
Thank you. I feel like there was a lot in that.
Yes.
But I'm curious about how the government's investment in aged care workforce reforms, so things like higher wages, training pathways, and remote workforce initiatives have improved access to care for First Nations elders, particularly in regional and remote communities.
Yes, Senator. So some of those initiatives that I mentioned earlier, the Indigenous Employment Initiative and the Elder Care Support Program. So the Indigenous Employment Initiative is focused on, increasing Aboriginal and Torres Strait Islander people working in aged care. It's focused on entry-level roles, but with a focus of training up and building capacity in aged care service delivery. As well as the Elder Care Support Program, which is focused on, ensuring that elders have workforce that can support them through, how they navigate the aged care system. So it's about working with them to understand what aged care services are, and then working through the actual processes alongside providers and assessors, and navigating that system through, from end to end in terms of, what their aged care service experience, how they want it, in terms of what's available as well. So that's really premised in...
Is it the equivalent of like, when, my mother-in-law might be having an issue with her phone, she can ask me to help, but instead you can go to somebody in the aged care system to help you navigate the system.
Yes, it's they do prioritise face-to-face support and understanding.
So does my mother-in-law. Yeah.
Yes.
Senator Stewart, I might just in terms of your preamble to the question and your mention of VARCHO and some of the issues they've raised, I've certainly heard those as well, and so has the Minister, and so we'll certainly be working closely over the next couple of months on that.
I've got no doubt, Minister. Thank you very much. I'm getting the eye from the Chair here, so I'll leave my questions there. I do have a lot more that I'd want to ask.
Excellent, thank you. Well, keeping in with the theme of running ahead, we will now go to a short break for the next 15 minutes until 11:15. Thank you.
We will recommence in outcome 3, ageing and aged care, and I will hand the call to Senator Pocock.
Can you pick up on some of the questioning around the no worse off principle that Senators Ruston and Ormond-Payne were asking about earlier? And rather than getting sort of bogged down in the details and the numbers, I wanted to share a few stories, as I've been inundated with emails from people who've been transferred from home care to supported home and who feel that they are now paying substantially more for their care each month. Anne is in her 80s. She recently lost her husband, now lives alone. She has pulmonary fibrosis. She requires oxygen therapy. And she was managing reasonably well on her level 3 package. But now under supported home, fees have apparently gone through the roof and she's had to reduce her morning personal care. She now only has enough budget to afford help having a shower in the morning. She doesn't have help anymore to do the laundry or to prepare meals. And when friends visited her, they noted that she didn't have any clean clothes. She's had to reduce her house cleaning. She now receives no help in the evenings, and transport now costs her $105 an hour, up from $85 an hour. Is Anne no worse off under supported home?
I might start by, and thank you for sharing that case study. I might start with a couple of comments and then hand it over to my colleagues. If the person that's spoken to you about their circumstances feels that the prices that they are being charged are not reasonable, because the new legislation does require that prices are transparent and that prices are reasonable. If they feel that these prices are not reasonable, that there's avenues available for them to bring this to our attention, particularly through complaints that they can make available in terms of that. In terms of the no worse off principle, as my colleague Ms Traynor spoke about, it was very clear about the out-of-pocket and the focus on that. But I might hand over to Ms Traynor if she's got anything further to say.
That's right, and noting that I can't talk about any individual case, when we do talk about the no worse off principle under supported home, it really is about that, the number or the dollars that the person is paying out of their own pocket compared to the amount that the government is paying towards that person's aged care costs. So rather than about service prices.
Sure. Well, maybe let's try a different one. This is from an 84-year-old man who lives at home. His family sent this in. He has dementia. He receives a level 4 home care package and has been managing well on that with the support of his wife and daughter. From November 1 under supported home, they've had to completely change his mix of services. They report that in-home respite has gone up from $75 an hour to $109 an hour. Group care has gone up from a flat rate of $132 to $447 per hour. And they've now basically had to cancel any transport and most of his care hours. Is this gentleman no worse off under supported home?
I think I have the same answer around the no worse off principle. Potentially, I think the Aged Care Quality and Safety Commission, who have responsibility for assessing complaints about prices and whether they are reasonable, may be able to make observations about what they look for. That may be helpful to you, Senator, but I think in terms of the no worse off principle, it is about that out-of-pocket costs.
Okay. I've got another story from a woman whose husband...
Talk about your pricing issue and unreasonable prices.
Okay. I might just read this one. This relates to a woman whose husband is living with a rare neurodegenerative disorder, and apparently they've been getting by okay with the level 4 home care package. It was able to provide access to showers, cleaning, the occasional meal, physiotherapy, and really importantly, some respite care. But now under supported home, they've been told that their out-of-pocket expenses for each service will roughly double. And they've had to reduce all of their services just to make sure that they can cover morning showers. Respite care, which we know is so critical for people in these sorts of circumstances, is apparently out of the equation altogether. And this woman will probably go into residential care, though there are likely no beds in the area that will take her. So I'm just wondering if this woman is also no worse off under the supported home program.
So thank you, Senator. As Ms Traynor had said, she's gone through the no worse off principle. I can see that the Aged Care Quality and Safety Commission has come to the table, but I might just make a couple of comments. So first and foremost, providers set their own prices in the home care packages, in the support at home program. That's a continuation of what happened under the home care packages program. We are monitoring to make sure that those prices are reasonable and justifiable, and the providers do hold evidence to show how those prices have been met. If there is evidence that those prices are unreasonable, they do get referred to the Commission for further monitoring and investigation. So the no worse off principle, I think, has been explained. We do have pricing and transparency protections in place, and I will just see if the Commissioner wants to add anything around the regulatory and compliance actions.
Can I just ask though, you've talked about the no worse off principle relating to out-of-pocket expenses. This woman's been told that her out-of-pocket expenses for each service will roughly double. So, like, how are these people no worse off? Like, you can go to technicalities all you like, but in the spirit of the Act, it was very clear to older Australians, if you have an existing home care package from November 1, you will be no worse off. And it shouldn't be on older Australians to have some sort of degree in reading legislation to be able to decipher what that actually means. Surely that was the promise. And
sorry, I'll let you
these people aren't not worse off. They're clearly worse off.
So I think it's really important to note that, again, not knowing the circumstances of this particular case, that the eligibility for that no worse off principle is based on whether a person had been was receiving a home care package or had been approved for a home care package on or before the 12th of September 2024. So there will be instances where a person's co-contributions and out-of-pocket expenses have increased if they were not already approved for a home care package on or before that 12 September 2024 date.
But these people were all on home care and were transitioned. So why did we tell these people that they'd be no worse off, where clearly they're worse off? People are having to drop services, they're not getting the care that they used to get. In some circumstances, their out-of-pocket costs have gone up. But there was a firm commitment from government that you'll be no worse off. That was one of the key selling points with this legislation to everyone, to older Australians, to their families, to consumer advocacy groups.
So Ms Traynor's been through the application of the no worse off principle. I mentioned before the break around how we had been communicating exactly what the no worse off principle meant, and I've mentioned the various documentations, including the Support at Home program, including media releases, including consumer forums, webinars, you name it. There has been no shortage of outreach that we have tried to give to people to make sure they understand the application of the no worse off principle. So I take your point, Senator. However, I would say that there has been zero lack of transparency from government, from the department, around how that no worse off principle would apply. I can also appreciate that you and other senators are hearing different stories, and we want to take those on board and work out, the best way to go forward with them. But to reiterate the point, the no worse off principle, it's not something that's been hidden away. It has been something that has been clearly communicated previously.
But the minister, when selling these reforms, said if you're on home care, you won't pay $1 more under supported home. Clearly, older Australians are paying more for the same number of services. So what are we going to do about this? What is the department, minister, what's the government going to do about this? This is clearly not in line with what you promised older Australians.
Yeah, thank you, Senator Pocock. I am aware through the Minister's office that you raised these constituent matters with him. I'm advised that the Minister has asked the Department to look into the concerns raised and is very mindful, obviously, of the privacy of those involved, so I won't go into that here. But I would note that the matters raised all relate in some form to the no worse off principle. As you're aware, protections are in place for older people under the new system, and people already in residential aged care when the new laws took effect will remain under the old means testing arrangements unless they choose to opt into the new system. The no worse off principle also applies to supported home, meaning anyone in the system before the 12th of September 2024 will have their contributions grandfathered. But to go to your question about how people are feeling now, we are mindful that it's 4 weeks since the legislation came into effect. We know that there are matters out there that we need to address, and we will do that.
How much have fees gone up across the country on average since the 1st of November for personal care? Do you have those figures?
I can take those on notice, but we have had independent analysis done by Stuart Brown and other organisations that did forecast that there would be an indicative price increase of around 30% across the sector. But, Senator, that is because there is a complete change in the pricing.
Sorry, can I just intervene? The side commentary that's running is not helpful for me, one, to hear the witness's response. If it is not your call and your question, can I ask that the response be heard in silence? It is not helpful that the voices are carrying from behind the desk. Thank you. Continue.
That's directed at me and I will stop.
Well, it was directed at a few people, so you know, it is a courtesy as part of our behaviour code to listen in silence when there is somebody else talking, and the witness did have the call.
So 30% is what you were expecting services to go up?
I think Mr Pugh was about to explain it's not a like-for-like comparison because of what's included in the prices.
Yeah. So under support at home, we have a completely different pricing construct where we've got the entire cost of delivering the service built into the unit price, whereas under HCP we had different arrangements. You had participant charge for the service, you had charge separately for package management, staff travel. That was where we saw some of the previous reforms made around capping the administration fees because, you know, anything above 20%, you know, that was literally eating into the care that the older person was receiving. So what we try to do with the amended pricing construct is build in every element into that one price. And yes, there have been price increases as a result.
And so when you bundle up the existing pricing structure into one catch-all price, how much was it expected to go up in the transition? Well, you didn't do that.
30% was around the anticipated amount. That's what's been modelled.
So, but that's bundling. You said there was a different price structure, but you bundle all that, and there's 30% extra, taking into account the sort of one price that includes everything. You know what I'm saying?
Yep.
That's still a huge jump. How many?
I think, Senator Pocock, I think what Mr Pugh said is that admin charges in the previous pricing structure are up to 20%. So that's included in the 30%, so the net increase is significantly lower. He also pointed out that transport was also dealt with separately.
Yeah, sure.
So, and maybe it is a point where Ms Heffron-Webb might want to talk about what we are doing to look at this question of reasonable prices, because we wouldn't expect that prices would increase as a result of this change in like-for-like terms by anywhere near those sorts of numbers.
Thank you. I've got a couple of questions to do with that, but Secretary, the thing I was asking was if you take into account all of those charges, you know, the 20% admin fee, surely you did the work saying, okay, these are all the different charges. If we bundle them up into a total price, what will be the increase when we go to a catch-all pricing structure? And that was my question to Mr Pugh.
Senator Pocock. Jasmine Snow, Access and Home Support Division. Perhaps I can give an overview of how the prices worked under home care packages and break it down slightly more, and then we can talk about...
I'm just interested, I'm running up on time, I'm just interested in the increase.
So as Mr Pugh has outlined, there was some external modelling that suggested 30%.
Okay. And what's been done with some of the sort of skyrocketing costs?
The other thing...
How many providers have been investigated or have been challenged on their pricing. Go to the example I gave earlier, group care going from a flat rate of $132 to $447 per hour. Maybe Ms. Heffron-Webb, what's...
Liz Heffron-Webb, Aged Care Quality and Safety Commissioner. So, Senator, we obviously will take referrals from the department, also through individual complaints and any other ways that we receive information about prices that appear to be unreasonable on the face of it. What we will be doing is asking the provider to show us how they've arrived at that price, what's the cost structure, and we'll be comparing it with prices of providers who are similar in a similar geographic region, potentially have a similar cost structure, and where we determine that we think the prices is unreasonable, we will require that they address that. As you know, it's very early days.
Sure.
We have not had a big surge in direct complaints. I understand you've had people coming to you, encourage them to come to us, because once we have that information we can go to the provider. But at this stage it's very early days and not all providers have actually put their prices out publicly yet. So, but we will be investigating any cases we become aware of.
How many referrals have you had to date?
Final question, Senator.
So I'm not aware we've had any referrals from the department as yet. We've had a few referrals come through the complaints line, but a handful. So that's all so far.
Thank you.
If I may, Senator, I might just add very briefly to the Commissioner's answer. I'm Robert Day, First Assistant Secretary of the Quality Assurance Division. In terms of that process of how the department will refer cases to the Commission, we will have a rolling process of program assurance reviews on supported home pricing commencing early in the new year. That will look initially at the outliers of pricing and involve engaging with those providers to ask them to justify for us why the price is the way it is. And if we're not satisfied with that, we'll have a conversation with them, but we'll also be referring those to the Commission for action.
Okay. Thank you, Chair.
Thank you. Senator Ruston.
Thank you very much. I won't ask any more questions on the issue of home care and supported home, in the hope that I might have that information before lunch so we can return to it after the lunch break. Can I just now move to follow on some questions that Senator Allman-Payne asked you this morning around older Australians who are medically fit to be discharged from hospital but that are in hospital. Now, I'm interested to understand why you were unable to answer the questions. I have gone through all the publicly available data, so I'm keen to, if you can verify the figures that I've been able to extrapolate from all of the reporting that has been available, including by government consultants like Mr Stephen Duckett. So is it your understanding that as of August 2025 there were 830 older Australians in beds in New South Wales hospitals?
Trish Garrett, Assistant Secretary, Service Delivery Division. We don't actually have that hospital data, that state and territory data. They don't provide it to us in a consistent manner, nor do they provide it consistently either. So we unfortunately don't have access to that data. The data that we do have access to is from the Report on Government Services, so the ROGs. And as you probably know, the ROGs are somewhat delayed in terms of data. So, for example, the 2025 ROGs have data from 22 to 23. So that's our, I guess, source of data on separations of older people, and that's, for us, that's the source of truth. I can talk to the data, that 22, 23 data in the ROGs.
I don't need that data. What I'm trying to understand here is that there is publicly reported data for every state and territory, of which, according to the data that and I've just done it myself without any resources of a department, there are 2,736 older Australians who are currently or in recent days were in hospital who were medically fit to be discharged if they had been able to get access to either a residential place or the necessary support at home. And there were at least an additional 945 Australians who were in hospital waiting for placement in relation to support from NDIS. So as we sit here today, there's 3,681 on my extrapolation, people that are in hospitals, in the state and territory hospitals, who are taking up beds that they would not otherwise be taking up if the services that were appropriate for their needs were available. I find it quite incredible that week after week we come back to estimates that the federal government or the department doesn't think it has a government's responsibility to understand, firstly, as was, I'm not sure who made the original comment, that there is, I think it might have been you, Mr Comley, that there is no definition. Well, don't you think you should come up with one? And secondly, that you make no attempt whatsoever in order to find out this information, which I've been able to find just by looking at reports and reading media articles that refer to legitimate reports that you could have gone and had a look at yourself. So I'm just keen to understand, why is it that the department thinks it's not its responsibility to understand what 2,736 older Australians who have been assessed as needing care by your agencies, why you don't know who they are, where they are or what they're doing?
Senator, I'm reiterate the answer from this morning, which is, first of all, the Commonwealth Government acknowledges that there is an issue of delayed discharge of older patients and that there's something that needs to be addressed. Secondly, we actually work very intensively with the states and territories. In fact, Ms Garrett and her team works very intensively on often a location-by-location basis to try and facilitate those older patients to transition into care. So we take the issue very seriously, and we're actually working with the states and territories on literally a daily basis on this issue. However, when it comes to endorsing a particular number, the reason of not having, there is not a common definition. The states and territories provide that information on different bases. As I said this morning, we are working intensively with the states and territories on developing a common definition of what is a delayed discharge of an older patient so that we can have that data set. So we take the issue seriously. We're working on it intensively, both at the conceptual and definitional level, but also on the practical level of moving people out as quickly as possible. But we don't endorse any particular number that's put forward from those data sets because they're collected on a different basis in each state and territory.
So I'm interested to understand how the Commonwealth is negotiating with the states and territories in relation to the National Health Reform Agreement. When the states and territories have obviously raised this issue of older Australians and Australians with disability putting immense pressure on their hospital system, how are you negotiating this when you don't even know the quantum of the issue that the states and territories are putting on the table as one of the negotiating items?
So I just, Chair, I did actually think that the NHRA disability negotiations were going to be in cross-portfolio, but I'll answer the question. We're negotiating with them on the whole system, partly by continuing to engage with them with issues such as what is the need, how locally specific it is, and what interventions they think would be most effective in clearing that backlog. That's what we're negotiating.
But you don't have any understanding on the basis of what Ms Garrett's just told us and what you've told us yourself of the quantum of the problem. So, I mean, how do you even know whether this is a legitimate concern by the states and territories and what size that concern is if you are refusing to find out what the quantum of it is? I mean, how long have you been in the process of trying to come up with a definition?
Well, the definition will work, Ms Garrett might comment, but it's been going for quite some time and we've had varying degrees of success in moving that forward. We're keen to resolve the definition. We're working very closely with states and territories to understand the limit, but I come back to my point that I'm not... We couldn't endorse a particular number, but we do understand from all those conversations where we think particular pressure points are around the country.
So do you have any idea of how many people on the national priority system are in occupying hospital beds around the country?
No, we don't.
We don't. Okay. So I'm just keen to understand. I mean, like, as I said, I've got these figures. So in New South Wales, August 2025, 830 older Australians in hospital. I mean, Stephen Duckett's report from this year says there were 782 people in Queensland hospitals, a 40% increase over the last 3 years. In October in South Australia, 377. That's a very recent data. Tasmania, October, 77. Western Australia, 300 from August 2025. In Victoria, their figures are actually really current. They're actually November 2025, 220. ACT, 70 in 2025. And the Northern Territory's lagging a little. Their figures are up till July and they're 80. And that's only older Australians. And all that information is publicly available and verified by sources in the media. So, I mean, we have got a serious issue going on here, but clearly the department is not intending to actually verify those, or can you verify that that would be your understanding of a likely quantum?
We wouldn't endorse that. We would say we have to establish that definition. And I think, again, I assume you're quoting in mentioning Stephen Duckett, the report that Senator Almond Payne referenced earlier, which was commissioned by the states and territories. I'm sure that is the data reported to that report by the states and territories, but we don't have a common definition and we don't have a way of verifying that.
Okay. It does seem rather like a head in the sand. So I'm really keen to understand about what you think is the department's sort of government's responsibility in relation to tracking where people are who have come under the care in the sense of the Commonwealth after having been assessed or referred for assessment for aged care support, that you have no mechanism by which to track it. You have no clear definition of who's responsible. I mean, so this seems to me like a failure of federal policy and a failure of the department to actually be on top of an issue that has been publicly described for quite some time. It has escalated massively in the last 2 years since the hospital funding agreement or the NHRA has been negotiated, and we're sitting here less than 7 months before we're supposed to have a new hospital agreement in place, and you have no idea and will not even confirm your understanding of the quantum of the problem in relation to one aspect of hospital funding that is within the direct control of the federal government.
Well, Senator, we've been working very, very intensively with the states and territories on this issue. It has been, I don't think there's a meeting of, for example, health ministers or health chief executives this issue doesn't come up and that we deal with it in a very constructive way. So I just don't accept don't accept the characterisation that we're not taking this seriously and engaging seriously with the states and territories.
So,
but I also just want to add that the characterisation that is made that it is solely a result of Commonwealth policy that this occurs, I don't think is correct. There are a range of decisions made in hospitals on the way through that also determine what happens to the journey of an older patient in a facility, and that differs from jurisdiction to jurisdiction and hospital to hospital. So that's why we're working incredibly intensively with states and territories to understand where we have kind of local solutions that can facilitate that, which includes quite active brokering at times of where is there an individual patient who needs to find a placement and how can we liaise with facilities around that place where they need to go into residential aged care. As Ms Stewart said earlier, not all older patients who are medically fit for discharge either need to or want to go into residential aged care facilities. Some of them want to have a different pathway, and that's part of our brokering arrangements we do on a constant basis.
So do you accept the fact that a responsibility for aged care, whether that be residential care, home care, CHSP, rests with the federal government?
It's a federal government responsibility for aged care. I'm saying the interface between other systems and aged care is not as straightforward as there's a black and white distinction, because we have to manage both systems, which both has a Commonwealth and a state dimension to it.
So talk to me about the state dimension in terms of care for the people that you're talking about.
Well, Senator, there is an issue, for example, when an older patient comes into the hospital, about at what point is the process of thinking through the discharge starting from almost the day that they arrive within the hospital. What are their actions to take with it? How do they actually navigate that care journey with a point towards the departure? That is something that is done within hospitals, and also has an impact on how the transition out of the hospital will occur, including things like how comprehensive are the discharge summaries that will be put together, because one of the feedback we get from aged care facilities is that sometimes the lack of comprehensive discharge summaries makes it difficult for an aged care facility to be able to assess what type of care that aged person may require to be in a position to take a judgment about receiving them. I mean, Ms Garrett deals with this on a daily basis. She may want to add something.
Sure. Just to add to what Mr Comley was saying, we are absolutely, despite not having confidence in a quantum, we are absolutely working from both the national level but also on a local level to try to find solutions to address the issue. One of the real things that's happening here is that it is very complex, and that older people, not only as they go into hospital but also exit hospital, it's a much older cohort than in the past, and they have much more comorbidities than previously. And so it's not simply about finding a residential bed for them, it's about finding the right care for them, and of course with the new Aged Care Act, finding the place that they are wanting to go themselves. So the work that we've done over the last number of years in conjunction with the states and territories has been sort of twofold. One is the top-down work, which has been working together on a national strategy and a national work plan. So really working through all of those issues that will make a difference.
Ms Garrett, thank you very much for the information, but given that we are short of time, I'm not necessarily sure you're adding any value to my question, but I appreciate the advice you're giving me. So could I confirm, in 2024, my understanding is IHACPA undertook a report at the government's request on stranded patients. Is that correct?
So, Senator, we have IHACPA coming later in the program. I'm trying to remember at what time they're coming.
I'm sure I can look up the program for when IHACPA, but I'm asking, it was at the government's request, so maybe, Minister, do you have any line of sight over this report the government requested IHACPA to undertake in relation to stranded patients?
Senator, I can take your question on notice.
Okay, so I'd be very interested to understand whether that's obviously correct, and if that's the case, what the status of the report is. So premiers have stated that many of the excess hospital costs are being driven by aged care residents stuck in public hospitals due to a lack of aged care places or appropriately Commonwealth funded places. I'm sort of interested, Minister, do you dispute that proposition by the states and territories, chief ministers and premiers?
In terms, just repeat the question, please, Senator.
The premiers, state and territory premiers, have in writing stated that many of the excess hospital costs are being driven up by aged care residents stuck in public hospitals due to a lack of aged care places or appropriately Commonwealth funded services. I'm just interested whether you agree or do you dispute the comments made by the premiers.
Well, I'm sure the premiers and chief ministers have their reasons, but as Mr Comley was saying earlier, there are many different elements of patients going into hospital. I mean, if I look at the Northern Territory, for example, you've got elders who are flown in on care flight. from places like Nooka and Arnhem Land, and once they're in there, sometimes they may have to stay in to the hospital. The other areas that we're looking at is Aboriginal hostels and what other ways we can assist. And then we've also got the opportunity for the out-of-home care packages. So we do understand from the Commonwealth level that we do need to look at many alternatives for our elders. And what the states and territories are saying is obviously up to them, but I do know that the Minister is trying to work with them, as we've said earlier, in response to Senator Ormond-Payne.
So let me ask the question another way. Given the Commonwealth's responsibility for aged care, does the government accept that the delays in aged care access that have been driven by the rationing of care are directly inflating state hospital expenditures?
Well, I just refer to my previous answer.
Well, that wasn't your previous answer.
You may not like the answer, but it was my answer.
Well, no, you didn't respond to the question. You gave us some very useful information.
I gave you an answer. You may not like it, Senator Ruston, but that's my answer.
Well, maybe I could ask the department.
Senator Ruston, I'm just checking how much in this block that you'll need. I need to shift the call in a second.
I can go for days.
I know, I'm well aware of that. But out of courtesy, I'm just asking the question.
I
understand that Mr. Pavan is coming up with people.
He is, yes, and I believe that I've just been alerted that he is here in person, so we will ask him to come up in the next round for you. If we can, if you
I'm
just
happy
want
to move on.
Okay, yeah, and we'll get IHAC part. I think Professor Pavan is here in the building, so I'll just give the call to Senator Roberts, and I'll come back to you. Sure, Senator Roberts, you have the call.
Thank you, Chair. Thank you for appearing today. Since the introduction of personalised aged care packages, there's been an abject failure, it seems, of monitoring how funds allocated are actually spent. This is one of the major failings of the administration of the NDIS that may well bankrupt Australia and be responsible for the death of vulnerable Australians. My question's specifically about the case of David and Sandra Smith. Under their package, they're entitled to some assistance in minor property maintenance. Needing some minor trimming of half a tree and a few branches of another on their property, that was not even completed. They found that $3,000 had been taken out of their package and given to the contractor without discussion between the Smiths and the service administrator of the package. Having raised the issue as a complaint, the Smiths have been ignored, and because of the depleted funds, the Smiths had to cancel some medical appointments that they could no longer afford. This issue is gravely affecting their health at an age when they can ill afford such events. The Aged Care and Quality Commission closed off their complaint and refused to even discuss it with the Smiths. Refused to even discuss it, and no explanation was given. To me, this seems like elder abuse by a government agency that is supposed to help older Australians, not abuse them. What is the cover-up, and why was $3,000 paid for next to no work?
I think the Commissioner will provide a response, noting, of course, it's difficult for us to talk about individuals in this forum, but I'll ask Ms Heffron-Webb to make a comment.
Thanks, Senator. So obviously I can't comment on any individual case, and I don't have any knowledge of the case you're talking about. But we receive around 10,000 complaints a year. Each of them is triaged and assessed, and we do provide a comprehensive response to people. I'm not aware of it. We would ever refuse to provide a response, so I'll be very happy to follow up the case you're talking about.
So we can put you in touch with them?
That would be great, yeah, very happy to.
But it does raise issues of accountability and also the level of care and the attitude in the department.
Well, so it sounds like it's an issue of pricing that they're concerned about.
It might actually be fraud as well.
Potentially. And we do receive, I think it's the third most common complaint we receive around home care is on pricing of services. And we do investigate those complaints, and we do follow up to see what's driven the particular pricing. And you weren't here earlier when I said we will compare providers, and if another provider is offering the same service for a lot less, we will ask the provider to explain how they've arrived at that price.
So do you normally get quotes?
We don't get quotes. We ask the provider how they've come up with their quote.
So you don't insist on a second quote, but you ask them the source of their quote.
So it's the provider who is managing the package. If there's a price that the consumer feels is excessive, we will investigate how that's come about. So that's our role. And if we suspect there's a fraudulent aspect, we'll obviously refer that through to the department, because they're responsible for fraud and assurance, and we're responsible for compliance with the standards.
Okay, so we'll send the contact details.
Yeah, that'd be great.
And could you check on notice
Yes.
if you've dealt with this, or if aged care has dealt with this, because we'd like to know what happened.
Will do.
This disgrace has badly affected the health of 2 innocent senior citizens who deserve an answer and money put back into their package. Is that what happens when there's found to be something incorrect or wrong or unfair?
So I think the department has responsibility for dealing with fraud and how that is dealt with in terms of the individual's package.
And if there's something wrong specifically, is the money given back to the aged person?
I think there would be a range of possible actions. If it's okay, it might be best if we work with the Commission really closely to have a look at the case, have a look at what's been undertaken to date, and come back to you.
Okay, thank you. But can money, I see the caveat, but if appropriate, can money be put back into their account?
Yes.
Thank you, that's what I wanted. And then there's the case of Mr. Gary Bayliss, who had $14,449 taken from his My Aged Care account to replace some worn-out timber rails from a fence. Again, the Commission failed to take action to remedy the fraud. And now the Minister has announced the concept of co-payments is to be instituted into the aged care packages. That will mean the cancellation of many services needed by package holders because they will become unaffordable. Minister, the proposal is that many services will need to be paid for at $100, at least $100 plus per hour, often more than twice the market labour rate. An aged pensioner cannot afford this. From the absurd to the impossible, this is not care. As I said earlier, it's abuse. Minister, what can you do to fix this?
Yeah. Thank you, Senator Robertson. And thank you for your questions too, and the concerns that you're raising on behalf of your constituents. And clearly there are many stories there that you're hearing that really hit at the heart of how people are feeling in terms of their own care. I will take your questions on notice, if that's okay, and I will get back to you in regards to that particular question.
And also the bigger picture, what can be done,
sure,
please. And Commissioner, could you take on the case of Mr. Gary Bayliss?
Yes, absolutely.
Thank you. We'll be in touch. Thank you, Chair.
Thank you, Senator Roberts. Senator Orman-Payne.
Thanks very much, Chair. I just want to go back to the line of questioning in relation to no worse off, and I did listen to the responses that you gave Senator Pocock as well, so I'm not intending to rehash questions that have already been asked. I guess other than to highlight that certainly the examples that Senator Pocock gave are not isolated and they correlate with the sorts of things that we're hearing. Just a quick clarification in relation to the information provided by Stuart Brown. My reading of that was that the recommendation or estimate was 30 to 38%. Is that correct?
I believe that is correct, Senator. I'll have to go back and triple check, but I think the wording that comes to mind is at least 30%. So, but I'll go back and triple check the exact wording.
Okay, it's just I heard 30% mentioned a couple of times. I just want to clarify it was a range. I've also tabled a document titled Case Study 1 HCP. Do you have that?
Not in front of me, sorry.
Does the Secretariat have those? Yep. Just in relation to that, I guess to preface, this has actually come from an aged care service provider. It's a small provider, one that only has one residential aged care facility. They also provide Commonwealth Home Support, home care packages, and now support at home.
Sorry, Senator Orman-Payne, to interject. I just want to check that they've been circulated to officials to give them an opportunity, rather than you giving the context. They've had an opportunity to read them before you pose any questions. So I'm just checking that. I know that you have provided them for tabling prior to this question, so I just want to make sure the officials have a copy. Yep, they do, and have
they don't?
No, they don't.
Chair, can I suggest that we've got, I fear, a sense of reasonable amount of time on aged care left. Would it be possible for us to take that case study, have a look at it, and maybe come back and I assume you'll have another block? Is that?
Yes, I've got other questions I can ask in the interim while that's
maybe in the interest of them being able to provide a sufficient answer. I think it's just courtesy for them to be able to have a look at your.
And to be honest, the answer isn't predicated on you understanding that particular case study. It's really for your information, because one of the things I've heard today is that you're interested in finding out what's going on.
I think the precedence is that any questions that are posed, regardless, if there are documents that have been tabled, officials would need to at least have some time to look at them and understand what that line of questioning would be. So, yeah, if you possibly can ask your other questions, we can go back to that.
Okay. Okay, so one of the things that we are hearing, which is kind of in line with this no worse off principle and prices increasing, is that we are hearing that people are rejecting services. So this particular provider that I've spoken to in Brisbane, and this is not the case study, this is just another example, a gentleman who is a full pensioner, lives in hostel accommodation, and was currently receiving 5 days a week assistance with showering and getting dressed. Now, given the price rises, they have basically rejected that service and said they can no longer afford it. Is the department keeping track of people who have applied for home care packages but who've actually started turning them down now that the new rules are in place because they can't afford the co-contributions?
So we will, Senator, and the answer, there's probably a bit more context around it. It comes to one of the questions that Senator Ruston provided in advance in her letter, just around what the take-up rates have been under the Support at Home program and under the HCP program before it. A person gets assessed, they get their letter of offer, they get allocated a package. It's then on them, because, you know, choice and control, they get to elect a provider to take up that package with, and they've got a minimum of 56 days by which to do that. And with the agreement, they can actually have up to 112 days if they need an extension, something's happened, they've gone to hospital, they've gone on holiday, whatever the case may be, to actually take that up. So what we are doing is we are absolutely keeping track of take-up rates, allocation rates, take-up rates, all those sorts of things, consistent with what we did under the home care packages program. I guess we're a month and 3 days in, so what we've got so far is a very incomplete picture, and that's due to exactly that, the older person having the choice and control to take up a package when they want. So probably the short answer to your question is yes, but given that we're so early in the program, we do not have a very good data set at the moment.
Yep. I note the use of the words choice and control. I guess the feedback we're getting is that if a service has been priced out of your ability to afford it, then it's actually no choice in having to reject that service. So just to be clear, are you tracking the reasons why people are not taking up packages that are allocated? Is that the intention that you will understand the reasons for that, or are you just tracking straight out numbers of whether they're taken up or not?
We're looking at avenues to collect that data. It's not in the data collection at this point in time.
Okay. Are you collecting data, or do you have data, or do you intend to collect data on how many people who were in the system prior to November 1 who are actually dropping the number of services that they're getting since the changes?
So we can do a service take-up and utilisation sort of comparison, and we have started to do some initial work on that. Again, I guess there are some services that are similar, there are some that are different, and there are also different pricing constructs that we've been through previously. So again, short answer, yes, But when we get when we get to the point of actually being able to compare prior and future, there will be the usual caveats apply around what we're measuring.
And this is likely to be a survey because obviously we didn't have that level of granularity under the home care packages program, so we can't do that direct comparison.
Okay. I understand that the indicative fees were based on consultations that happened during February 2025. Is that correct?
That was the indicative prices?
Yes.
Yes, that's right.
It's now November, so I guess my question is, do you think that modelling is accurate? Is it the case that prices have gone up the amount that you predicted, or does that need to be revised?
I think we'll have much better data in the coming months. Obviously, providers could start claiming from the 1st of December, so that will be a really key comparison for us to look at the indicative prices that they provided to the department in February and then what's actually happened once the program has gone live.
And probably just to supplement that as well, sorry, Senator, providers are required to upload their pricing information onto the My Aged Care website, so we've got that data source as well, and we'll be looking at how we can incorporate that into our quarterly reports onto the Support at Home program, which is consistent with what we did under HCP.
Yep. Has any modelling or analysis been done or intended to be done to understand the relationship between, I was going to say potential price increases, but I guess we're up to actual price increases in service provider fees and the number of services that someone will be able to access?
Yeah, I mean, we can do that analysis. Yeah, it is the intention to do that, yes.
Okay.
Yep.
Do you have a time frame for that?
So we have a legislative requirement to do some work in relation to like aged care wait times, and there's a whole bunch of specific metrics that we need to track and do some analysis under. The reporting time frame for that is the 28th of April, and so we would ideally be wrapping all of our reporting and analytics around that sort of time frame. We should have a good initial data set by that stage, because we'll be about 4 months into the program. 5 months, sorry.
Okay. I believe that you have had circulated those case studies. As I said, this is from a small provider in Queensland, provides services to people from the CALD community. A lot of the work that they do involves translating documents in addition to providing care. The questions that I have for you, not specific to that, but I'd really like you to take that away, because we've indicated to those providers that we will pass on their concerns. Providers have told us that under the previous Act, providers could charge for care in intervals, but now they have to do it in full-hour blocks per service, even where they provide multiple services at once, and there's a minimum 1 hour per service. Is that right?
No, providers will be able to claim in 15-minute blocks, so
Okay.
they can do part hour.
All right, so this might be an instance where information hasn't flowed in as well as it should have.
Excuse me, Senator, can I ask a question? Sorry.
Yeah.
Just in relation to this case study, so more than happy to take it away, and probably just to echo the Commissioner's comments from before, like more than happy if you want to put them in touch with us and we can work through what they're hearing and what they're seeing and how the implementation's working for them on the ground.
Yes, because they've certainly said that they're concerned that they won't be able to provide ongoing services, and as you can see from that first case study, they've noted down the bottom, to stay within budget, the weekly service hours were cut from 14.5 hours to 11.5, and they've reduced their advertised hourly rate to try and still provide that person with services. As it's been relayed to us, one of the reasons that certainly for this provider prices are going up and their budgets aren't reaching as far is because the way package management fees have now been pushed onto the service, each individual service themselves, and therefore if you need more care and more services, you're actually paying considerably more. One of the, if I can just take you to the last page of that case study, at the bottom of that just says key pricing issues and why they have concerns. So they're concerned that it's providing all provider costs into each hour of care, costs that were once spread proportionally through package management fees are hitting those who need the most care the hardest, and vulnerable participants assessed for high-level support are now facing unmet needs. What I'm hearing is it might be helpful if I can put that provider in touch with you to talk through some of those issues.
Yeah, absolutely, that would be much appreciated, and even just to dispel some of the misconceptions around the billable timeframes and those sorts of things might be of help for the provider and for us as well.
Yeah, I had another provider on the town hall on Monday too who also had concerns about information flow between Services Australia and the department and their ability to actually get clear information. They said they were making calls and people didn't seem to be able to answer their questions. Am I better off putting them in touch with you or Services Australia?
No, wrong at all. Put them in touch with us.
Okay.
Yep.
All right, I will follow both of those providers up and get in touch with you. Just something else that came up in the session that I had on Monday night with older people and providers. We've had reports that providers are using software to scrape data from My Aged Care to target older Australians with telemarketing calls and to sell them aged care services. And my question is the department aware of this, or has this been raised with you?
So we have heard of this previously, as in not in the most recent months, and your town hall experience is definitely not the first time that we've heard of it, so probably worthwhile reiterating our position in relation to that. So we collect personal details through My Aged Care. That helps us to organise aged care services. There are very clear terms of use and clear guidance around what we collect, why we collect it, how we keep it safe. We've got a lot of data scraping protections that are applied across all of our My Aged Care websites and portals. And I don't want to deverbal the Commissioner or our colleagues at the Office of the Australian Information Commissioner, but I would think that they would have some pretty strong views in relation to the use of personal data as well. I mean, I can go further into the terms of use and security and responsibilities and the protections that we've currently got. But, you know, the short of it is it's against the terms of and conditions. It's not something that we allow or condone. And again, if there are examples of where this is being used for this purpose, please refer them to us or the Commissioner or the Aged Care Quality and Safety Commission more broadly, not directly to the Commissioner, and we will look into it.
All right, well, I might get them to reach out with you. One of the things that's been relayed to us is older Australians are being, in this particular location too, and it's more than one person, are being targeted by telemarketing right around the time that they're due for assessments. So it's clear that information is being used incorrectly. Okay, I will pass that on. I just have a couple of questions around the independent auditor's report and the annual performance statements.
Yep.
I might work backwards, actually. I'll just prioritise a couple of things. One of the, is the right word? Performance measures, that's the word I'm looking for. One of the performance measures, 3.2C, was older Australians with diverse backgrounds and life experiences, or who live in rural and remote areas, can receive culturally safe and equitable aged care services where they live, measured through access by A, First Nations people, and B, people in rural and remote areas. In that report, data in relation to 3.2C, as I understand it, was unable to be verified by the auditor. However, the target for First Nations people as of 30 June 2024 represented 1.3% of permanent residents accessing care in mainstream residential aged care. Are you able to tell me what the current number for that is?
Sorry, Senator. Emily Harper, First Assistant Secretary, Market and Workforce Division again. Can I just get you to repeat the last part of that question? Yeah,
so as I understand it, data around 3.2C wasn't able to be verified by the auditor. The target for First Nations people and it quotes, as of 30 June 2024, was 1.3% of permanent residents accessing care in mainstream residential aged care. Do you know what that current percentage is?
I am just attempting to find that number at the moment. I'm looking at my colleague, Mr. Power. Do you have that?
Hi, Senator. Travis Power, Assistant Secretary, Market and Workforce Division. The most recent data I've got available at the moment is the number we used in the annual report. We can check to see if we have something else on notice.
Okay. Is there a reason why it wasn't able to be verified?
Yeah, I'm checking with that data, Senator, to get the background on exactly why that couldn't be verified. So we'll take that one on notice as well.
Okay. I'm also keen to understand what's occurring in relation to the view of the called specialised framework applications, and maybe just to relay a concern that's been relayed to us by providers, is that it seems to be very oriented towards services that are directed at one particular called community, whereas services that provide broad-ranged multiculturally safe care are finding it very difficult to engage in that process, and so they're keen to understand where this specialised framework application review is at.
So this is the specialisation verification framework,
Yes.
Senator, that you're
Yes.
referring to. So the framework itself has actually been revised and updated relatively recently.
Yes.
But there is an ongoing review, and through that process we will be engaging with our Diversity Consultative Committee, which is a departmentally appointed committee through that process. So that will be occurring over the next 6 to 12 months.
All right. Well, can I maybe just put on your radar that one of the things that has been raised is if you're a service that provides care for a broad range of multicultural communities, that process doesn't seem to be working very well for them. It seems to be very directed if you're pointing your service at one particular community, and they're concerned that they will lose accreditation in that process.
Thanks, Senator.
I'm just trying to... maybe if I could just put on notice, Mr. Power, I think you're the right person to ask, just in relation to that auditor's report and the performance measures. The other measures that were unable to be verified was 3.1A, older Australians and their representatives have access to reliable and trusted information through My Aged Care as measured through consumer satisfaction. As I understand it, that wasn't able to be verified by the auditor. And the other one is 3.2, older Australians are assessed for service need as measured through assessment timelines, and that was also unable to be verified. So if I could get on notice some background as to why that was the case.
Senator, can I just make one overall observation on that?
Yeah.
We've been working quite intensively, and you've probably seen this in other committees with the ANAO on these performance statements. And there's a real, to be frank, a tension between auditing these like you would audit a financial statement and trying to have measures that are actually meaningful and you don't go back to how many widgets do we produce because you can audit them.
Yes.
So we'll find out the specific reason for that, but I suspect that's the tension between we're trying to have a measure that is actually what the community would care about, but we sometimes struggle to have data sources that back that up. So we're still working. We think we've made a big improvement in the last year in being more meaningful, but we are working on a pretty continual basis with the ANO to make sure we get that balance right. So
I place on the record that this committee has already had a private briefing with the ANAO, which Senator Antic and I were quite alone on that call, and that it was an opportunity for and some engagement in that. So, I think that they're just backing up the Secretary there on that, and I think there was a real keen interest from members of this committee to engage in that also. So I am open to revisiting that in the future if that's something that the committee would like to do.
Yeah, great. Thanks very much, Chair. I actually was at an alternative event at that time, but we did read the transcript, so thank you for that briefing. Just if I can go back to one last question just around the called stuff, because I've just realised that I said I would ask this question. I haven't asked it. The feedback that I've had, as I said, is that the integrated care assessment is found to be inappropriate for called communities. And is there anything happening to address this lack of equity?
So, Senator, there's certainly a great deal of work, again, through our engagement mechanisms and otherwise to improve and uplift the engagement and the appropriateness and encourage, of course, called Australians to engage with the aged care system where and when they need to. Mm-hmm. That work is ongoing. If there are particular examples that you have and are comfortable sharing, we'd be very, very happy to take those on board.
All right. Well, there's some crossover too with some of the other things that I said I would put them in touch with the department, so we might see if we can follow that up.
Wonderful, thank you.
And maybe just to highlight one of the other concerns that has been raised with me too is the particularly for providers of care to called communities, be they multicultural communities or one particular called community, in terms of the work that has to be done, and they've raised with me management fees. Like the example that was used was if you are having a meeting with an interpreter, you actually need to have a pre-meeting with the interpreter, then you have to have the meeting with the client, then you have to have a post-meeting with the interpreter to make sure that things have been done clearly. And similarly with service agreements, for example, as well as having to provide the service agreement to the client, some of those service agreements are having to be translated first. So maybe if I can just provide that feedback as something that needs to be considered for those communities.
We might check that with the Aboriginal Interpreter Service as well.
Yes, I think it's probably happening across First Nations and called. Yep. And thank you for that. And I'll come back to you, obviously, after this about those couple of providers who might get some assistance.
Just checking, Senator Ullman-Payne, I'm just about to shift the call if you're finished in that block. Yep. Okay. Senator Ruston.
Thanks. Just one final question in relation to the bed block issue, and that is the South Australian Government, I understand, opened tenders for new services to take 120 long-stay hospital patients with nowhere to go due to lack of aged care availability, so essentially creating a halfway house for these patients. So I'm just interested, does the Minister consider temporary accommodation of this nature to be appropriate care setting for older Australians waiting for care placement?
I'll pass to Ms Garrett first.
No, I asked the Minister.
Oh, sorry.
Yeah. Senator Ruston, can I just say to the committee that the care of our elders across Australia does really matter to this government. We followed through... No, hear me out. We followed through with the Royal Commission and the issue of neglect for elders across Australia. And we will do everything we can across all portfolios, including mine, in terms of the Aboriginal hostels, to ensure that there are choices for our elders across Australia, be they First Nations people, be they from called communities, be they from city areas or regional and remote. So I really find it quite offensive, your line of questioning, as though we have no interest. You saw through the debate of the aged care bill, in which the Minister has created and enabled the opportunity for more access for elders to have choice. So I reject categorically any sort of assumption by you that there is no care in regards to looking at all different options for our elders.
Well, thank you very much, Minister, but I would contest that this is not...
No, thank you for asking, because I wanted to make that very clear.
That this isn't a matter of choice. There is no choice to these older Australians in South Australia. But could I perhaps then move to residential aged care build? Is that you, Ms Garrett?
No. Sorry, it would be in part. Sorry, build. I thought you said bill. That's what we would just...
Oh. Is there something you want to tell me about a bill?
No.
At the last estimates, I asked you in relation to the number of new beds in 24-25, and you said that it was 802, but you needed to verify that data through your normal processes. I'm just wondering whether you could provide us with the actual... Has that number been verified?
Yes, Senator, it has. It's been released in the report on the operations of the Aged Care Act just early this month.
Yep, and what was that number?
802.
802. So that's 802 new beds. So does that cover, is that the net result or?
Jessica Evans, Market and Workforce Division. Yes, correct. That is the net results between financial years.
Okay. So according to the Boxwell Collier's report, it said the net movement of beds was actually 578, which related to both home openings and closures and bed increases and reductions, and the total figure was 578. So how do you reconcile that against 802?
I'm aware of that report too, Senator, and we've had a look at that. The difference between the data reported through that report and the aged care information that's published by the department comes down to 3 specific facilities. The department's 802 is published at a point in time, so it's the difference between June one financial year and June the following financial year, and there was the net increase in 802 as provided to us by what aged care providers have told us to be the new beds becoming available. We then do a stock take to understand through local networks what has actually come online from the places that were allocated. The difference is 3 particular facilities, one of which didn't have occupants in it, so I understand the publication you're referring to decided to extract that from the 802. Another one, again, was around the number of places that they expected to become available, but they weren't actually open to have people available, but the provider had anticipated that that would be the case, and that's what they'd reported to us, and a similar situation with the last facility. So it is 802 as reported to us by providers. Any changes in that we would see kind of wash through in the following financial year, where they might have been lower than what we otherwise would have anticipated.
So these, I would assume that you'd be reporting on operational beds, but quite clearly that's not the case.
So we report on, yes, the operational, up until 1 November, we were reporting on operational places that were allocated to providers to be used in that financial year.
Okay, so is your 802 operational? By the sounds of what you just said to me, they're not.
At a point in time, it was providers were asked to report on those that were expected to be operational places, and that is what we then report. There have been those 3 discrepancies, which were they were not actually filled with people or kind of open to have people in them. But I understand that number will be reflected through in the, any changes will wash through in the second financial year or the subsequent financial years.
Senator Ruston, if I may just add to Ms Evans' response. I think at the last estimates hearing we also discussed the challenge between, and the opportunity that the new Act presents in terms of providers being somewhat more compliant with updating the government or the Commonwealth with the status of various beds that may be offline or online for various reasons. So we anticipate having, a far clearer picture moving forward as a result of requirements on providers to provide that information more regularly to the department.
We're talking about, 25 to 30% discrepancy in the figures, which is pretty significant. Forecasts that were included in the Aged Care Task Force report suggested that around 10,600 beds per year over the next 10 years will need to be built to keep up with demand. So we have got an absolute abject failure of meeting anywhere near that. I mean, it's sort of looking at around 5% of what is required to be built was built in the last financial year. So I'm interested to understand if the government's failed in its, absolutely catastrophically failed in terms of getting beds built in that financial year, what happens in subsequent financial years in terms of projected bed build and what the government's intending to do to meet its own demand schedule?
Senator, I think I shared this data in the previous hearings that we are working with the industry sources to get a better understanding of beds coming online. What we know is that the majority of services and new builds are privately funded, so are funded outside of the government's capital expenditure program. We know in the 25-26 financial year that there is an expectation of 1,700 beds to come online and a further 4,000 the following financial year, so 26-27. And I would also say that the 10,600 average people that are requiring beds that is reported in our financial reports, we are doing some further modelling on that number to take account of the supported home program to take account of supported home program, which will therefore have an impact on residential needs going forward. So 10,600 is our best current estimate of people that will need residential aged care, but more detailed modelling work is underway, which we expect to have finalised mid next year, which will take account of the supported home uptake and what that will do to demand for residential aged care.
So as we're sitting here today, there was a projection of 10,600 for 24-25, of which you've managed at best 802, or that 802 have come online. You're telling me that sometime next year you'll have some idea about what you're going to do about the shortfall. I mean, every year that this goes by, that people are not putting a shovel in the ground and building new aged care beds. And I'm assuming that when you did supported home, given it was done at the same time the reforms were done in terms of residential aged care, you had some idea before you made decisions around that Act, around what the demand was likely to be. You've published it. So I'm really at a loss to understand why we're sitting here today. We have missed the mark by an absolute country mile. You've just told me that you don't actually know what's going to happen next year. And every year we're slipping back by, close on 10,000 beds a year, and you have no answer for that?
Well, it probably didn't help that there was no investment by your government from 2018 to 19 until we came to government and had to actually backfill and invest in beds, Senator Ruston. If we want to go back to why we're so far behind, let's start there.
Well, Senator McCarthy, you probably need to do your homework a little bit better than that, given that it was $19.1 billion invested in the last 2 years
there was
of
no
the coalition
investment.
government
There was no investment
aged
from you.
care. So don't come in here throwing things around if you don't.
There was no
actually have
investment
the
from you.
figures.
Ladies, can I just interject? I'm very happy for the conversation to happen between ministers and shadow ministers with respect. So would I ask that that we just keep it to a minimum of talking over each other and using acceptable parliamentary language, please.
I just put on the record I didn't speak over Senator McCarthy. I waited for her to finish to correct her. But thank you. I take your ruling, Chair.
Chair, can I add something to your question, Senator? And this question of investability and build rate is something that we've talked about many times in this committee. I think there's no dispute that the current build rate is lower than the projection that's required over a 20-year period. There are two things that are policy matters that fundamentally will change the investability question, or potentially change the investability question. The first is, as you know, the Act commenced on the 1st of November, and that allowed individual residential facilities to retain part of the residential accommodation deposits for 2% per year. That builds over time as residents move into the system, and that significantly changes the economics of new builds. The second thing that was made in the same package was to increase the maximum permissible RAD before the regulator had to approve it, from $550,000 to $750,000, again improving the economics of investing. And the third thing that is currently happening is there is a review of the accommodation payment under residential aged care, The first two measures principally affect non-supported residents. The second one affects supported residents. So there are two in the Act measures and one in the pipeline of a review to look at the adequacy of the accommodation payment, which is a significant thing the government's looking at in terms of the adequacy of the incentives to have builds to close that gap.
Well, I have some questions about where we are, given the time frame that's lapsed since what you referred to in relation to RADs and maximum deposits, etc., etc.
I just think it's quite important context in terms of what's already in place.
It's a very important context because I have a series of questions that show that that's also failed, but obviously I accept that that was the basis and the premise for those changes. So I'm just keen to understand that does the government or the department concede that we are so well short of our ability for new build. We know from the reports that we've seen, whether it be through NACA or this Boxwell Collier's report, that they are predicting that there will be, as of 2027-28, actually a shortfall where there will actually not be beds available. At the moment, we're pushing up against the 100% for residential beds. Their predictions are that post 26, 27, that will actually go into deficit. So does the department concede that we are on a trajectory at the moment of not being able to meet demand? In fact, we will end up with a situation we are not even meeting current demand.
Senator, I would say a couple of things to that. I would say, one, that the work that has been undertaken by Alternative, the Collier's report I believe you're referring to, we will have a better understanding of demand by mid-next year. That will determine the level of beds needed to make that demand. We've seen increased capital expenditure over the last financial year. We're seeing increasing approvals for the first time in a number of years that will drive new bed growth, and the numbers, as we have them reported, are starting to increase. With the reforms that are flowing through that the Secretary just mentioned in terms of RAD retention and increased RAD payments, these kind of combined reforms are expected to drive capital growth and help to meet demand, and where we will have a better number and understanding of that from mid-next year.
So have you upgraded your expectations in relation to build subsequent to the changes to ANAC funding and the change in the weighting of the NWAUs and the 15% pay increase that appears not to have flowed through to providers? So there's been a lot happened since those RAD or since the changes that came in the Aged Care Act in 2024. So have you upgraded your estimations in terms of build on the back of that? Because I can tell you that every single aged care provider that I speak to said that their expectations of November 2024 are no longer their expectations in November 2025.
We are continuing to use the data that is available to us, which is not, it's not kind of a modelling. It's not modelling that is based on assumptions. It's based on what providers have told us.
Okay. So could you, I was just having a look through the questions on notice that you've provided me and know where I could find in there that I asked for a breakdown of the new residential aged care beds that were delivered in 24-25, the 802 or the 578, whichever number you're looking at. I asked you to specify how many of those were funded through ACAP. Did you provide that in response? I couldn't find it.
Yeah, we can take that through with you now.
Yep, sure.
So my colleague, Ms Milford, can go into the detail if you had follow-up questions. But of the 802, the first thing I'd say is none of these were funded through the current ACAP program. However, there was the previous program, capital expenditure program, which was the Rural, Regional and Other Special Needs Building Fund
How many
program.
were funded by government?
31 in the 24-25 financial year.
Okay. How much ACAP funding was released in 24-25?
Released funding was the question?
Yeah, how much ACAP funding was released in 24-25?
So the actual amounts was 78.4 million, Senator, but essentially there's 165 million per year minimum available for ACAP as it's an ongoing program.
Yes.
But as you'd be aware, Senator, sometimes we move that up and down if we get additional funding. So
Sure.
At the moment, for example, just to give you an idea, it is higher, above 400 million. So for this year, so the budget for this 2025-26 at the moment is approximately 450 million. So as you'll see across kind of the forwards, it'll be a minimum of 165. And then it varies as we move. We do tend to reprofile for a couple of reasons. A, if we get obviously additional funding. B, if we, depending on when we run the competitive round, Senator. So we want to make sure we do that in the most effective way at the effective time. And of course, sometimes we do have to move the funding around because there are, unfortunately, as you'll be aware, Senator, delays, particularly in regional, rural and remote Australia. So there can be, milestones pushed out, in which case we will also adjust that funding.
Sure. So of the 31 beds that were delivered through ACAP funding in 24-25, how much funding went to those 31 new beds?
So the 31 new beds, which was under the old program, that was at a total cost to government, so it was only a small amount out of $11.8 million for that particular amount of projects. But I guess what I would say, Senator, one of the reasons this is a bit difficult is that even for ACAP, as for the previous program, there is obviously a focus, on building new beds, but a significant number of the projects from around are often actually upgrades or expansions. So just be aware, it doesn't mean, that's why it wouldn't equate, if that makes sense.
Quite understand that.
Sorry.
Quite understand that, and much needed in many instances in rural and regional Australia, so absolutely concede that. So,
Senator Ruston, I'm just going to check that we are heading towards lunch break, and I know Senator Payne has some questions, so just checking if I can share the call with her.
As long as I get the same amount of time that you allocated to Senator Payne, as I'm most happy to share with Senator Payne.
Absolutely, you can check the spreadsheet if you like.
Yeah, sure, no, it's okay. I pushed my button but anyway, that's fine. We'll go till this is done. So I'm interested, of the 78.4 million that was released in 24-25, how many new beds are expected from that 78.4 and how many refurbished?
I don't think I have an exact figure for that specific amount of money, Senator, but if it helps, kind of, as I think I mentioned at the last hearing, at the moment, for all the ACAP funding that we have committed, which is at this stage 951 million, and that's shortly to go up to 991. You'll see some, because we've recently done some extra grants that will be announced. So of that total, as I mentioned last time, when all those projects are finished, that is a total of over 1,000 beds. So I've now confirmed that's 1,040 beds, Senator.
There's 1,040 new beds.
That's completely new, so I'm not talking about any reopened beds, just new beds
and
for
that
you.
applies to the 951. So how much of that 951 goes to the 1,040 new beds, and how much of that 951 is going to refurb?
I can check for you. Give me 1 second. So for the new beds, it's sorry, just want to check I get the right figure here. 457.6 million in project funding equates to the 1,040 beds.
Okay, thank you.
And it kind of grows each year, Senator, just so you're aware. So as my colleague mentioned, starts with no beds in the last financial year, 93 beds this financial year, 279 beds the next financial year, and then 668. So you can see, because the ACAP program is relatively new, those bed numbers are going up each financial year as, the period increases.
Yeah, thank you. Thank you for that. So in the Collier's data, it suggests that 64% of beds were built by private operators without ACAP funding. You've just said that there were 31. So that means that your data is suggesting that there is a significant discrepancy between what the Collier's data is and your data. Do you have any explanation as to why that discrepancy is so huge?
I don't think we would, Senator. We can certainly investigate that further for you, but I wonder if there's potentially other other government funding that's involved that perhaps people are referring to. But yeah, we've definitely gone back and checked the previous grant program, as we thought that was probably most likely what was being referenced.
So when is the $300 million that was promised by the government as an additional ACAP grant round as part of the deal for the Aged Care Act, where is that $300 million profiled over the period of time that you've just described?
So that additional $300 million, Senator, has actually effectively already been committed. So we made sure across the last, I believe, 2 rounds, Senator.
Yeah, so just where is it profiled to actually leave the government coffers?
Look, I think from memory, Senator, it was kind of actually split sort of 50 million and 100 and 100, but actually we brought it forward. So I can take that from your notice if you like, Senator, but I can assure you and I can let you know how much we spent in round 2 and round 3 that was specifically directed to those areas that were relevant in the context of that 300 million, i.e. the MM 3 to 7 areas, but certainly we have definitely spent, or committed at least, that 300 already.
Yeah, so if you just give me the profile, that'd be great.
Happy to do that.
Just flagging, final question.
Okay, no, that's fine. Senator
Okay, thank you, Senator Ruston, for that. Senator Ullman-Payne.
Thanks very much, Chair. A question that I failed to ask earlier. Are you able to tell me how many people in total are subject to the grandfathering arrangements for residential aged care and home care?
How to find that information that you were going to provide me from earlier this morning, that I could maybe use the lunch break to have a look at it.
Just checking on the time.
I understand the question. I just check with Mr. Pugh. I haven't been advised myself. The information that was requested this morning, what's the likely timing on that?
About 45 minutes, but it won't be a complete picture. We'll get as much as we can.
You might want to say that in
if you just come to the desk and make that.
So sorry, Senator. We will get it to you in the lunch break. We will not have 100% of the questions asked. And just to note, the questions that you've asked that we took on notice in the earlier session, not all of those were captured in the advanced questions, so that's why we didn't have those figures to hand, but we will do our best to get as much as we can to you in the lunch break.
Okay, so you'll do that by emailing the Secretary?
Yes, we'll go through that in committee secretarial process.
Thanks. And they will be tabled as requested.
Thank you.
Thank you, Senator Ruston. Sorry, Senator Ullman-Payne.
That's right, yeah. So my question was how many people are subject to the grandfathering arrangements, and if I could get the number in relation to residential aged care and the number in relation to home care.
So for home care, we should have it in this request that we're going to give you at lunchtime.
Yep.
And Senator, in terms of residential aged care, I don't have an exact number in front of me, but it would be equivalent to every single person in permanent residential care on the 31st of October 2025.
But I don't know what that number is.
I don't know what that number is. The number of people in permanent residential aged care usually moves around the sort of 180, 190,000 people mark.
Can I get an answer
to get an exact... Well, I don't know how recent our numbers of exactly how many people there are, but we can certainly get you the most recent available number.
If I could get that on notice, that would be helpful. Absolutely. If it's possible to get it in that tranche of data that's coming at lunchtime, that'd be great. But otherwise, if I could get those numbers, please. I've just noticed that The Guardian is reporting today that people, staff who work in relation to the National Disability Insurance Scheme were given an internal briefing about the fact that they would be moving to computer-generated funding and support plans with a reduced human involvement in that. And in fact, it's being reported as a dramatic reduction in human involvement. I guess given we've already moved to a single assessment system in aged care and we're hearing a lot about people being engaged in tick and flick processes, lots of over-the-phone consultations rather than the much more detailed and comprehensive assessments people were getting when healthcare providers were doing them. I guess I just want to get an indication from the department as to whether there is any suggestion that aged care assessments are going to be moving in a similar direction.
So, no.
Just before you answer, obviously we can't really comment on what the Guardian might be reporting on the NDIS changes, and we obviously have the disability people, including the agency, here tomorrow, so probably the right
And
place
to be
pursue
clear,
that.
I'm not asking you to comment on what's happening over there, but it's raised flags for us, I guess, about what might be being considered in the aged care space.
So at this point in time, no. And in fact, it's the opposite that's true. I think in the last couple of months, we've had the highest number of assessors on the ground that we've ever had. And I'm just getting the number. 2,716 as at the 31st of October 2025. So that's the that is up there with the highest that we've had since the advent of the single assessment system and its predecessor systems.
So can I get confirmation that there are no plans or discussions underway to move aged care to computer-generated assessments?
Not as far as I'm aware, no.
Okay, thank you. Minister, just a question for you. When you were engaged in exchange with Senator Ruston early, you said we followed through on the Royal Commission. One of the key recommendations of the Royal Commission was to end the rationing of aged care. We're currently seeing that based on current numbers, the number of aged home care packages that are funded to be released will fall well short of the number of people waiting on an assessment and the number of people who've been assessed and who are waiting. We've also had the Inspector General of Aged Care say that this is a real issue and that rationing of care in many instances can amount to a denial of service. Minister, could you please tell us when the government intends to end the rationing of care so that you have in fact delivered on the recommendations of the Royal Commission?
Sure. Senator Orman-Payne, thank you for your question, and I can certainly take that particular aspect of the question on notice, but what I can say is this, that in terms of the recommendations we've known, and I know the Minister and his predecessor were very, very aware of the need to change across the aged care sector. So there was $18 billion to deliver award wage increases for aged care workers. We put registered nurse on site in aged care homes more than 99% of the time. We put 7.1 million extra minutes of care every day compared to under the previous government. We have a higher standard of residential aged care. So in December 2023, only 54% of homes had an overall star rating of 4 or 5 stars. Today, 79% of homes do. So there is a real genuine effort by our government, Senator, to invest in this sector. We know there's a lot of work to continue to do and we will continue to keep doing it.
Is it the intention of the government in the next budget to substantially increase the amount invested in home care packages so that rather than seeing that wait list continue to blow out, we actually see it start to come down?
We've made significant investment in the aged care sector and of course that will be a matter for the Minister, and I can certainly take that question on notice in regards to the next budget.
Okay, thank you. That's all my questions, Chair.
Oh, lovely. Well, we are about 6 minutes ahead and I want to continue that trend. So I think we'll release everybody for lunch and we will return. Oh.
Sorry, just for lunch?
Yes. Yes, we will. I was just about to say that, Senator Askew, that we will continue in outcome 3. We are not releasing any witnesses, so hang tight at the back there, and we will return at 1:55.
break and continuing in outcome 3, ageing and aged care. I just wanted to quickly mention that there were also other witnesses that that I failed to mention during our changeover into outcome 3, and they are the Aged Care Quality and Safety Commissioner, Ms Liz Heffron-Webb, the Independent Health and Ageing Pricing Authority, Professor Michael Pavan, and also the Inspector General of Aged Care, Ms Natalie Siegel-Brown, as well. So if any of those witnesses had an opening statement, I would ask that they table those, and they will be invited to questions now. I think, Senator Ruston, you're ready?
Thank you very much, Chair. I've received this in the break in relation to tenders. Mr Pugh, was something else? Sorry? Okay, thank you. Okay, so is Professor Pervin here? Please, I'd love to talk to you. I have to ask, have they given you any more staff yet, or is it still just you?
Professor Michael Pavan, IHACPA. Thank you, Senator. No, it is the Pricing Authority still has one employee, but fortunately the COVID-19 infection rate's right down this year, so that hasn't happened. We've had 0 infections.
I would have thought with all the people in the department, they might be able to at least give you a few people that were your own. Previously, I asked a question in relation to a review about, I think, let me just get the exact wording, for people, so what do they call it, stranded patients. Did you undertake that review?
Thank you, Senator. No, I didn't undertake that review. Stranded patients was a term coined by Professor Stephen Duckett and some work he did for states and territories. We did, as part of our annual review of activity in the hospitals, undertake a report which it looked at long stay older patients in particular in 2022, 23. I'm not quite that old yet. And alongside that, trying to investigate the area a little further, contracted a company by the name of Taylor Fry to investigate one specific part of that group, which were the maintenance patients, the long-stay maintenance patients.
So where is that review now?
The review was completed and shared with states and territories, and was provided to the department, who worked with states and territories through health CEOs to establish a major work program to identify the detail of the cohort of the patients which we are regarding as long stay, or as Professor Duckett would say, stranded, and to develop work streams across the states, territories and Commonwealth to actually address the causes, the underlying causes of their stays being over when it's considered clinically appropriate, and to get them to their ultimate destination faster.
So where is that review now? Is it published?
IHACPA's involvement, apart from the interest, finished in around November 2023.
So maybe, Mr Comley, we could find out what the department's involvement in, or did it only go to the states and territories and not to the Commonwealth Department?
I can ask someone to come to the table. My understanding is it didn't just go to the states and territories, it went to HSF, and I believe it's been published, unless someone contradicts me on that.
Okay, well, maybe you can find out. And let
we can
me
find
know.
out. Yep.
Okay. So can I just ask in relation to the latest ANAC price increases that obviously went through you, there's been some conjecture that the modelling assumptions were from 2022 rather than more recent data. Is that correct?
So we've completed 23-24's costing study, and we're using data from 2022 all the way through. So we do use all of the data that we accumulate. What we're trying to do is establish exactly where the trends are going so that we can appropriately weight the various prices at the ANAC levels. So no, we don't model from 2022-23. There is some of that data in our considerations, but the current reference costs, if you like, are based on the more current study.
So have you been able to get access to updated modelling to reflect real inflation increases, real labour costs and real wage movements?
Yes. Yeah.
So with things like superannuation, leave loading, penalty rates incorporated in your...
Yes, they are.
Oh, okay.
Sorry, Senator, I think there are differences between 24-25's price and the price we're working on at the moment, and they actually go to the data that we're accumulating. So what the data is telling us is that movements amongst nursing staff in aged care are moving exactly where Fair Work Commission and others would suggest they are going, whereas care support workers, their costs aren't growing as quickly. So there are some slight changes between what's driving those two prices across those 2 years because of what the costing data is showing.
Because I noted in the recent Stuart Brown report, they said that the ANAC increases may be insufficient to fully fund both the Fair Work Commission's pay rise as well as the ordinary increases that you would have seen in terms of the inflationary impact on other things. And I have to say that has been my experience in terms of speaking to many providers, that they don't believe that the 4.3% base increase in ANAC funding, especially when it related to the change in the ratio on the NWOWs, actually delivered them the increases that they said they needed to reflect the pay rise and the inflationary impact on all the other aspects of their business.
Thank you, Senator. We do appreciate the concern and are very, very careful when the Fair Work Commission issues a decision. The decisions are by no means simple. They are very complex decisions to implement, and so we work very closely with the department to make sure that the pricing advice reflects the letter of those decisions, but also what we are getting from both our own costing studies and the quarterly financial reports. So we use as many data points as we can to make sure that the price reflects the costs.
Yeah. So in terms of your determination, you believe you fully accounted for the 15% pay rise?
Yes.
Okay. It seems to be in some level of contention, but no doubt you used the data that was available. So to you, Mr Comley, has the department validated that the change in the ANAC funding actually covers the mandated care minutes for an average provider on real-time costs, including all the on-costs that are associated with it? Have you satisfied yourself following the concerns of the Stuart Brown report? And I don't think anyone can doubt that Stuart Brown is considered the expert in the aged care market when it comes to pricing. So after the Stuart Brown report raised that it may be insufficient, has any activity been undertaken to make sure you've validated the concerns?
We obviously we engage heavily with IHACPA and make sure we do lots of due diligence on where we think the implications of those are, but we think IHACPA does a good job and they've fully factored in that wage increase in terms of advice on ANAC. I mean, Ms Trainham or others might want to make a comment.
Senator, Mark Richardson, Assistant Secretary, Residential Care Division. Yes, our view is that the Fair Work Commission wage increases, not just the 15%, but other Fair Work Commission decisions are incorporated in ANAC funding. So care is fully funded. So, yes.
So, after the ANAC change and the redistribution or reclassification of NWAs, how many providers saw a net reduction in their units following the October reclassification?
A net reduction in their funding?
Net reduction in... Well, no one's going to receive a net reduction in their funding. Well, did anybody receive a net reduction in their funding?
I think there may have been a small number, Senator.
Okay.
I would have to take the exact number on notice.
So could we have the number that actually had a real, actual decrease in the number? I think what I was trying to get at was how many, was it 4.3% was supposed to be, was the increase in the base ANAC? Okay, so how many providers received less than the 4.3%?
I would, once again, I'd have to take that on notice. The average was 3.3%, Senator, but if you take into account hotelling, it was a 5.1%
no, I'm not
increase.
asking you about hotelling.
Yep.
Don't conflate the two issues.
No,
They're two completely different things. I'm just talking about ANAC funding. So I'm interested to understand, of the 4.3%, you've just said the average was 3.3%. I'd really love to know how many received more than the 4.3% and how many received less than 3.4%, and how many received more than the 4.3%, how many less than the 4.3%, and how many actually had a reduction in their ANAC funding because of the change of the units?
I can take that on notice, but you're correct, there is a range.
Okay. And do we have a timeframe in which we might be able to get that information?
I should be able to get that to you quite quickly.
Okay. Okay. And I'd be really interested in terms of that data, if there was, where the actual location of the homes were, whether there was a greater propensity for rural, regional, remote homes to go up or down as opposed to metropolitan, etc. That would be really useful. So in terms of the NWAs, who is the determining factor in terms of the reweighting of those? Is that you?
Thank you, Senator. Ultimately, it's the Minister.
Okay.
And so we provide our advice under the Act to the Minister. The Minister confers with the Department.
Mm-hmm.
Sometimes the advice goes through as provided. Sometimes it's amended to reflect particular policy positions.
Mm-hmm. So did the advice go through unamended this time?
Yes, it did, Senator.
Mm-hmm. Okay. So I'm just interested, is the government funding only 25% of historical leave liabilities for residential aged care workers this financial year through a grant program? Is that correct?
Thank you, Senator. That is correct.
And how much what percentage of leave liabilities were funded last year?
I would need to just pull up those exact figures, Senator. My apologies. My colleague, Ms Hendricks, may have that figure.
Lauren Hendricks, Aged Care Workforce Branch. So it's 25% for residential care providers, 50% for all other eligible providers, and I don't believe that's changed between grant opportunities.
Okay, so 23-24, there was the same grant funding in terms of historical leave liabilities, same percentage were eligible year on year. And that's historically been...
For each of the grant opportunities, yes, that's correct.
Okay, right, thanks. So, okay, so before I move on, Mr Pugh. Chair, can I just ask if it would be at all possible for us to consider asking for this agency to return tomorrow if I have not received the information that I was promised by the time this section is finished? It seems to me like there is a reluctance to provide me the information. I hope that's not the case. but, you know, we were promised it before lunch, we were promised it during lunch, we were promised it after lunch. And it is the one issue that I seriously wanted to ask questions because it relates to the budget and I don't have it. So I just put on the table that I will be requesting that information, or requesting you to Aged Care to come back tomorrow, obviously subject to the committee with deliberation, because this is getting ridiculous.
Senator Ruston, I would suggest that suggesting that officials at the table are unwilling to provide information is very, very unreasonable. They've been here all morning trying to assist you with your requests. My experience with officials through estimates has been they make every attempt to be helpful to senators asking questions, and it is absolutely within the right of officials at the table to take questions on notice, and they do their best to get a response back to you as soon as possible, noting that questions on notice are usually supplied probably after estimates is finished.
Please, Senator Stewart, thank you very much.
So, no, I'm still talking.
Well, with the greatest amount of respect.
I'm still talking.
Senator Ruston, please don't interrupt. Senator Ruston,
interrupt.
In the courtesy of, again, the behavioural code of senators, it's written out here if anybody needs a reminder, that
I
while
just wonder
other
whether
senators,
you gave a call
again,
to the senator as a point of order. Is there?
You can't
yes, it is a point of
Please,
order.
I'd like a private
Absolutely.
meeting in relation to that. Broadcasting, thank you. Thank you, everyone. Just in light of the conversation, I'm going to do a couple of things, and thank you to colleagues in the private meeting. Firstly, I'm going to ask Senator Stewart to complete her point of order that was raised. I'm secondly going to ask officials to clarify the data that has been requested by Senator Ruston and to clarify the time frame of that. And then I believe, based on that answer, I may have to allocate the call to Senator Orman-Payne, who just ran out of the room. So I will go in that sequence so that we can work through this. So, Senator Stewart, you have the call.
Thank you, Chair. My point of order was really about reflecting on the public service, that they are intentionally trying to be unhelpful. My experience with officials at the table and public servants over quite a few estimates now is that they do their very best to provide information in a timely way to senators when they are asking questions. And I think reflecting on officials in that way, for my mind, is just really disrespectful of them and is entirely unfair. So I would ask the senator to withdraw that comment about the public servants and officials at the table.
Thank you, Senator Stewart. Senator Ruston, would you? I would invite you to withdraw your comments made before we entered into the private meeting in the reflection upon.
Sorry, which comment you asked me to withdraw?
The reflections on public servants in withholding information from the Senate. Willfully.
If it assists the committee, I'm happy to withdraw.
Thank you.
And I look forward to your next question.
Thank you. So, Mr Pugh, Mr Comley, can you give us an update on the point that was raised by Senator Ruston in relation to the data that was earlier requested? I think, without verballing her comment, was that they were given an indication that it would be with them at the lunch break. So I just want to clarify that time frame so that there is clarity around that.
So my understanding, Chair, is that the data is being sent as we speak, emailed as we speak to the committee. I wanted to make two comments. The first is some of the things that Senator Ruston requested were flagged in her letter, and we were prepared to talk to that. Some subsequent things were slightly different written information requests, and that's partly what's taken some time to pull together those two pieces of information. There may be one or two outstanding things there, but in the interest of time, we've sent what we have through to the committee to assist the deliberations of the committee.
Okay, thank you very much, Mr Comley, for clarifying that. And I will get the Secretary to confirm for me that that has been received, and when it is, then we will ensure that that is tabled. Senator Orman-Payne, in light of that, is there, I believe you wanted to make a comment?
Yeah, I just want to place on the record, whilst we appreciate that that's been sent through, there is a level of frustration given that we still have a number of questions taken on notice at the last estimates hearing that are still outstanding, and we tried to do the courtesy of writing ahead of time to give the department a heads up, and it makes it very difficult to ask the questions that we want to ask in an efficient way if we're still waiting on information, and particularly from last estimates.
Okay. Thank you, Senator Orman-Payne. Just checking, Senator Ruston, if you were finished your block of questions. I did have it at about 20 minutes that you already had been asking. I'm hoping to shift the call now to Senator Orman-Payne and come back to you if that's possible.
I don't have any more questions,
okay.
Chair. I'm going to Dewar in a minute.
You're on your own.
Thank you.
You have the floor.
Yeah, thank you. Could I ask some questions about a story that appeared in AAP in relation to aged care worker shortage? I'm happy to table it if you don't have it.
Might be useful to table for completeness. Was it also in the West? Is that the...
Look, I've just got this particular one.
I suspect it's the same article.
Yeah, yeah.
This is, yep.
Yeah. So,
Sorry,
do you want me to move to something?
Tabling a document?
Yeah,
Sorry.
I just handed it to.
Okay,
yeah.
great.
So I can ask something else while I'm waiting.
I think in this case we are familiar with the article that you're talking about, so
Okay.
I'd be happy to take those questions.
Sure. So I'm just wondering, first of all, regarding the accuracy of the accusations or what was provided in that news article.
Thanks, Senator. Emily Harper, Market and Workforce Division. So the reporting that I think you're referencing, and we'll certainly check once we have those tabled copies, was in reference to I
was going to say, do you want to wait until you've got them so that you actually can be sure that you're talking about the same thing?
I think I'm broadly comfortable.
Okay,
It's the same thing. But that reporting referenced some internal draft outputs from a model, and those internal draft outputs were not used in any fashion. We were unable to validate those outputs internal to the department, and so they have not been used more broadly, and we're unable to validate the outputs as against some of the assumptions that were input to the updated model. One of the other things I'll call out, Senator, is that there is work underway at the moment, and I think we have conveyed this through previous correspondence with yourself ahead of estimates hearings, that we are at present working on a revised and updated model which takes into account further data sources that we are now able to access in the post Aged Care Act implementation world, as well as drawing on the various policy assumptions and so on. And that testing and validation will be happening over the first quarter of next year, after which point we'll be able to provide additional information about forecasts and modelling.
Can I just add, my understanding is that draft modelling was released under FOI, so it was not the department saying these are final estimates, we've put them out in a published form. Maybe with the benefit of hindsight, we'd look at that and say that's a draft or a working document, and that was not helpful, but it was never the final position of the department that incorporated those numbers, and we identified that there was better ways of modelling it.
So do you still stand by the numbers that you have put into the public domain over recent times? Because, I mean, the difference between there was 4,000 and the like, and I mean, we're now talking, 120,000 more staff by 2035, 36, an extra 35,000 aged care workers this financial year. I mean, they are substantially different to the figures that were put out into the public domain prior to that. I must say that if these figures are so wrong, the reason you would release them absolutely mystifies me. So could you perhaps give us an update on the accuracy of your existing figures? Are they correct?
So the figures that are in the public domain that have been referenced previously, we stand by those figures until such time as we've completed the revised modelling that we've spoken about. Those are the best figures that we have available on the information that was available at the time, Senator.
So when did the department first become aware of the calculation flaw that was identified in this memo in March 2025?
So the revised draft model was finalised and provided to us in March, and the documents that were released under FRI indicate that the analysis that we were doing internally was conducted over April and May this year.
So what you're telling me is that you released a document that you believe to be manifestly untrue into the public domain? Or not?
What we're saying is we released under FOI a document which we don't think was the best modelling we had available, but as I'm sure you appreciate, when you do an FOI request, you identify all the documents that are relevant to that request. It's not actually a test of the FOI Act or whether something is misleading, it's just whether it's a document and whether the exemptions apply. Arguably, someone should have applied an exemption to that in terms of a working document, but they didn't. They released it, and now it's in front of you, even though it's not our view of the best modelling available.
So did you advise the Minister's office that this document existed and that there were potentially concerns around the modelling in terms of workforce requirements?
So we regularly update the Minister's offices around workforce constraints, shortages, pressures and so on in the general sense. About this particular document, it was an internal working document, Senator. The answer to that is no.
So you released under FOI an internal working document with that kind of data in it without telling the Minister?
Yes.
Okay, I'm not sure I'd be very happy if I was the Minister. So we've got two sets of figures at the moment. You've got the FOI document that you say is not the best information that you might have. We've got another set of data that you have been relying on for some time, which is significantly lower. I mean, we're not talking by a matter of 1 or 2, we're talking like 10 times lower. I'm just keen to understand, have you done any emergency analysis around the discrepancy between this document and your publicly available information as it might relate to the impact on providers for meeting their care minutes?
Senator, the answer to that question, the short answer to that question is no, we haven't done emergency additional analysis. We understand that there are issues with the model internally. We are working through that to further strengthen the model, as I've articulated previously. What I would say, though, is we are seeing some positive trends in workforce as reported by providers through various surveys, also through workforce surveys, direct workforce surveys as well. We do know that the aged care workforce is growing and significantly, and whilst the forecasting is, of course, a key focus, an area of work and very important for informing future planning, it is not the sole evidence or data point that we use when we are considering and advising government on workforce matters. We have a range of surveys. We have our engagement directly with providers. We also have our ABS labour force statistics. We have various other models that are in place across the department. We monitor turnover rates. We monitor direct employment rates, and many of those are trending in a positive direction.
Okay, so in this document it also says that new workers from the pay rise may be double counted in current figures now that the pay rise is 22 months old in effect, and that current figures underestimate how workers will sometimes need to spend longer than the minimum care minutes with residents. Is that part of the document correct?
So there are a range of issues that the document has highlighted, but we were unable to validate some of the findings from the outputs in that model. It is an internal working model, and it has not been an internal working document of a draft which included draft outputs from a model that hasn't been used because there were concerns within the department about the veracity of the information within it.
So that could be correct, you just haven't validated it?
Yes.
So everything in this document could be correct, you just haven't validated it, and you're in the process of validation now?
We are in the process of validating a new model that takes into account the changed policy parameters associated with the reform as well, when that will include, yes, care minutes and Fair Work Commission outcomes and their application and implementation.
Okay.
But we are not working to validate the outputs that have been reported there. We could not validate those, and that is one of the reasons we are moving forward with a new model.
Okay, and so what timeframe are you proposing that you will actually have more accurate data in relation to workforce needs?
So Senator, we're working to validate and test the new model over the first quarter of 2026. So in the next 6 months.
So, I mean, this begs the question of the confidence that the sector can have in the data that is coming from the department. Have you got any concerns about other data that you've been using and providing in the public domain that potentially has been undermined by the kinds of document that this one was released? Are there other situations where the publicly available information that you've been providing, there are potential conflicting data within the department that would suggest they're not correct? I think this is just so massively different from anything you've said. It really does raise some pretty serious concerns about the efficacy of the data that's being provided by the department.
Sarah, I wouldn't accept that. I mean, I think in any modelling exercise, there is a often quite vigorous contest of ideas within any department about how you might model it, what's the best source of information, what is going to be the most important thing. It's quite a usual part of the process of finalising modelling input and output. And then as a department, what we make sure is that we feel we've done the full validation and verification process before we put that out as official departmental numbers. Though that FOI request released a document at a point of the maturity of that modelling process which wasn't mature, which is why we wouldn't stand by those numbers. But I'm completely comfortable that that is an illustration of internal hypothesis and debate that you'd expect in any modelling exercise.
Mm. Okay, so can I ask some questions about the integrated assessment tool?
Can I just flag that I'll need to shift the call shortly to Senator Payne.
If Senator Payne wants to go now, I'm happy to leave my next block because it's a new block of questions.
That's very helpful. Thank you, Senator Ruston. Senator
Sorry,
Payne,
I've gone and asked.
Sorry to shift everyone in that. Just hold fire if it's not the same area.
My one's just on palliative care, so end of life. Okay.
Thank you.
We'll see where it takes us. Good afternoon. Thank you. I was just curious to understand what data or evidence there is to support the current entry criteria for both A and ACC Class 1, which is for palliative care, and the end-of-life pathway, specifically the requirement that someone be certified by a doctor or nurse practitioner as having 3 months or less to live.
So thank you, Senator. So we can answer, myself and my colleague here can answer the end-of-life pathway for support at home.
Sure.
The question around the palliative care in the ANAC will be one from my colleagues at the end of the table. So
excellent.
Ms.
Thank
Snow
you.
can answer. Yep.
So is the end-of-life pathway is a new pathway. We consulted over a number of years and we did have a look at the ANAC Class 1 eligibility, and you'll note that it mirrors that eligibility. So it is something that we will be looking at over time as part of any good program administration.
How frequently is the review process? When you say you'll be looking at it, is it?
So there's a formal supported home evaluation that will be undertaken. Colleagues in the room can provide further detail on that, and the end-of-life pathway will be captured as part of that process.
Okay, cool. Thank you.
Senator, I think you asked about ANAC Class 1 and the criteria.
Yes.
I guess there's a form that's submitted to the department. It does require a health practitioner to verify that an individual has no more than 3 months to live in order to receive palliative care or ANAC Class 1. In addition, there's something called a modified Carnifsky score of 40 or less, I think it is, which effectively means that the person is largely refined to their bed. If those two criteria are met, and the form has to be submitted within 2 weeks of entry into residential aged care, the person receives ANAC Class 1.
Okay, thank you. And can the department explain why less than 0.1% of residential aged care entrants are classified as ANAC Class 1 when the equivalent figure under aged care funding instrument was around 6%?
So I think there's some context here, Senator. While to get ANAC Class 1 you have to be palliating as a part of entry, once you're in residential aged care, you can a provider can request a reassessment or a reclassification. Providers often do that at end of life or when someone, I guess, has no more than 3 months to live. And as a result, they would receive a new ANAC classification. And people pass away in every ANAC class. I wouldn't be able to tell you the number of people that pass away, I guess, in those circumstances in each class, but I think we have about a 30% turnover in residential aged care on a yearly basis.
And does the department have any data that would indicate what proportion of support at home participants the department expects would make use of the end of life pathway, which I guess would be you guys?
At this stage, we don't have data we can share on that.
Okay. Is there an anticipated timeline when we can expect any form of data or information on how that's tracking?
We expect the first quarter of next year we'll have a much broader data set we can share.
Great, thank you. And is the department aware of the Inspector General of Aged Care's recent recommendation to commission independent evaluation of the prognosis-based access criteria for palliative care specific pathways to consider whether they are unnecessarily restricting access to support? It was on page 51 of the Inspector General's recent report on the implementation of the recommendations of the Royal Commission into Aged Care Quality and Safety.
So yes, we are. Thank you, Senator, and that will be wrapped up as part of the review process that Ms Snow mentioned.
Okay, and that will be also released sort of in the first quarter of next year?
That'll be a longer term.
A longer term?
Yeah.
Okay. But is there any form of, I guess, update on how that, implementing that recommendation, will we get some form of an indication or update in the first quarter of next year?
We're happy to take that on notice and see what we can provide earlier ahead of the broader evaluation.
Thank you. And I guess you would probably take it on notice on whether such an evaluation will be commissioned by the department in full or in parts, and what that's going to look like as well. Yeah,
happy to do
okay.
that.
Fantastic. Thank you. Thank you, Chair. That's it.
Senator Payman. Senator Brown.
Thanks, Chair. My questions go to workforce, and I want to ask some questions around how the government is supporting the expansion of the aged care workforce. So I've got a few questions here. Ms Harper, and they'll go to pay, training and various other efforts that the government's making. So first I'd like to start with how much has the pay of our aged care workforce increased over the past 3 years due to the Fair Work Commission's decisions, and the support that's been given by government in the budgets? Are you able to provide that information?
Absolutely. I might ask Ms Hendricks to...
Sure. Thanks, Senator. Maybe a few examples of the scale of wage increases for workers, given that each worker at the various pay points receives slightly differently. So a few examples: so a registered nurse level 2 is receiving more than $28,000 extra a year, an enrolled nurse level 2 $25,000 a year, and a personal care worker level 3 more than $18,000 a year. And the total investment in wage increases for aged care workers has been $17.7 billion.
So how many years are we talking about? Over the last 3 years, is it?
So the first wage increase commenced on the 30th of June 2023. There's then a series of increases: 1st of January 2025, 1st of March 2025, 1st of October 2025, and there's one final increase on the 1st of August 2026.
1st of August 2026. Do we have a figure on that?
I don't know that I have just the August increase, but I can take that on notice.
Sure, that would be good. So I think you just said that those increases from 2023 over those bands was $17.7 billion in aged care pay increases that the government supported, funded.
That's correct.
Okay. So the government's also introduced the 24/7 registered nurse requirement as well. When did that happen? Hi, Mr Richardson.
Yes, sorry, Senator. Could you repeat your question?
The 24/7 registered nurse requirement that's been introduced by this government, when was that announcement made, and when was it introduced?
The 24/7 registered nurse requirement was an election commitment in 2022, and it started on 1 July 2023.
Oh. Okay, and was that from my memory, that was a recommendation of the Royal Commission, was that correct?
Correct, Senator. The Royal Commission recommended that recommendation to be implemented on 1 July 2024, but it was implemented 12 months early.
12 months early. That's good work. So how's it going? How well has the implementation been, and can you give me any information on to how well it's been received, and what difference it's making?
I can give you the most recent statistics in terms of coverage, Senator.
I love a good statistic, so right.
Okay. So that's of the month of September of this year. For those facilities that reported, there is a registered nurse on site 99.42% of the time. That's equivalent to about 23 hours and 52 minutes a day. For those facilities that reported, 94.94% reported that they had an RN on site 24/7.
Right.
That's an increase from July 2023, our starting point, from 86.03%. So I guess roughly a 9% or close to a 9% increase since then.
So a nurse on site 99% of the time in residential aged care?
Correct, Senator.
So that's across the board. So what support is in place for those smaller facilities, in regional, rural and remote areas to meet the requirement?
So we have a care minute supplement, Senator.
Sorry, can you...
A care minute supplement.
A care?
Minute supplement.
Right, yeah, sorry.
The supplement's designed for those facilities that don't receive sufficient funding through ANAC funding to deliver 24/7 registered nurse care. So that's for homes with 50 people or less in any given month.
Okay. And that's working well?
It is. There's about 570 homes that receive that every month.
Okay. So, and of course there's other challenges when we talk about regional, remote and rural areas, particularly around attracting and retaining aged care workers. So what steps, I'm not sure, I'm over here I think, what steps has the government also provided in terms of any sort of capital assistance?
Thank you, Senator. So in terms of capital assistance, around $106 million has been allocated through the Aged Care Capital Assistance Program, or ACAP, to support a total of 52 staff accommodation projects. We know that's very important in some areas where it's quite difficult to house staff, particularly in residential aged care. On top of that, there's also been $37.1 million provided for the Rural Locum Assistance Program, which assists approximately 80 to 100 aged care homes annually in rural and remote locations with locum support, where staff can be very difficult to directly source. And in addition, there's been a $31.1 million investment in testing a virtual nursing framework.
Sorry?
A virtual nursing framework.
Can you give me some more information on that?
Yeah, certainly. So this is around the delivery of safe and high quality services in areas of workforce shortage. So the program here is to support up to 30 homes across Australia. I hasten to add it does not count towards care minutes that Mr Richardson was referring to earlier, but it does allow facilities that are in areas where there are challenges in obtaining those sort of clinical oversight staff to trial programs where there may be a virtual sort of online presence and allows for, information to be provided and support to be provided to train the staff that are in the location as well to care for people's particular requirements.
So how long has that framework been in place?
So the first 5 residential aged care homes to test the frameworks commenced on 17th of July this year. The program's currently funded for 3 years and aiming, as Ms Harper mentioned, to have 30 homes in total trial the model.
Right. How's it going?
We've heard some really positive early feedback on the program. What we're hearing is that it's really supporting continuity of care for residents because the virtual nurse is often the constant for a resident, and that it is, we are evaluating this to have some clearer data, but what we're hearing anecdotally from the providers participating is that it is actually supporting residents to remain in the home and not be escalated to hospital because they have that clinical oversight from the virtual nurse.
How does it work?
So there is a cart that has a camera on it, and phone call and video conferences can be made between the virtual nurse and the home to speak to the resident. Often,
it's not an actual. Sorry to interrupt
you,
Ms Hendricks, but it's not an actual person being carted around.
So, so there are booked appointments for residents, and it might be at times like clinical handovers between staff shifts that a virtual nurse might be there participating in the handover, and it's often things like wound care, medication management, that extra clinical escalation point for nurses on site to be able to escalate cases and get a second clinical opinion.
Okay, that's good. Now, also, Ms Harper, you did talk about some of the other measures that the government's been taking, and you talked about accommodation as well. I think. If it's too much, otherwise I'd like to know where they are, but if it's, happy to take it on notice.
There are. It has been around 52
you said
projects.
Yeah.
So I think, given that scale, Senator, if you're comfortable, I would suggest providing on notice.
Yeah. Okay. Oh, okay. If I have.
Last one.
No, that's fine.
Okay.
If I do have any more questions, I'll put them on notice. But it's obvious that there's a lot of work that's been undertaken to attract and retain staff out in remote and rural and regional areas. Well done.
Thank you, Senator Brown. I have some documents that have been that need to be tabled with the committee. The first one is the Department of Health and Ageing, Disability and Ageing contract notice information as requested by and in response to questions from Senator Ruston to be tabled. There are also in response to the questions that were requested on the 25th of November from Senator Ruston and response to requests from questions from Senator Allman-Payne on the 27th of November. So they are now tabled with the committee. Are you ready to go again, Senator Ruston? Nicole?
Sorry, just trying to read some of the data, and so thank you very much for providing that. So back to the integrated assessment tool. So I'm just wondering if you could briefly just explain exactly how does the IAT determine the support level assigned to an older Australian?
Thanks, Senator. So the integrated assessment tool is the assessment tool, as you've said, used by the aged care needs assessors. And what that does is it tries to capture a comprehensive picture of an older person's needs to ensure accuracy and consistency across outcomes.
Sorry, my question was how. Not what, but how.
Sure. So the how, it consolidates a range of different inputs across the older person's needs across several domains. That gives them a holistic view of their health and circumstances, and it uses embedded, independently validated tools, and that assesses abilities and capacity. I'm not sure if Ms Black would like to add anything else to that.
I think that covers it well, thank you.
Yep. So is it possible to provide a breakdown of the inputs and how they're weighted?
Yeah. So, sorry, just having a side discussion on this. So I can take that component on notice. We were just wondering if that was more towards the IAT classification algorithm that sits underneath it, or if it's the tool itself.
First of all, I'm just trying to understand how this actually happens. So, as an example, I mean, are all complex clinical and behavioural needs built into the IAT's inputs?
So it's a bit of like a decision tree as an assessor works through the integrated assessment tool. There will be different pathways and additional clinically validated tools that open up depending on the answers to particular questions in different domains of the integrated assessment tool.
Yep. So are those assessors or those clinicians able to override an IAT generated support at home classification?
So not for support at home. I mean, the IAT is there to basically put you into an aged care program. So it can be used for, not within support at home itself, but it can be used to override.
Just speak a little closer, or maybe
sorry.
Sorry,
hard to hear.
witnesses, can we, Hansard is having some trouble, so please use your outside voice.
Yep. Is it just me only?
No need to whisper. They are having some trouble picking everyone's voice up, so thank you.
So there is an IAT functionality that is used for support at home specifically for the end of life or restorative care pathways. It's also used to classify someone into the Commonwealth Home Support Program or into residential aged care.
Yep, okay, I'm not talking about that. I'm actually just talking about a general assessment. So we're not talking about transition care or end-of-life pathway or restorative care. We're just talking about just a IAT generated support at home classification. Can an assessor or clinician override that?
No.
No, they can't. So what happens if a clinician's observation, behavioural patterns, cognitive decline, safety risks, falls, etc., indicate that an individual requires a higher level of support than the IAT spits out? Is there no capacity for them to do anything about that?
So not on the spot. The way that the IAT is designed and the algorithm that sits underneath it is to make sure that the inputs...
So it's done by an algorithm?
There's an algorithm that sits underneath the IAT, yes. So maybe to take it back with some context around the IAT classification algorithm. So that is a set of rules that objectively assigns each participant to a funding class based on the clinical characteristics recorded when they're assessed entry into the program. So basically that is the thing that delivers an assessment outcome. So that's for the IAT, and then the support at home priority system algorithm is the one that puts you into the priority or classification level for which you're assigned a place in the support at home program.
And I'm just trying to clearly understand, so there's no capacity for an assessor or a clinician at that time to override the decision of the algorithm. So given that inability, could you point to me in the Aged Care Act or in the rules where this inability to override the IAT for support at home exists? Because this is the first, of recent times, is the first that I realised that we actually had an algorithm determining what people's care needs were. So where in the legislation or the rules does this appear, and when did it appear?
8110 in the aged care
Just
rules.
before we go there, Mr. Pugh, I don't. An algorithm means many things to many people, but the assessor, when they're doing what Mr. Pugh described as the drop-down boxes of classification, is actually forming a judgment of a whole range of clinical and need assessments on the way through. So what the process then takes those inputs, which is from the assessor, the human assessor, then allows that to be used consistently across the program. So I just don't think there should be any impression that there's just an automated process that doesn't have human intervention forming assessments on the way through, and those assessments by the assessor can also take into account clinical judgment at the time to say which category of need people should sit within. I don't know if the Chief Medical Officer would like to comment at all, but this is not an unusual process in terms of deciding what level of assessment should be met.
Thank you, Secretary. Professor Michael Kidd, AO, Chief Medical Officer for Australia. Having looked at the process, it's encouraging that there is a human element and a strong human element in this assessment, and that the clinical judgment is contributing to the assessments which are being made.
Thanks, Professor Kidd. I suppose I'll just draw your attention back to the fact that Mr. Pugh said that there was no capacity for a clinician or an assessor to override a decision in relation to an IAT-generated supported home classification. And so did you want to answer me? You said it was 8110, and I'm assuming that's in the rules?
In the rules, yes.
And when were those rules registered?
So these rules were the ones that were released for exposure draft on the 31st of July 2025.
Okay. So in that it was made clear that there was no capacity for the assessors or the clinicians to override? Yeah,
that's correct. And then those rules were made on the 23rd of September 2025.
Okay. So are there any independent audits in place at the moment to monitor how the IAT is actually working in terms of the accuracy of these algorithm-generated classifications?
Yeah, so when it was developed, it was based on a range of statistical and machine learning techniques, and it actually used data from over 22,000 aged care assessments. So there was that level of...
Using AI?
We're not using AI to generate the outcome, no. It's just an algorithm that is prescribed in the rules, and that is what is used to generate the outcome. There is no AI involved in it.
Mr. Pugh just said that when the 22,000 records that were used to validate the tool were looked at, there was some AI used to determine how accurate the tool was compared with other clinical assessments. That's right.
So in a sense, there is AI used in this. An algorithm seemed a little useless without AI.
So the AI was used at a point in time to inform what the algorithm could be, obviously checked with a whole range of other sources of analysis. The algorithm has now been established as and applied by an expert assessor taking clinical input where required to determine which subcategories people fall within, which then goes through the algorithm to work out where that maps into the level of need for a level of supported home assessment.
Okay. So, as I said, do you have any independent audit, and what has that independent audit found if you have one?
So we've got a couple of mechanisms in place in terms of audit and assurance. We've got staff that undertake in-depth desktop reviews, and they also do some comparative analysis of aged care assessments across all assessment organisations, and we're doing that to make sure that there are consistent outcomes and ensuring there are continuous improvement in quality of practice. We do have an intention to regularly review the IAT classification algorithm. We will make refinements if we are seeing that it is not operating as intended. And we've been quite open with our state and territory and also our private assessment organisation partners in saying if you are seeing issues where an adverse outcome is being made from the IAT, please let us know. We have started to receive some case studies that have been sent through, and all of that will factor into our review processes.
Yep, okay. So does the department accept that, automating these decisions actually reduces a level of autonomy for older Australians, which is in direct conflict with the rights-based system that the Aged Care Act was supposed to implement?
I wouldn't say that I accept that. I would say that what we were seeing under previous aged care programs was quite a distorted level of assessment outcomes, and so the intention behind this process is to make sure that people who have got a similar level of need are matched to a similar outcome in terms of what they receive for their packages and their needs.
I was wondering if the Commissioner might come to the table and perhaps give us any advice in terms of whether she's received any complaints in relation to the classifications that have occurred by this mechanism.
Thanks, Senator. No, we receive contact from people from time to time around assessment issues, but we don't take formal complaints about assessment because we're taking complaints about aged care providers, and the assessment process generally is occurring before the person is with a provider. So when we get contact about that, we'd refer them back to my aged care.
So who would be? Oh, don't go. I've got other questions for you, so stay there. So who would be the one? Where would somebody who has received an assessment that they think is manifestly inadequate, where would they go to make complaint or seek remediation?
I see Mr Day joining us at the table, and just while he gets ready, probably the primary set of recourse is through our reconsiderations team. I received one yesterday, for example, and so that's going through the reconsiderations process.
So could you perhaps provide us with a number of reconsiderations that have been requested since this new tool's been in place?
I think we're at 2, but I'll take it on those.
We might be able to get that for you now to see if the official can come to the table.
Sure. I'm happy for you to provide it later if it's going to take a bit of time.
I'll let Ms Hutton.
Good afternoon, Katie Holm, Quality and Assurance Division. Senator, I think your question was how many applications under the new Act
have sought reconsideration?
19.
19. Okay, all right. And over what period of time was that?
Since the 1st of November.
19. Okay. And how many assessments would have occurred in that period of time?
In terms of completed matters, or
to have been in a position to actually have the assessment such that they would be in a position to seek a redetermination?
In that period of time, we've had matters considered under the previous legislation as well as the current Act.
Those that have used the IAT?
If I can just clarify on that, the IAT, the tool, has been in place since the 1st of July 2024. Yep. What's new under these new arrangements are the additional tools that run over the top of that Mr Pugh has talked about. Yep. We don't have stable data yet about the number of assessments that have been finalised since the 1st of November. We are keeping an eye on that, but it takes some time for that to filter into the system.
I'm happy to come back in February. If you could put on notice that I'll ask that in February, that'd be great.
Senator, 19 under both previous and the last month, and we are doing tens of thousands of assessments each month. Proportionally speaking, I know we'll take it on notice, but I think as a matter of proportion, it is quite low.
Okay, well, we can certainly get some more data from various groups in terms of, I wouldn't be raising this if it hadn't been something that had been raised with me on numerous occasions. And I can assure you not everybody raises it with me. So to you, Ms Hev from Webb, in the last estimates, we raised the issue of Northgate in South Australia, and we were having a discussion about the star rating system and how it provided sensible, reasonable information to older Australians and their families. At the time, there were a couple of really serious breaches that occurred, one in November where there were 3 breaches identified, and then again in May this year where a mechanical restraint breach was identified. At the time, we noted that the star rating on the website for Northgate was still at 4 stars. As of today, it's still at 4 stars.
Thanks, Senator. So the star rating, as you know, is generated by the department based on a range of inputs, and those inputs include where there's been certain compliance action taken. Our engagement with Northgate has involved working very closely with them to rectify and remediate the issues that we identified. So we have not been, we have not issued one of those kinds of decisions that would flow through to the star rating. I understand that that's a concern, and that the department has issued new advice about how future compliance actions will impact star ratings. That advice went out to providers recently. I think in recognition that currently the compliance rating is probably not picking up quite what it needs to, so that reform is happening, but it's being done by the department. So I invite, if one of the department staff want to speak to how the star ratings are being adjusted, that might be of assistance to you.
Well, I suppose the issue around the star ratings is that we're talking about a non-compliance in relation to mechanical constraints, which I think most people would view as a reasonably serious issue to be rectified. And we're sitting here some months later. I mean, the first breach has happened in November, the second breach happened in May. We're still sitting here in December with a 4-star rating sitting on that particular facility's star rating page, and yet you're really quick to whack a facility if they miss 1 minute of their care minutes, and will at best give a 3-star rating for somebody who's actually meeting their care minutes. So it just seems to me that there is a different rule when it comes to the care minute star rating as opposed to the other star ratings, of which are very serious and looked after by the Commissioner. I just don't understand why there is such a heavy-handed approach in relation to the star ratings when it comes to staffing levels, and we don't seem to take the same approach when it comes to issues of compliance in other areas.
So I think, Senator, probably the logic behind the 5-star ratings and where our home sits on those is probably similar between the two, in the sense of 3 stars is the benchmark of a provider meeting its obligations.
So non-compliance allows them to be above the benchmark.
So what we've had in the case of Northgate is, although there has been issues where the Commission has engaged and sought to rectify, none of the formal decisions that would trigger the compliance rating have been taken. The issues have been sought to be resolved without that occurring. What has changed with the new compliance rating that was announced on the 31st of October is a modification that takes into account the audit outcomes from the routine audits that the Commission will also undertake. And so to have a 4-star rating, you will need to have no non-conformance or only minor non-conformance that's been rectified found in that audit. And to achieve 5 stars, you'll need an exceeding grade.
So, Mr Day, can you see the ridiculousness of that argument in the sense that if you are meeting the requirements of care minutes, that you are rated at 3 stars, which sort of suggests you're mediocre. You're not bad, but you're not good. You're just mediocre. At a time when we've just found out that potentially we are significantly workforce constrained, if there's any validity to the information that's now been put into the public domain by the department, that you're actually requiring aged care homes to exceed the care minutes that have been determined as necessary by the department, but at the same time you are largely turning a completely blind eye to a breach in relation to mechanical constraints. I mean, I just cannot see how that can be reconciled as providing the public with credible information that would meet their public expectations in relation to any star rating. It just doesn't make any sense to me at all. But anyway, I would hope that we can actually have a resolution to this issue by the time we get back to estimates in February, and I don't have to ask this same question again, that you can either guarantee me that all issues have been resolved in relation to this particular issue, and I would hope that maybe the Minister might reconsider the overly punitive allocation of care of star ratings when it comes to care minutes. So to you again, Ms Hevram-Webb, just interested in relation to aged care clients or who self-manage their packages, in the new, in the current arrangements, how would that happen? So I would be, as a self-managed person, would be engaging a series of providers to provide me with the services as per my package. Is the expectation that the person who is self-managing will fund their care for a period and then seek reimbursement from the Commission? Is that your understanding of how it works?
Senator, so that's a policy question for the department, I believe. So we are not involved in the funding. We would only become involved if the person contacted us and had a dispute with their provider or something like that. So,
well, no, I'm just so have you not received any self-funded or self-managed clients who have been concerned about the requirement for them to pay upfront and then seek reimbursement?
I believe I have seen that issue raised. I'm just being cautious because I'm not sure it's been raised formally through our complaints mechanism or whether it's something I've seen through another source. But I have seen that issue flagged about needing to pay up front.
Yeah, because I mean, in the correspondence I've received, it says you'll need to pay the suppliers and then submit a reimbursement claim at the end of the month. We and the Commission are still working out how we can claim from Services Australia, so we're trying to maintain some form of control. And so what it says, so you're saying it is the responsibility of the person to pay your own suppliers and then they have to seek reimbursement.
I'm not sure what you're reading from, but
it was an email that was sent to me that there was some suggestion that the Commission was also trying to work out how this occurred, but that's obviously not to your knowledge.
So we are not engaged with how funding flows, but we will deal obviously with a complaint if someone's got an issue with the way their package is working and it sounds like that's an email from a provider. So that provider obviously has communicated that. I'm not sure quite why they've mentioned the Commission in that.
Yeah, no, it's just that they had, so there was also some suggestion that providers were creating their own spreadsheets and workarounds because they don't understand what the official process is when it comes to managing co-payments with Services Australia. Is that an issue that's been raised with you?
No, I haven't heard that issue. I mean, it's very early days, and most providers haven't yet been invoicing, so it might be an issue that arises, but it's not been raised with me.
Yeah. When I spoke to Services Australia last night, I asked them a series of questions, and not surprisingly, they handballed it all back to you guys. And just wondering, have the updated pricing structures for all providers been uploaded to My Aged Care?
I'll ask the department to answer that. My understanding is no, but they'll have the latest statistics. Yeah.
Senator Joshua Malden, Acting First Assistant Secretary, Reform Implementation Division. Can I just get you to repeat the question, please?
Just wondering if the pricing structures for all providers have been uploaded to My Aged Care?
No, not as yet.
Okay. So, Services Australia advised us last night that all letters had been sent out in the first 2 weeks of November, so everyone should have their letter in terms of what their co-contribution is. So can you confirm that older Australians have got 90 days from when they receive their Services Australia letter in relation to their fees before they're required to sign a new agreement in some form in order to maintain their package?
They do have 90 days, that's correct, unless they agree to sign it earlier.
Yeah, but they have up to 90 days, I should say. Yep, okay. So during that 90-day period, are older Australians kept on their current packages, like the pre-November one, or are they already transferred over in terms of co-contributions onto the post-1 July co-contribution requirements as per the letter received from Services Australia?
Senator Erica Barnett, Acting Assistant Secretary, Reform Implementation Division. So everyone who was on a home care package before 1 November has been transitioned to support at home. They would be under their transitional classification.
Okay, so I'm understanding in their transitional classification, are they obliged, or does that classification require them to pay the co-contribution as determined by the letter that they received from Services Australia, or do they remain on their existing contributions until such time as they sign their new agreement?
Senator, there's nobody who would be continuing to make contributions based on the pre-1 November arrangements. The income-tested care fee has no legal standing under the Aged Care Act 2024, so there's no one paying on that kind of model. And then there's questions around the timing of when they may begin based on when they enter into their service agreement.
Okay, so what I'm trying to understand is that on the 1st of November, everything changed from the old system to the new system. And so the co-contribution or the new financial arrangements that came into place on the 1st of November applied to everybody. Some were grandfathered, some weren't, but everybody was still required to sign a new agreement sometime from when they received their letter. So what I'm trying to understand is from the 1st of November, if somebody was receiving a service and the financial arrangements changed on the 1st of November, they've then got 90 days or however in order to sign their new agreement. What are the arrangements and where do the financial risk liabilities sit in the period of time between the 1st of November or them receiving their letter and the date they sign their new contract? Assuming that what would happen if somebody went through that 90-day period and then at the end of the 90-day period, after still receiving the services they did during that period, then decided not to sign the contract? I mean, how do you make somebody pay something without a contractual arrangement in place? So what is happening to older Australians who, quite frankly, are still very confused and unsure about the changes? What is happening to them in terms of the services that they're receiving? Are they being asked to pay up front? What happens if a service provider just continues to provide the services because they haven't signed the new contract and then they don't sign the new contract? Who wears the liability, financial liability there? How is this all working?
So we'll cover the scenario, I think, where a person does sign the service agreement first, and that a lot of that will come down to what the terms of that service agreement are. So it is permissible for providers to put a backdating arrangement into the clauses of that contract, and if they do that, they would be able to charge the participant the co-contribution for any services received. Sorry?
But what if they choose eventually not to sign the agreement? Where's the liability sit then?
It would sit with the provider in that case. If the person has ultimately not entered into the contractual agreement to pay a co-contribution, the provider won't be able to claim that.
So the legislation has enabled in the transition a 90-day period for the person to be able to sign onto a new arrangement. So you've made a statutory requirement that allows that to happen for the older Australian, but you've taken no responsibility for the potential liability to the provider of maintaining services during that period that you've statutorily required or enabled, that you're making the provider pick up the tab for that.
So the government would still fund the full amount of the government share of that co-contribution once that means assessment's happened. We know that for more than 3/4 of participants, they are full-rate pensioners, and so that's either 100% for the government or 95% of their independents and 82.5% of their everyday living services. But for that remainder, there is no provision for government to step in and cover a gap if a person doesn't sign the service agreement. That's correct.
So have you done any modelling as to understand what the potential liability might be there for the sector? I mean, particularly when we know that the sector is in a state of, constant change. They're completely reform fatigued. A lot of them are still running pretty close to the edge in terms of their financial viability. And through an action of the government, you have just increased their potential financial liability or risk, and you're just saying it's their problem to suck it up.
So I might jump in on this one. So in relation to the 30-day, 90-day rule, this was an intention to balance the rights of providers in terms of being paid for the services delivered, and also for the older person to not be coerced into signing onto a service agreement that would not be within their interests. So the 30-day, 90-day rule was something that we actually put through our aged care transition task force as saying, does this meet the pub test, or does this strike the right balance in terms of upholding the older person's rights and also the very real commercial needs of providers? So we accept that it's not perfect, but it is the best balanced transitional arrangement that we then tested with a large portion of CEOs, peaks, advocates, all those sorts of folks who have been around the industry for a very long time to reach that best compromise position. In terms of have we modelled the actual dollar impact, no, not at the outset, but we do seek continuous feedback from that transition task force and independently from its members around the statistics around how many people that they're still not seeing sign on to service agreements, how many that don't have those interim fees or backdating provisions in there, so they're not left out of pocket. And I don't have numbers to verify today, but the anecdotal evidence is that it is a very small number.
Senator Ruston, I just need to gauge how much more time you need. I'm just going to shift the call quickly to Senator Stewart and then come back to you. Is that okay? Yeah, Senator Stewart.
Thank you. I feel like I'm right in the middle of two microphones here, so I want to be helpful to Hansard. Just got some follow-up questions I didn't get to with my first round for First Nations elders. Thank you. So I'm keen to understand what progress has been made in ensuring First Nations elders receive timely assessments and access to care under the new supported home arrangements.
Thanks, Senator. I might ask my colleague Ms Tadipata to talk through the First Nations Assessment Organisation and where that program is at in its delivery.
Sorry, Senator. Yeah, so with our First Nations assessment organisations, that's, I guess, through the recent budget 2025-26, we reiterated government's commitment to deliver Aboriginal and Torres Strait Islander aged care assessment organisations as part of the single assessment system. As part of the pilot work that's underway at the moment, it is being navigated as a pilot to, a staged approach and phasing in a number of our. We're working with Aboriginal and community-controlled organisations as part of this first stage to understand how we can set up foundationally to support these types of assessment organisations working in to give our elders another choice in the system in terms of, going through that assessment pathway in response to the Royal Commission. So as part of this first tranche, we're working currently with 3 organisations that have been, I guess, contracted since August and working through, their needs to understand how we can onboard, build up their capacity in terms of what it takes to provide cultural, so we understand what they offer in terms of culturally safe assessments. It's then working through how we set them up foundationally to be able to deliver those assessments and be complying with the system. And so, we're just working through those steps right now. We're on track at the moment to ensure that, we're able to deliver comprehensive assessments in early 2026.
So, Senator, I might just add to Ms Tadipata's comments. The 3 organisations that we have engaged through this process represent a real diversity. So, as was articulated, it's a phased approach to implementation, quite deliberately so, to ensure that we're learning lessons from each phase of the implementation before we broaden out. There are many organisations that will not have undertaken assessments before, and so there's a degree of sort of mutual learning through that process and a training up with the system. And of course the reform of the system more generally. The mix of those organisations reflects, very regional, remote, metropolitan, and more sort of regional, we've got remote and very remote, regional and metropolitan. Apologies, I got my R's a little bit tongue-tied there.
And are you in a position to say who those 3 organisations are?
Yeah.
Yeah, so we have NPY Women's Council, which is, have coverage of, care in South Australia, Northern Territory and WA. I caveat that in terms of where they're located, there's complexities in terms of understanding their care and how they navigate with those regions. And in terms of the others, it's the Institute of Urban Indigenous Health, which is located in Brisbane, and then Rumballara Aboriginal Cooperative in Victoria.
As a Victorian, I'm obviously pleased to hear that Rumballara is in there. And do you? So it sounds like they're quite deliberate in how you've chosen them to learn different lessons from the pilots to make sure that we, to the best of our ability, get the settings right for elders, no matter where they live. That's right. And are there? And you might not be in a position to say right now, are there some early lessons you think that you're seeing in some of those pilots?
Yes. There's things we're still working through. We're trying to ensure as part of the pilot that we're meeting the organisations where they're at and wrapping around them with the support as identified as we work through the pilot with them. understanding that there is a commitment that we have to the broader public in terms of, you know, how we're delivering assessments, but we, you know, again, striking that balance between what the provider's needs are, and understanding, you know, how we need to ensure that in that response to the Royal Commission that we're meeting our requirements in providing culturally safe assessments. Understanding too broader assessments, you know, is also met under the needs of the mainstream program as well.
Thank you. I feel like there's quite a bit of noise behind you then with, I think, some excited people going to afternoon tea.
Will be all of us very soon.
Just moving on to so the first thing I would say, it's great you've got that kind of staged approach to making sure that we get those settings right. There is not a, you know, a one-size-fits-all approach, especially when it comes to First Nations elders. It's true for lots of older Australians, but particularly so for First Nations Australians. How is the government addressing the shortage of residential aged care beds in remote and very remote communities with high First Nations elders populations, and what results are we seeing from those measures?
I'll just ask my colleague Ms Milford to join us at the table. So there's been quite a significant investment, Senator, in the aged care capital assistance program, just while Ms Milford is getting set up beside me.
That's what happens when you have a government that cares about aged care.
Yeah, there's been a very significant investment in the ACAP program, and that has had a very significant, that has seen a very significant proportion of those funds directed to organisations that do deliver care to First Nations elders in those remote and very remote regions. And I'll just ask Ms Milford to.
Thank you. Sorry, everyone. Kathy Milford, Acting Assistant Secretary, Thin Markets Branch. Thanks, Senator. I think talking, earlier about the aged care assistance program, in terms of the First Nations component, the government has actually committed $339 million specifically to First Nations providers. So obviously that won't all be in rural and remote. It will be across the whole of Australia, but a fair proportion would be.
It was $339 million, I believe, Senator.
Yeah, thank you.
So that's across a number of basically, we had a non-competitive round specifically for our NATSIFAC providers, Senator, very early on with 100.
Sorry, just the acronyms there.
National Aboriginal Torres Strait Islander Flexible Aged Care Program. So that was $139 million directly to 4 providers to assist them. And then basically we've, through a number of rounds and additional non-competitive opportunities, we've delivered a number of programs, and also through all that there'll be about 108 new beds opened directly for First Nations residential aged care.
Excellent. Very glad to hear that. I'm getting the wrap up from the Chair, but thank you very much.
Thank you, Senator Stewart. Senator Ruston.
Thank you. Just a couple of single ones. The review of the supported resident supplement in relation to accommodation, when is that due to report?
Senator, I trust by that you mean the accommodation pricing review?
Yes.
Yes. It is, work is progressing on that. The review has been undertaking consultations. It is on track to be tabled in both Houses of Parliament on or before the due date next year, which is 1 July 2026.
1 July 2026. Thank you very much. And could I, thank you for the provision of this information. In terms of, you've taken so many questions on notice today, could I ask respectfully that you prioritise the answers to questions 7 and 8 in terms of your response to my questions, which these 2 you've taken on notice, as they apply particularly to budgetary issues. Obviously, all of my questions are important, but particularly 7 and 8 in terms of prioritisation. In terms of the co-contributions, is it correct that providers are allowed to waive the co-contribution that an individual might pay and just charge the government for the government allocated component of support at home?
Senator, we believe that there's no legal barrier to a provider doing this. We do know, however, that it does mean that the provider would receive only the government share of the service price.
Did you advise providers through the process of the legislative reform period that they had to have, their software providers had to build in the contribution component into the changes that they made to their software? Was that a direction given to providers?
I'm not aware of any such direction. Mr. Meldon may know more.
Sorry, Senator, if I understood your question correctly, it was whether or not software vendors had been instructed to build the additional contributions or pricing into their systems. Can you just repeat what you were saying?
Yeah, so when you work with providers in terms of building the new interface for the new supported home payments systems, did you require them or ask them and their software providers to build the co-contribution requirement into their systems?
Erica Barnett, Reform Implementation Division. So we issued a claims and payments business rules document to help software vendors understand the requirements that the department had given Services Australia around the system settings. We would have to take on notice whether we directed them to build that. They would be sourcing contributions information from Services Australia. Whether we mandated that they build that into their own solutions, we'd have to take on notice.
Yeah, it'd be interesting to find that, and also in the letter that was sent from Services Australia to providers / clients, what did that letter say in relation to supported home clients in terms of their obligations in relation to co-contributions? Because there seems to be a bit of a grey area in terms of whether they have to provide it. So is the situation that every time you get a bill from your provider that says 90% is contributed by the government and 10% is supposed to be contributed by the client, is there a requirement from the government that 10% is actually paid for?
So I think I'd have to defer to other colleagues on the actual legislative basis for that.
I think Ms. Traynor already said that we think legally you don't have to collect it, but it'll be up to the provider to deal with the financial consequences of that.
Okay, and what was the expectation that was created in terms of the communication with providers in contrast to the advice that was provided to clients around how these financial arrangements may or may not operate would be really helpful. Just quickly on CHSP, has the government, has the department done any modelling on how CHSP is to be absorbed into supported home?
Senator Julia Atkinson, Access and Home Support Division. The department does a whole range of modelling exercises to inform decisions by government, including this particular one. A whole range of different modelling has been done around that. As you'll be aware, the government has stated that CHSP will not roll into support at home before 2027. And further decisions around that are for government and they have not been taken yet.
Can I just clarify that? The decision of the previous Minister for Aged Care was that it would start on the 1st of July 2027. You've just used the terminology not before 2027. Has there been a subsequent decision in relation to that, or is that 1st of July 2027 still the start date of whatever comes next?
There hasn't been a subsequent decision. The minister, the announcement from government is that it won't occur before 1 July 2027.
Sorry, I just want to seek clarification. You're saying it won't occur before 1 July 2027 or it will occur on 1 July 2027. Is there some ambiguity around this?
No, I don't think there is, Senator. It has always been not before 1 July 2027. Could be after that. The government is considering what the appropriate way to phase into CHSP would be, noting that there are over 800,000 people who benefit from CHSP.
So how many people is the government or the department anticipating will transition from CHSP to support at home or whatever it is going forward? Because my understanding is that the decision of government was that there would only be one program and it was support at home. So I'm just interested how many people will come into support at home as a result of the ending of CHSP.
So, Senator, just to build on Ms Atkinson's and the Secretary's responses from before, the government decision was that the Support at Home program enabled by the New Aged Care Act would originally commence on the 1st of July 2025. That was obviously deferred for a 4-month period to commence on the 1st of November 2025. The public announcement has always been that the CHSP will not transition into the Support at Home program any sooner than the 1st of July 2027. So it really depends on any further decisions the government does or does not take in relation to the transition of the CHSP into the Support at Home program. At the moment, we've got about 838,000 CHSP clients, and so that is the group of people that we are looking at around transitioning into support at home in one form or another, depending on the decision of government around what option for transition that it takes.
So when the government made the announcement around the 300,000 new supported home packages that would be made available over the 10-year period to 2035, what consideration was given to the 838,000 or thereabouts of people on CHSP, given that, as we sit here today, the decision still is to transition the CHSP into support at home, the time obviously perhaps being a little more flexible than it once was. So I'm just trying to understand how 300,000 new packages over 10 years is able to deal with existing demand plus 383,000 other people.
Sorry, I just find my my notes on this one because this relates back to the demand for aged care over the longer term. So what we had was an assumption that by 2035 the Support at Home program would need to support 1.4 million people stay in their homes as they age. That constitutes the number of people that are in the Commonwealth Home Support Program at present, plus those folks who are in the Support at Home program now. And so if you bookend the government's public commitments around a 3-month wait time by the end of the second year of the program, and having those additional 83,000 packages rolled out in its first year, and then having the additional 300,000 people in by 2035. That was all modelled based on growth over time.
So you're saying the 300,000 is an additional to the 83,000?
So that's what the projected growth in the program is over the 10 years. So there's been a commitment to, that's how we're going to get.
Yeah. So I'm just trying to understand, was the commitment by government for 383,000 new home care packages? So not 300.
So additional 83,000 in the first year of the program, with growth in the program by 2035 of an additional 300,000 people. So if you take the number of transitioned clients today, you plus the remaining of the 63,000 that need to be rolled out by the end of the financial year, plus the 300,000, that gets you a figure of the total of those three. I don't have in top of my head, but that is the sum total that's been modelled.
Thereabouts, one imagines. Okay, but you've just said that you're expecting 1.4 million on the Support at Home program, and you've just outlined how you're getting to 600,000. So where would we find in any budget papers, what the provisioning is in terms of the costs for absorbing CHSP into supported home.
So the 600, just to clarify that further, that previous point, the 600,000, that's the number of additional places in the support at home program. The 1.4 is obviously that plus the 800 and something thousand that's currently in CHSP. Yeah.
So I'm just trying to understand. So you get the numbers, they add up. Yeah. I'm just trying to understand what the budgetary provisions and where would I find it in relation to the cost impacts of absorbing 838,000 or whatever the number happens to be when the transition in the next couple of years happens to be into supported home. Where do I find that? Because the amount of money that is allocated to CHSP is quite small in comparison to what you're talking about here. So where would I find that funding?
So the way that I understand it is that there are several different line items in the budget papers. So first of all, you've got expenditure on the Commonwealth Home Support Program that appears as part of broader Bill 1 expenditure. You've got your support at home line item that's in there, and then you've also got individual line items that are not included in the support at home appropriations. That includes funding for the assistive technology and home modification scheme, and it also...
Just understanding how this relates to the 800,000. I get the 600,000. Yep. I'm just trying to understand, is the 800,000 contained anywhere in the budget papers to date or any component thereof?
They should be split between Bill 1 expenditure assumptions in the support at home program and then different line items as well. I can get that for you on those.
That'd be great. Thank you. Thank you very much. So if somebody is on the Commonwealth Home Support Program, when it transitioned over, is it the intention that they go back into the national priority system or will they be automatically transferred over to receive support?
I don't think that decision's been taken, Senator. Yeah.
Okay.
And I don't believe that there's a national priority system for CHSP, but I may have misunderstood the question, sorry.
Sure. At the last estimates, the department said, I'm not sure whether it was Mr Pugh or not, but said that you were creating a milestone plan which will include some modelling on how the absorption of CHSP into supported home will work. So how's that planning going?
So that's all wrapped up in the options and modelling that Ms Atkinson referenced before.
Okay. And is that likely to be released in any interim way, or when will Australians, older Australians in the sector know?
There's been no decision made, so that's a matter for government to consider when they release that.
Okay, fine. Could I just ask a few questions in relation to and following on from this, from the NACA report that was just recently? Is that for you too?
I think there was a lot in the NACA report, so it depends on what the subject is, Senator.
Okay. Well, the report basically said that supported home will barely make a dent in the crisis for the existing home care wait list, and it won't be fixed under the current settings. So I'm just wondering if the department had a view about whether that statement was accurate, and if so, what is the response from the department about how you would address that? Because I think when the 83,000 packages were put on the table, that was about what the wait list was. Subsequent to that, it's no longer the case, and even at the end of this financial year, after the 83,000 packages have been released, I think your own projections say there'll still be 60,000 people on the wait list. So just wondering what your response to that is.
So for that particular item, appreciate that there has been some modelling done by the National Aged Care Alliance. I haven't seen the underlying assumptions that feed into that model. We have done our own modelling. We've got a program that is going to grow over time in line with projected demand for in-home aged care services in the community. We've based that on historical demand for the home care packages program and population growth. And one of the data points to point out is that over 2024 to 2044, the average year-on-year increase in home care demand is expected to be approximately 34,500 people per year, and that will result in approximately 1.82 million people seeking access to home care by 2044, and that is in line with the annual average growth rate that we're expecting of about 2.4% over this time. So, again, I very much welcome the NACA modelling, because I think it's good to have other people coming up with what their view of the world is so that we can test our own assumptions. I would just note that the demand projections and the costings for the Support at Home program and for future growth, they've all been verified and agreed to by the Departments of Finance and Treasury. So we do have our own sort of independent validation and checks there.
But I mean, we're all agreeing that there'll be 60,000, well, sorry, not we, you agree that there'll be 60,000 people.
I'm not sure that I did agree to that.
Yeah, I think that was your predictions from the departments.
I think the point that you made is the target the government's working toward is the average wait list that we'll be at by 30 June 2026, 27, sorry, which is we project that we'll be at a wait list of on average of 3 months at that point in time. So the government is not saying, the department's not saying there'll be a zero wait list at that point in time.
What sort of number did you... I was under the impression you'd said 60,000 on the 30th of June 26.
So we've got modelling that says that if you wanted to reduce the wait time by the 30th of June 2026, you would need to roll out approximately an additional 45,000 additional places. I'm not sure how that relates to the 60,000 though. Happy to take that one on notice.
Yeah, okay. Yeah. The paper also, highlights a call for a national outcomes framework. Is that something that the department is considering implementing in relation to, wellbeing, dignity, quality of life, not just staffing numbers?
My colleague, Mr. Powell, will come to the table to answer that one.
Senator Ruston, just checking, is this your last block of questions? Will be scheduled a break at 4 o'clock, or will you need a bit longer?
So let me finish this lot. I'll give in.
How many? Going to finish this block in 2 minutes?
No.
1 minute?
Well, it depends how quickly we answer it. So I won't be a few. I'll just be a few minutes.
Okay, no problem.
Yeah.
Thank you.
So has there been any consideration in relation to putting a national outcomes framework in place to actually measure things other than just staffing numbers?
Thanks, Senator. Travis Power, Assistant Secretary, Market and Workforce Division. We have a couple of different products that also step into this space. Of course, we report on a range of different metrics and indicators through our annual reports, which talk about, the certain outcomes and performance indicators for the department and the aged care sector. The department has a benefits management, benefits realisation framework as well that looks at the outcomes for the aged care sector and how that can be tracked over time. So obviously that's looking at the reforms that have happened over recent times and then looking at how perhaps they will track over time.
So can you measure those outcomes?
We can. There's a range of different ways you can measure things. We're looking at those kind of issues now. Of course, there's a legislated evaluation that was set up in the Aged Care Act to be tabled within 6 months of the 3-year anniversary of the Act. That has a range of sort of provisions in it for what should be assessed, and we'd expect that evaluation would speak to some of the outcomes that have been achieved and whether we've sort of hit that mark and shifted the dial.
So how do you measure quality care or quality standards or care standards?
So there's a range of different measures you can use. We're working our way through how we might develop some of those measures and make sure that we've got the right data to underpin that kind of assessment. Ultimately, that might be a matter for the evaluator if they're going through that process to work out how they might assess.
So we've just gone and put a massive new Aged Care Act in place with, more rules than you can jump over. And we don't actually know how we're going to measure the success of the quality outcomes of this rights-based act that seeks to put older Australians at the centre of the act. And you're telling me you're looking at potential measures. Surely we must have had some sort of framework by which we were going to measure these before we started.
So we do. We've set up the benefits for the aged care transformation sort of work. There were 6 benefits identified at the time. those benefits speak to a whole range of different issues around choice and control, around independence, around equity and access, around respect, quality care, and appropriate and available care. So they're the kind of the key issues that we're measuring. We look at different ways of actually tracking those things. Sometimes it's not simple to get a perfect set of indicators that would measure each one of those, so it's often an amalgam of different indicators to show whether we've achieved some of those benefits. But obviously some of those things take considerable time to flow through the data and the information, as we've made the changes. So that's why I believe the Parliament set the evaluation happen after 3 years of the Act's commencement.
And just follow from Mr. Power's comment, page 106 onwards of the annual report has the outcomes framework and performance measurement for the ageing and aged care, which includes activities to be assessed, such as the objective is to facilitate access to aged care services, and it talks about percentage of surveyed users satisfied with the service, percentage of surveyed users satisfied with the service provided by aged care. It's facilitate access to aged care services, and we have about 3 sub-performance measures under that with 3 criteria. It goes on with support older people to live active, self-determined and meaningful lives. And we've got a measurement there, maintain or increase the average residence. And we also have, there's many more of these, but also there's quite detailed qualitative discussion about how you would match that data up to the performance outcome. So we've done a lot of work on this actually, following on from Mr. Power's comments on how we can do that. We're always open for feedback, but there's a lot of information here in this annual report which goes to the outcomes of the aged care sector.
Yeah, I'll be very keen to obviously have a look at your annual report that was tabled late. I just, from the individual's perspective, there seems to be an obsession with staff and not an obsession with what the individual wants in terms of the dignity of risk that they're prepared to take.
Many of those measures, if you go there, are actually not staff measures. They're there are resident satisfaction measures, aged care satisfaction measures, and a sense of inclusion. We're always looking for better data sources, but it is very much outcomes from the perspective of the older person.
Okay, well, we'll look forward to seeing when those measures are actually reporting. Just quickly, when did the department first become aware that Telstra Health would not meet the October 1, 2025 performance milestone for MedPoint?
Did people hear the question? Yep.
Can we make this the last question we're going to have?
It depends what the answer is. If the answer is a good one, yes.
Excuse me, Chair. If it's going to continue, I'm happy to swap now with Senator Green.
Yeah, just that we will have to swap ministers, so...
sure.
So I'm happy to take a break now and swap if you want to.
Shall we...
Sure, I'm sorry, I understand the Minister may have something she has to do. I'll only be 5 minutes when you come back.
We can give you the call if we go to a break now. Give you the call when we come back.
Sure.
To continue this, and then if this is the last block of questions, yes, okay. So if we take a break, because the Minister does need to leave, we will have a short break of 15 minutes. So we can go to the break now and be back at 4:20, and then we will conclude those questions for Senator Ruston's, and then we will move on to the next outcome. So we'll be back at 4:20.
Peter's calling.
Thank you, Hansard. I'd like to welcome the Honourable Minister Nita Green to the desk this afternoon, replacing Minister McCarthy. We are still in outcome 3 and we will resume questions based on that, and I will hand the call to Senator Ruston. But before I do, we have an updated version of the questions requested by Senator Ruston, so I ask that they be tabled and circulated to the committee and to witnesses at the desk. Thank you, Senator Ruston. You have the call.
Yes, thank you. Would I be correct in understanding that MedPoint Telstra Health would be better asked in health?
I can answer that question now if you like, Senator.
Oh, okay. All right. So when did the department first become aware that Telstra Health would not meet its performance milestones for MedPoint?
Senator Daniel McKay, First Assistant Secretary, Medicare Benefits and Digital Health. The department became aware of some issues with Telstra Health's medication charts in late September, but the full extent of those issues didn't become apparent until we did further analysis with the Australian Digital Health Agency through the month of October.
Okay. Are you or is the department aware that MedPoint's system crashed when providers attempted to generate 3 months of prescriptions before the October 1 deadline?
Telstra Health did explain that to us when they put out messages to their customers, Senator.
Yep. And so have you investigated whether any medication errors or adverse events occurred as a result of this?
So we have been working with Telstra Health to make sure that they have worked with all of their customers to ensure no adverse events had occurred, Senator.
So have the department granted Telstra Health an extension until April 2026 to achieve conformance?
Yes, Senator. So the department has given Telstra an extended period to achieve conformance, and we did that for 2 reasons. One, because making them non-conformant and having to switch all of their customers to paper-based charts presented a significant clinical risk. And 2, we are doing some work with the Australian Digital Health Agency to understand whether there are enduring clinical risks that will make this product unable to meet conformance. That'll happen before Christmas, and if that does occur, then we will be working with Telstra Health to advise their customers to transition to different products. So we wanted to make sure there was plenty of time for that to occur.
So are there any contractual protections for aged care providers who invested in Telstra Health's MedPoint, and if it ultimately fails to achieve conformance? Can they get out of the contracts without penalty?
Well, that would be a matter for Telstra Health and those individual facilities. So we haven't gone and investigated what particular commercial arrangements they have with facilities. That said, we're not meeting conformance to be able to legally support prescribing PBS medicines, and the requirements around medication charts may well make their contracts invalid, but that would be a matter between the facilities and Telstra Health.
So how much direct funding, if any, has the department provided Telstra Health for MedPoint development?
So I'd have to take that on notice, Senator. I think we have, the department hasn't provided any money to these MedChart vendors, but I'll just have to check whether the Australian Digital Health Agency has.
Okay. Would you also be interested in the NRMC adoption grants that have been paid to aged care providers specifically for implementation, if you could get that as well?
Yes.
So did the department do any specific risk assessment regarding patient safety before notifying providers, I believe at the end of September, as you said, that they must cease using MedPoint?
The department did not notify providers, noting that they needed to cease using MedPoint. Telstra Health put out communications to providers which caused some of the issues you raised before, Senator. And then we worked with Telstra Health to give them an extension through to December, until the beginning of November, and then we've subsequently extended that through to April. So we were very conscious about some of the clinical risks of having a sudden cessation of those med charts, and wanted to make sure that we could prevent further clinical risks occurring with those customers of Telstra Health.
So does the department accept any responsibility for creating an unacceptable safety risk during this transition?
I think we were very disappointed that Telstra Health had known about the conformance requirements for over 2 years, along with other companies that provide these med charts into residential aged care, and they had not come forward and sought validation of their conformance requirements, Senator.
So with these deadlines now for conformance now extended multiple times, and multiple vendors still non-conformant, does the department have confidence that MedPoint is safe to use and not putting patients at risk?
So, Senator, we have been very clear with Telstra Health that there are a couple of areas which present some risks to residents that are using these charts, and they need to make those risks known to aged care facilities and community pharmacy. And we have put that obligation on Telstra if they want to stay. Telstra Health, if they want to stay in the market, they need to do that. They have done that and have been communicating with customers and the wider users of their systems about what are the types of things that we're concerned about.
So you're satisfied the risks have been mitigated, given the knowledge that you have around this non-conformance?
I think we're as comfortable as we can be. I can't guarantee what might happen in any of these med charts. There are always risks with med charts and medicines, but what we are being clear about is there are a couple of key known risks that Telstra Health has been communicating to their customers, and we have been working with Ageing Australia and others to make sure they're aware of those risks as well.
Okay. And just finally, Mr Comley, during the passage of the amendment bill, the Aged Care Amendment Bill, there was an amendment that was moved by Senator Allman-Payne in relation to the treatment of redress payments when it came to the means testing and assessments. At the time, we agreed not to just put the redress payment exemption into that particular part of the Act, that there was a broader discussion in relation to how redress payments were to be treated. So firstly, are redress payments, federal redress payments from the National Institutionalised Child Sexual Abuse, treated the same way for home care and residential care when it comes to assessments?
So I'll ask Ms Traynor to come to the table.
Senator, they're not treated the same at this point in time for residential care and support at home. That different treatment of the National Redress Scheme payments for the aged care assets test reflects the fact that that was a decision taken at a previous MYEFO before the support at home program had been designed. It's also reflecting the fact that we, in support at home, are reliant on the age pension means test for determining a person's contributions. So whatever the person's pension asset says their assets are is what is used for our contributions.
So you're telling me that in support at home, if somebody had a redress payment under the National Redress Scheme, that it would not factor into the determination when it came to support at home?
It would not be exempted from their assets. It would be from their income, reflecting that it's treated that way in the pension system as well.
But it wouldn't be from their assets?
Not from their assets, that's correct.
But it would be in residential care?
That's correct, yes.
Why is the inconsistency not being fixed?
It would be a matter for government to make a decision around that, and we do know that has
So
been
do any
considered.
state and territory redress schemes factor in the means testing of either support at home or residential care?
At this stage, the National Redress Scheme in the residential aged care assets test is uniquely treated differently compared to all other redress schemes.
Okay, Minister, I was wondering whether maybe you could take it on notice. I don't expect you to know the answer to this, but there was a clear undertaking given to me during the time when Senator Allman-Payne moved that amendment, and we agreed to not support that amendment on the basis that the government's intention was to rectify this problem. So if you could take on notice and come back to us as to where the government has got to in terms of rectifying the anomaly that Ms Traynor has just identified, that would be great.
I think it did come up last time I was here in estimates, and I think I gave the. I think I said to you that we're certainly considering it. I think that's probably a similar answer that I'll give to you again on notice.
I don't think I asked you. Maybe Senator Allman-Payne.
Perhaps it was Senator Allman-Payne. Apologies, but I'll take it on notice if there's any more information we can give you.
That would be great. Thank you. Thank you, Chair.
Thank you, Senator Ruston. That concludes outcome 3. We can say goodbye to all of the witnesses and agencies in outcome 3 of ageing and aged care. We'll take a short suspension while we move to the next outcome. Commence broadcasting again. We are now moving to outcome 1 on health policy access and support. I now welcome Senator the Honourable Nita Green. I know you were here before, Minister. Assistant Minister for Northern Australia, Tourism and Pacific Island Affairs, representing the Minister for Health, Disability and Ageing. Minister, do you want to make an opening statement?
No, thanks, Chair.
Okay, great. Thank you. I do have an update for the program in relation to the releasing of witnesses in outcome 1. The Australian Commission on Safety and Quality, the Australian Health Practitioners Regulatory Authority and the Australian Institute of Health and Welfare are all released from outcome 1. I now welcome officers from the Department of Health, Disability and Ageing in relation to outcome 1, health policy, access and support and cross-portfolio Indigenous matters. And I invite questions from Senator Steele-John.
Thank you. Hello everyone. Hello Minister. I'd like to ask some questions to begin with about dental health care and prosthetics, facial prosthetics for people who are survivors of head, neck and oral cancers. Somebody's making their way to the table, like that's them.
They're on their way. Thank you for asking.
No worries. Seems like we might just have to... Is there other people coming to the table for this? Oh. Saw a little bit of that expert sign language back there around it being a teeth question. All right, fabulous. I'll just let you get your name plaques ready. Lovely. Okay. So as I said, these questions go to dental health care and to facial prosthetics for those who are survivors of head, neck and oral cancers. On the 31st of October, Minister Butler mentioned in a press conference that there had been a review that has been undertaken by the department looking at the various different prosthetic schemes currently run by the states and territories. Could you confirm for us to begin with that this review has been completed?
Good afternoon, Senator. Liz Devlin, Deputy Secretary at the Department. Yes, I can confirm that that review has been completed.
Fantastic. And has the review, the report, as a result of that review, been delivered to the Minister's office?
Senator Ariane Herman, First Assistant Secretary, Chronic Conditions and Screening Division. At this point, the department's still considering the outcomes of that review. There is quite a lot of cross-government work that we need to do to consider the recommendations before providing advice to government.
Okay. So, on what date was the review completed?
Sorry, one minute, Senator. I'm just trying to grab my brief after running upstairs.
Senator, I believe it was provided to the department in September 2025.
In September? On what date in September?
Don't have that date in front of us. We'll have to get that for you, Senator.
If you take that on notice, that'd be great. So it's under consideration with the department now. How long is that? How long have you given yourselves to consider the review, recommend the report?
Senator, I don't believe we've set an internal deadline, but we do anticipate that we'll be able to provide advice to government fairly swiftly.
Sorry, I didn't pick that up.
Sorry, we haven't set ourselves a deadline per se, Senator, but we do expect being able to provide advice to the Minister fairly swiftly.
Okay. So when you say fairly swiftly, is this advice you're expecting to provide, say, in the first half of next year?
Oh, certainly, absolutely, the advice to government would happen in that time frame.
All right. Fantastic, thank you. So the report itself, once you've used it for advice to government, will it be made public?
Senator, that will be a matter for government.
Okay. Minister, can you provide any additional information there as to whether the report will be made public?
No, I can't. Sorry, Senator.
Okay. Thank you. Will the Minister be providing a response to the report once it's been delivered as advice to government?
I don't think the Minister's made a decision about how to respond, but I can take it on notice for you.
Okay. So the review itself, if you could take it on notice for us, if the Minister intends to respond publicly to the review, whether that review will be made public more broadly together with his response. If so, when? That would be much appreciated. The review itself was it conducted by departmental staff or by outside contractors?
No, it was outsourced, Senator.
It was outsourced. Who was it outsourced to?
KPMG.
KPMG, okay. And who was consulted as part of the review?
Senator, the review took fairly significant consultation across Australia, so state and territory governments. There was a range of non-government and consumer organisations that were consulted. That includes a number of our, so for example, Head and Neck Cancer Australia were consulted as part of the review to feed into the consideration. And there was also consultation across federal government agencies as well, so including with agencies like the NDIS and others.
Okay. Could you provide us with a list of stakeholders that were consulted as part of the review?
Yes, we can take that on notice.
Thank you. And can you share with us the terms of reference that were created for the review?
Senator, I'm not sure there was a terms of reference specifically for the review, but in going to market, we could share with you what the actual review was intended to look at.
The brief, yes, if you could take that on notice, that'd be great. Okay, thank you. Moving on to the National Oral Health Plan. I understand that there has been work underway on the creation of the new plan. There was some workshops undertaken in June and July. There was some stakeholder consultation that concluded in September, I believe. Now, the National Oral Health Plan is due to run from 2025 through to 2034, and we're now in December of 2025. So can I assume that the new National Oral Health Plan will be finalised and released publicly within this month?
Senator Mark Rodham, First Assistant Secretary, Primary Care Division. The plan's being finalised at present. We expect it to be ready for Health Minister's consideration very early in 2026.
Okay. So it'll be ready for consideration by Health Ministers in early 2026?
That's correct.
Once it's been considered by Health Ministers, what is the process from there?
Well, if it's adopted by Health Ministers, then it becomes the National Oral Health Plan and adopted for the next 10 years as the previous one was. So the current plan continues until it is superseded by the plan that will be considered by Health Ministers.
Okay. Look, I think I've got to express a little bit of frustration at the timelines here. I feel as though many people watching this would feel that given Australians are withdrawing millions of dollars from their superannuation every year to cover the cost of dental care, that people would look at this exchange and wonder why the department is dragging its feet on a plan that should have been finalised, released, locked in somewhere much earlier in this year, if not late last year, so that it could cover the 2025 period and actually begin putting stuff into place. What is actually taking so long? What is the cause of the delay in finalising such a vital health plan?
Senator, I wouldn't agree that the department or any jurisdiction is dragging its feet. There's been very extensive consultation on the plan that has required adjustments to the plan over time and gone through the relevant governance and consultative processes. And as I said, it will be ready for Health Minister's consideration very early next year.
Yeah, in 2025, when it's a plan that should have actually been concluded far earlier than 2025. This was meant to be its first year of implementation.
Well, the current plan goes until 2025, so yes.
Well, yeah, so it's not going to be ready, it's not going to be rolling out on the 1st of January next year.
It'll be very early next year, considered by Health Ministers, Senator.
Okay. Now, moving to the question of breast screening funding options and leaving the oral health plan for a moment. In August of 2025, the department website said that the final report and recommendations from the review of the Breast Screen Australia program were, quote, with all Australian governments for consideration. The final report will be released in due course, end quote. The report is not mentioned in the communique for the September meeting of health ministers. Can you provide an update on what action has been taken in response to the report and when it will actually be published? Who would like to give that one a go?
Senator, the breast screen review report has not been provided to health ministers yet. It is still under consideration by what's known as the Cancer and Population Screening Committee, which is senior officials from all the jurisdictions. As you would appreciate, the states and territories deliver the breast screen program, and they are currently considering both the review report and providing advice to health ministers about the recommendations of the report and what action and priority should be taken.
Okay. Now, I've got some questions for the TGA. I'm just going to do a little bit of a time check with the chair, though. How are we going?
Yeah, you've got about 5 minutes left.
Okay. All right. I'll get the TGA up for the beginning, and then we'll conclude in the next session. So my questions will go to yourselves in relation to Wild Child Laboratories, which manufactures the base ingredient for many of the sunscreens which have been removed from Australian shelves recently for not meeting their SPF claims. The ABC reported a discovery in October that the United States Food and Drug Administration, or the FDA, had actually placed restrictions on the import of Wild Child products for the last 3 years because of repeated breaches of the international quality standard in relation to manufacturing, known as the Good Manufacturing Practice Standard. Can I confirm that the TGA is aware of the FDA restrictions on imports from this manufacturer?
Thank you for that question, Senator. Professor Anthony Delawla, Deputy Secretary for Health Products Regulation Group. I would just clarify that there are a couple of issues that relate to sunscreen regulation, and we've had the conversation previously. I recognise there's a very specific question. I would just highlight that we have a number of staff with us, but they're in the waiting room downstairs. The staff member that we have who is responsible for the manufacturing quality branch is on her way up and will be able to respond to that question specifically. If you do have other sunscreen-related questions.
I have another question for the TGA, which is one standalone question, which I might then ask and then just pass the call back so that we can come back with the right people in the room. It's a question on vitamin B6, and it's come to me from community members in response to the TGA's recent decisions in relation to vitamin B6. You announced on the 25th of November a decision to further restrict sales of vitamin B6 supplements. The question that's come to me, however, is why are these restrictions coming they're not coming into effect until June, I believe, of 2027, when right now people are being exposed to and experiencing the health effects of dangerous levels of this vitamin in supplements and are unknowingly consuming unsafe levels of vitamin B6. So why the delay?
I appreciate that question. Thank you, Senator. I'll ask Mr Clark from our complementary and over-the-counter medicine branch to comment on this as well. But I would highlight that in making decisions around scheduling and availability, and I would also clarify that this was the final decision following a significant consultation. We do have to balance a number of factors. One is the risk of immediate harm to the public, and obviously that's something that was raised through the consultation. But the other is the ability of individuals to continue to be able to access products that are safe. And when we do have a delayed process of implementation, which is a transitional period, which we believe is appropriate to the risk presented, we also do undertake other mitigating measures to reduce the risk during that period. But I'll ask Mr Clark to add to that response.
Avinash Clark, Assistant Secretary in the Medicines Regulation Division. I don't have too much to add over what Professor Lawler said. Industry does need some time to transition, but in those intervening periods, we intend to continue with the warning labels that are required, asking with above 10 milligrams. There's a warning label that consumers should seek medical advice if they experience symptoms related to peripheral neuropathy, and we are considering what other communication campaigns we can run as well.
And we'll also, added to that, we will be engaging in a public education campaign to ensure that the nature, the consequences and the transition for the changes are understood.
Okay, thank you. Thanks, Chair.
Thank you very much. Senator Pocock.
Your time this afternoon. I wanted to ask about Commonwealth-supported places for medical schools. And I understand that new CSPs were recently awarded to medical schools across the country, and that UTAS in Lonnie received 20 CSPs for their medical school as an election commitment from Labor. I was really quite shocked to find out last week that not a single extra CSP was given to the ANU Medical School as part of the recent grant round. I was wanted to find out why no CSPs were awarded to the ANU.
Hi, Senator. Eliza Strapp, First Assistant Secretary, Health Workforce Division. The grant round for the additional CSPs was a highly competitive process. We had more applications from universities than got CSPs. I can run through the criteria that we use to assess the CSPs, but and really, essentially, it was highly competitive, and we had to, I guess, look at all the criteria for the CSPs. I'll just bring up the CSP criteria. And so it was highly oversubscribed, and the considerations we looked at was their capability and their capacity, value for money, community impacts, innovative approaches, and past and current performance of the applicants. We found 10 universities successful, and they've been awarded 10 CSPs. I would say for those universities that weren't successful in this round, we will be holding another round in 2026 for an additional 50 places. So there is opportunity, but essentially it was a highly competitive round.
I'm keen to come through some of those details, and to assist us, I'd like to table a few letters, one from myself, one from the ACT government, one from the New South Wales government, and a piece published in MJA Insight Plus, if I can do that. Yeah. And just in terms of understand it's competitive, but presumably this is to help solve the issue around GPs. The ACT has the lowest, Canberra has the lowest proportion of GPs population out of every capital city. Yep. Parts of the ACT have so few GPs that the Grattan Institute says that they're a GP desert. The ACT has the lowest bulk billing rates in Australia. The New South Wales government believes that the ANU Medical School should receive more CSPs, saying that, and I'll quote from this letter, "Local graduates have made an important contribution to the medical needs of the greater region and will continue to form part of the solution to our health workforce challenges." The ACT government says that they need 33 additional interns each year by 2041 to meet growing demand in our hospitals and ensure that there's a pipeline of new GPs entering the market. The ANU is our national university with a track record of training new GPs. And in fact, as a proportion of their graduates, they are the 4th best university in Australia in graduating GPs. Far more as a percentage choose general practice at the ANU than most universities. And when it comes to those GPs that then go to MMM 2 to 7, I think they ranked 5th in the country. So on all of your criteria, they would have to be in the top 10. And so I'm just trying to understand, like, how, if you tick all those boxes, are you not in the top 10?
Senator, I can't go into the individual, assessment criteria or what we assess an individual university about in our assessment process. The best answer I can give you is what I gave you, which was we look at a range of criteria and the universities that were selected were rated good, or they got a score rating of 16 out of 20 and above. But unfortunately, I can't go into the reasons why ANU's particular rating in that circumstance and why they didn't get additional CSPs.
Well, I think you're going to need to, because you have a university that ticks those criteria that you've just given me, is the 4th best in the country in graduating GPs as a percentage of medical graduates, the 5th best in the country at graduating GPs that then go and work in the areas that this government says we desperately need GPs, and yet you don't even see them in the top 10 to get 10 extra CSPs. So where have they fallen short? How did they drop to top 10?
I can't go into the reasons why.
Why not?
Because I think it's a assessment criteria. It's not. We don't disclose what people's assessment is.
To answer the question,
Sure.
I think the interjections are not helpful at this stage of the evening. So if the witness can complete her answer.
Yep.
Penny Shakespeare, Deputy Secretary Health Resourcing. I think it would be possible for the ANU to discuss with you the feedback on its individual application. I don't think it's possible for us in the department to do that, given that we've had a competitive tender process.
I just don't see how competitive it could have been if you have a university that is ranked number 4 for graduating GPs, number 5 for graduating GPs that then go and practice in a regional area, and you're saying it's not in the top 10. Like, what's going on here? If we're trying to actually meet unmet need, surely you go with medical schools that are actually going to graduate, one, GPs, and there's a number of medical schools who've got extra CSPs who don't graduate a significant percentage of GPs. And the medical school that actually graduates almost the most regional and rural GPs.
Senator,
I don't understand how they could have missed out.
Senator Mike Pope, Acting Assistant Secretary, Workforce Training Branch. I'd just add that it certainly was a competitive grant process. There were 20 eligible applicants through the process, and 10 were supported. The successful universities were judged, or all universities were judged on the basis of their grant applications. So we certainly took into account information including sort of their track record in graduating medical students who go on to follow careers as GPs. We took into account their plans to do more of that, and we took into account what they put forward in their bid in terms of the innovation that they were planning, how they were going to support those students in terms of providing clinical placements and supervision, putting in place a curricula that was supporting interest and in primary care careers, and an academic staff. So there are a number of considerations as we considered each application, but the applications were absolutely considered on their merits, and that was the basis for the advice to government, to the decision makers from the Selection Advisory Committee, which included representatives from both of the GP training colleges, GP colleges, the Royal Australian College of General Practitioners and the Australian College of Rural and Remote Medicine, as well as myself and a representative from the Department of Education. So it was a rigorous process, and it was a competitive process, and not all universities could be successful with this round, but there is a further round to be undertaken for an additional 50 CSPs from next year, and the ANU will have an opportunity to apply through that round.
So, Mr. Pope, I assume you live in Canberra.
I do.
How on earth are we going to solve this problem if we can't get more GPs in this town? And we all know that the way to do that is to actually graduate people where they live and where they want to work. And so how are we going to fix that?
Well, I'll note you're absolutely correct in the sense that ACT has a lower number of GPs per head of population than other equivalent metro areas, but it actually has a higher number of medical student places per head of population than other capital cities around Australia. So part of the problem, I think, is more about retaining students who then graduate within the health system within the ACT, rather than specifically how many students we're graduating through our universities here in Canberra. So I think it's a broader problem, and it goes to attracting and retaining doctors and within the ACT once they graduate, and convincing them to take up careers in primary care.
Yeah, but
Senator Pocock, I'm just flagging that I need to shift the call, so this will be your last question.
Can I get two questions?
Okay.
Thank you.
2 last questions.
But Mr. Pope, you'd know better than most that that is the challenge for any regional area, is people go there for a medical placement and then they go back to where they're from. And so you can say, yeah, we've got more people actually doing placements here, but all the evidence suggests how you actually fix it is have people from there graduating, staying. Minister, maybe this is a political thing. We've seen your government, without any competitive tender process, just say to Tassie, another small jurisdiction that struggles when it comes to their health system in terms of costs and medical professionals. You said, well, he had 20 CSPs for Tassie. The ACT is pretty similar when you look at low bulk billing rates, lack of specialists, all the other things. How come How come you sort of dig into the pocket for Tassie but not the ACT?
This was a competitive grant process.
No, I'm asking about the uncompetitive.
No, I know. And you asked me if it was a political process, and I'm saying it wasn't. It was a competitive process.
No, I'm asking about the 20 CSPs.
Based on recommendations.
So she's answering a different question.
No, I'm answering your question. You just don't like the answer.
I think you've asked the Minister a question. I think it's
sure. Go for it, Minister.
Within the rules to allow the Minister to respond.
This was a competitive grant process. Recommendations from a selection advisory committee, which, as the officials said to you, took outside advice from health professionals. There are universities that, in addition to ANU, that missed out, some from my part of the world, who of course would also be disappointed. But there was 100 places on offer. There will be a further 50 places in the next round. And I know that that will also be a competitive process. And I know that there are lots of universities who will apply, and will continue to create CSP places for universities around the country where this continues to be a very in-demand program for a problem that is a nationwide issue.
Thank you, Minister. My question was actually about the election commitment of 20 CSPs for Tassie. That's well justified. I'd say the same thing is justified for the ACT if you actually look at bulk billing rates and GPs. How come the government is giving CSPs, not through a competitive, this is an election commitment, you know how these things work. Why for Tassie and not the ACT?
Well, because they're two different processes, Senator Pocock, and you know that. And I've walked you through the process we've gone through with these 100 CSP places. It is, of course, open to the ANU to apply for the next round of CSP places that are available.
Okay.
I'm shifting the call. Thank you, Senator Pocock. Senator Ruston.
Thank you very much. Why don't I go to where I'm supposed to be? What are the latest projections for annual hospital expenditure growth over the next 5 years?
So we're just conferring here, Senator, because we don't have projections for the next 5 years for hospital expenditure growth.
So how are you negotiating the NHRA if you don't know what you're negotiating on?
Well, when we negotiate the NHRA, which I thought, by the way, was a whole of portfolio issue, we have scenarios that could be the level of volume growth and price growth, but we don't actually forecast that over the next 5 years.
Okay. So what's the current status of the negotiations?
Well, the Commonwealth's negotiating in good faith with the states and territories.
Are you still expecting the negotiations to be completed by this calendar year, as you advised me at last estimates?
The Commonwealth is hoping to conclude negotiations, but that requires both parties to agree, so you can never be certain when they finish.
Okay. The Prime Minister wrote to the states and territories indicating that their hospital funding would only be honoured, and I quote, if they, according to media articles, reined in hospital spending. Is it possible for that letter to be tabled?
I think questions in regards to the Prime Minister should be directed to PMNC.
Okay. You couldn't take that on notice for me for the Prime Minister?
Well, the question would have to go to the Prime Minister and Cabinet.
Okay, well, I'll put it on notice for them. At the December 23 National Cabinet meeting, the Prime Minister committed to lifting the Commonwealth share of hospital funding to 42.5% by 2030. Is that correct?
No, that's not, Senator. It's not complete. The Prime Minister said that the intention was to get to 42.5%, but subject to annual caps.
Annual caps?
Yep.
So my understanding from the subsequent correspondence, not the communique, which had no mention of caps in it at all, that the annual caps on Commonwealth Hospital contributions was to be abolished and be replaced with a cumulative cap for the first 5 years. So you're saying that's not correct?
No, sorry. Let me go back a step. The communication was that there is in fact an annual cap, but it is different. The offer that was made by the Commonwealth is different to the preceding agreement, the current NHRA. The current NHRA is a cap based on what your expenditure was in the previous year. This is a cumulative cap, so it's based on annual caps. But if you haven't used up the cap in the 1 year, then you effectively have that cap carried over and increased in the following year over the 5-year period.
So when was the determination for the more generous cap to be determined?
The more generous cap was in the offer from December 2023.
And so where is that? What is the more generous cap? Because it's really hard to get an annual cap or a cumulative cap if we don't actually know what the cap is.
That was being clearly communicated to states and territories at the time of December 2023, and there's been a subsequent offer by the Prime Minister in the letter that you've alluded to, which lays out the cumulative caps that have been offered to the states and territories for the period. Going back a step, there was a 1-year extension deal, so that originally the plan was to start from 1 July 2025. There's a 1-year rollover from 1 July 25 to 30 June 2026. The Commonwealth is currently negotiating with the states and territories on the basis of cumulative caps that would apply for the period 1 July 2026 to 30 June 2031.
What was the basis of changing from an annual cap to a cumulative cap when the states and territories have never yet missed their cap?
Well, that's not actually correct, Senator. I think over the period in the past, some jurisdictions have been below their 6.5% cap in previous years. And in particular, my recollection is because of, particularly in COVID, but not just COVID, there were jurisdictions that didn't reach their 6.5% cap. And so one of the things that they welcomed in that original deal was the idea that it would be a cumulative cap, so that if you had a low year, it wasn't a use it or lose it, it was a cumulative cap.
So the catch-up growth premium in the first year, was that expired by the additional funding that was provided in 25-26, or is that catch-up growth premium to be applied to the first year of the new agreement?
So that's a matter of negotiations between the Commonwealth and the states. The 1-year rollover deal provided a catch-up amount of 12.3% growth for the 25-26 year.
Okay, so there could be a subsequent catch-up, but it's part of the negotiations.
It's part of the negotiations.
Okay, so there has been.
But sorry, Senator, in the offer to the states and territories, the 12.3 has been included in the base of that offer to the states and territories.
Okay, so there's been much speculation that annual hospital expenditure growth cap of 8% is on the table. Can you confirm that?
I can confirm that.
Okay. So if annual hospital expenditure growth exceeds 8%, so if growth is 8% and the cap is 8%, does that get you to 42.5% Commonwealth funding by 2030?
Senator, essentially, in all of this, it's the difference between the cap and the actual expenditure drives whether the Commonwealth contribution increases or decreases. If you had, and I'm reluctant to sort of go into, if that, but...
Well, no, I'm trying to understand. As we're sitting here at the moment, the Prime Minister has categorically stated in a communique in 2023 that the federal government will provide 42.5% by 2030 and 45% by 2035. Subsequent to that communique, there seems to be this 8% more generous cap has been thrown on the table. I'm just keen to understand in the calculations in terms of hospital funding, if the growth is 8%, Does that equate to 42.5%?
So Senator, we can kind of repeat this as many times as you want, but the Prime Minister did not categorically state that it would reach 42.5%. Said it was an intention to reach a CCR of 42.5%, subject to the funding caps, which in I think the press conference afterwards, there was a comment made that there'd be more generous caps than there was in the past, but they would still be caps. The caps prior to this was obviously the 6.5% annual cap under the NHRA.
So do you have that communique with you?
I don't have it in front of me.
Okay, I'll come back to that because I think you'll find when you read the communique there was no mention of caps whatsoever.
Senator, we had this discussion last time.
Yep.
There's a question what's in the communique, there's a question what has been in subsequent press conference, there's also a question about what are in other documents that are between the Commonwealth and states, which included more detail of the agreement, which wasn't in that communique.
Okay. The Prime Minister's press release quite categorically, and it have just been said, it quite categorically said that it was 42.5% by 2030. So I'm just keen to understand, on that basis, what was, how did you come up with 42.5%? How did the government come up with 42.5%? That was what was clearly said in his press release. There was no mention about caps. So how did you come up with the 42.5%? Was it based on an 8% growth rate?
My recollection, actually, Senator, is there was a midterm review of the NHRA, which was conducted by Rosemary Huxtable. It recommended moving away from the previous funding arrangement, which was a base plus growth arrangement, to a situation where you had a glide path of the CCR. I think that review actually did recommend moving towards, over time, the 45%, but it was subject to the caps to put some bounds around the potential financial exposure to the Commonwealth should you be in a situation where hospital expenditure growth grew significantly faster than had been anticipated.
So when was the first time that the communique in the Prime Minister's press release, which said, and I quote, National Cabinet endorsed Commonwealth increasing National Health Reform Agreement contributions to 45% over a maximum of a 10-year glide path from 1 July 2025 with an achievement of 42.5% by 2030. That was in the communique and that was in the media release, and there was no mention of caps. So obviously quite clearly the states and territories understood that was the case, because obviously if they were aware of caps they wouldn't be out there at the moment making the accusation that the Commonwealth was trying to renege on the deal, and that's exactly what they're saying. So when was it first made publicly aware that there was conditions around the 42.5 and the 45%?
Senator, have to check, but my recollection is that actually in the press conference mention of the caps was made, and it was clearly aware to the states at the press conference. Okay. But it was also clearly known to the states and territories it was subject to a cap.
Okay. Well, clearly there was no public communication of that, and so I'm just interested in when it actually publicly came out. So what I'm trying to understand here is, where did the 42.5 and the 45% come from? If you were saying everything was subject to this, that and everything else, why didn't you just say that you were going to increase the cap from 6.5% to 8%? Where did the 42.5%, how was that calculated?
Well, as I said, I believe that number was flagged in the midterm review, the 42.5 and 45%. Mm. At the time that the NatCab deal of 2023 was concluded, it was envisaged that you would be able to meet those CCR rates within the caps that were proposed at the time.
Okay. Well, I'll check the press conference to see what was in there. So in the correspondence, states and territories...
Before you go on, yep. Senator, so I've just been handed the communique, which has a paragraph in it National Cabinet endorsed the current 6.5% funding cap being replaced by a more generous approach that applies a cumulative cap over the period 2025 to 2030 and includes a first-year catch-up growth premium, which I think you were mentioning before. So the communiqué may not have published what the caps were, which had been discussed with states and territories, but clearly included the fact that there was actually a cap which would apply to the constrained potentially meeting 42.5 or 45%.
So why did the Prime Minister make a commitment to 42.5% and 45% when it was conditional?
Well, it's not an unusual thing, Senator, to make a commitment but also have caps and limits in case circumstances differed, and that would lead to too high a fiscal exposure.
Sounds like a headline to me. In correspondence to states and territories, the Prime Minister has of recent times indicated that they must work to reduce growth in hospital activity. What specific hospital activity does the Prime Minister or does the Department advise the Prime Minister should be reduced?
So first of all, Senator, you're quoting from part of a letter that hasn't been made public and that doesn't have the totality of the letter, which would include other things. But if you're asking what the...
All right, can I ask you then, Mr Comley, did the letter that the Prime Minister sent to the states and territories ask them to work to reduce growth in hospital activity?
I'm not going to provide commentary on the letter that hasn't been made public. What I would say is that the context of the negotiations, which again has been happening in good faith between the states and the Commonwealth, and so I don't think it's really kind of appropriate for me to conduct the negotiation with the states and territories through here. But the context of the discussion with the states and territories is both on the hospital side and on the disability side that there is a need to ensure there is some control of expenditure to make sure the overall system is affordable. So the context of the overall deal was, for example, to have a increase in the potential contribution of the states and territories to the NDIS to 8%, and included caps from the Commonwealth side, and indicated that for the outcomes to be achieved in terms of the CCR, it would require moderation in both price and potentially volume growth. And when we think about it from a departmental perspective, we would think about things like trying to limit low-value care and have high-value care, ensuring that there are efficiencies in the way hospitals operate as matters to look to constraining expenditure.
The states and territories have stated that increases to hospital expenditure are largely driven by factors outside of their control, so population growth, ageing demographics, medical cost inflation, obviously aged care and bed block. Does the government, Ministers, does the government accept that a lot of the cost increases that are incurred in hospitals are outside of the control of the states and territories?
Senator Ruston, just flagging, I will need to shift the call after the Minister answers. Because we have a full house now, so we've got to run a tight ship.
It's a full house. Senator, without the context of that reference of yours in front of me, I think it goes to, rather than costs outside of the control of the state, territory or the federal government, it's about making sure that every dollar we spend in the health system is good value for money. And I think that that's the way we're approaching these negotiations, in good faith with the states and territories, and hopefully, they are obviously very keen to drive a hard bargain. That's why they're raising these issues. We are also keen to make sure that there is that we're able to reach this agreement, and we're working towards that, and hopefully it'll be finalised this year.
So the Commonwealth has reportedly blamed cost increases on states' decisions, including nurses' pay rises. So I'm keen to understand, is the government really saying that nurses' wages are the problem here?
I'm not familiar with that reporting. I'm not sure if it's true or not. I won't make any commentary on it.
Shift the call now. Senator Ruston. Senator Payman.
Thank you, Chair. Good afternoon. My questions are just around the tobacco excise. I'll just wait for the officials to come to the table. So I just wanted to know, does the department have any data on the effect the tobacco excise is having on public health?
Thank you, Senator. So the department routinely looks at both smoking and vaping rates across the population. So if you mean, do we look at smoking rates? Absolutely we do. There's a variety of data collections that we monitor to check smoking rates in Australia.
Is it the view of the department that the rise of black market tobacco is having a negative impact on public health?
Senator, I would suggest that illicit tobacco has a range of impacts. So you'll hear comments from other portfolios about the significant involvement of organised crime. So there's obviously extreme social issues. We have experienced in overseas countries that the link between sort of public health and illicit tobacco is perhaps not what it is sometimes made out to be in Australia. There is very strong evidence that the World Health Organisation supports tobacco excise as a very strong public health measure. So from the department's perspective, we really do think that encouraging people to give up smoking and reduce demand is one of the most effective public health measures. Reducing people's desire for tobacco is what we're aiming for.
We definitely appreciate that we want to reduce people's desire to smoke, but in 2024 to 25, smoking rates in WA specifically rose to 12% from 10% in 22-23, and that was the first rise in 30 years. Is there any analysis or reasoning the department could potentially provide the committee on why this rise could have occurred?
Senator, can I ask what data source you're using for this information? Sorry, Trish Clancy, First Assistant Secretary, Population Health Division.
I can get that for you. This was widely reported over the month of October, but I can get the exact source for you. But
I can answer in general.
Yeah, this is specifically for WA, so I'm not talking about the entire country, but I guess asking you guys as the Department of Health to give an indication of why that rise could have taken place.
So over the last 25 years, we've seen a decrease in smoking in general. That does not go in a straight line. You tend to see slight ups and downs within the trend of decreasing. It is not the first time we've seen either a plateau or an increase in WA or other states. It is a reasonably small number. It obviously causes us concern. Any indication of smoking rates rising are of concern, and we're constantly monitoring to see that we have the most effective policies in place to make smoking unattractive and make it easy to quit. But one data point isn't enough for us to confirm a pattern. It's obviously a concern, but it isn't a pattern at this point.
Is there any analysis the department's doing to measure whether this is developing into a pattern across other states, or?
So some of the highest quality data we use in this space is the National Drug Strategy Household Survey. That's done once every 3 years. It's currently data's being collected this year. Results will be available next year. So that will be a very good quality nationwide set of data that will help us look at the trends over time. And that's what we've used for many years.
Do we have a timeline or date when the report's going to be released next year?
I'll find that information for you in the next while.
Thank you. It was interesting to hear Premier Roger Cook, who was quoted in the West Australian on 20th of October about these figures in particular, and when these figures were released, saying that migration was the cause of this rise. Is the department aware of any particular surge of migration that could have caused this rise?
We are not.
No. Do you know, is the department aware of any sort of particular migration scheme that was established which gave priority to applicants who smoked?
We are certainly not aware. If there was such a scheme and we were made aware of it from a public health perspective, we would obviously have commented with our colleagues who set migration policy.
And I know that we're not to ask departments of opinions, but with your expertise and background, would you comment and say that migration has anything to do with the rise of smoking, not just in WA, but anywhere in the world?
It's extremely hard to call that without having evidence or data in front of me, and it's not evidence or data that I've ever seen.
Does the department believe that current tobacco excise settings from a public health perspective are appropriate?
So World Health Organization advice is that excise is a good tool to make tobacco less attractive and to pursue the public health goal of reducing consumption of an addictive good, tobacco, that is unhealthy and kills people.
Is the department aware of the rise of illegal tobacco being sold really at very low prices to people without requiring necessary any form of ID?
We are aware of illicit tobacco in the country, yes, and we work closely with our colleagues across government on this topic, particularly the Illicit Tobacco and E-Cigarette Commissioner.
On notice, can you please provide data held by the government on smoking rates over the last 10 years and lung cancer rates over the last 10 years?
Yes, we can.
Thank you. And I'm also curious to understand, where does WA stand relative to the rest of the country in terms of smoking and lung cancer?
The country is, in general, within the same kind of band of numbers. I will need to take I'll need to get back to you on specifics about how WA stacks up versus other states. There are no massive outliers that I'm aware of.
Does the department expect smoking rates to continue to rise?
Well, we're not in a position to say they have risen yet. We have some indications of potential rise, I would say, rather than we know they've risen. Our hope is that the sequence of policies that we've put in place and continue to put in place, there are measures that went in July 1 this year, would continue to decrease smoking. We spend our whole lives worrying it might go back up. That's kind of our job, to worry about it. And so we're very mindful and monitoring constantly, kind of periodically.
And the survey that you mentioned that would come out next year, would that give an indication of whether there's been a rise or
Yes.
what the trends are? Wonderful. Great. Thank you, Chair. Thank you.
Thank you, Senator Payman. Senator Steele-John.
Thanks very much, Chair. So I'll return to the TGA at this point, and I might take my line of questioning from the top so we're all on the same page. Just give Professor Lawler a chance to get to the table. All right. Okay, fantastic. So, as I was saying, my questions are in relation to Wild Child Laboratories. They manufacture the base ingredient that is found in many of the sunscreens that have been removed from Australian shelves over recent months because they do not meet the SPF claims made on the label. The ABC in October discovered that the United States Food and Drug Administration, or FDA, has in fact placed restrictions on the imports of products made by a Wild Child laboratory for the last 3 years. So this is not a new phenomenon. This has been since 2019. They have had these restrictions in place for a very simple reason. In the FDA's view, Wild Child Laboratories has breached on many, many occasions the good manufacturing practice standards. These are the globally recognised international standards for good practice in manufacturing. Can I confirm, first of all, that the TGA is aware that the FDA has placed restrictions on imports from this manufacturer?
So thank you for that question, Senator. Given that this relates to good manufacturing practice and our manufacturing quality regulation role, I'll ask Ms Hongjia Jin, who's one of our branch heads, to respond.
Thank you. Hongjia Jin, Assistant Secretary at Medical Device and Product Quality Division. Thank you, Senator, for your question. So the simple answer is yes. Yes, TGA is aware of that input alert. I do want to add a bit more information that international regulators do come to Australia to inspect our Australian manufacturers from time to time, but they do not routinely share that information with the TGA unless the issue is significant. On this occasion, the FDA did not share that information with us. We actually found the input alert information through the publicly available information. And it's also issued based on the inspection of a facility that's no longer in operation.
Thank you. So let me clarify. When precisely did you become aware of the FDA's restrictions upon products from this manufacturer?
Let me check the dates.
Yep.
We understand the FDA placed Wild Child Laboratories under input alert in October 2022. That was based on the inspection of a facility initially in 2019, and that was for the old facility. So we found that information through the public available information in October 2022.
In 2022?
Correct, yeah.
Yes. So you became aware of that in 2022?
Yes.
Okay. Can you confirm, please, that the TGA did an inspection of the manufacturer where it looked at whether the good manufacturing practices were being used?
Sorry, I didn't hear that question clearly.
So I'll just do it again, that's okay. So I believe you've confirmed, I just want to get you to state it publicly here, that in September of 2025, the TGA undertook a investigation or audit of Wild Child Laboratories, and that audit or investigation was to assess whether they were in compliance with good manufacturing practice.
Correct. We did conduct an inspection in September this year.
Yes. And you've put out a statement saying that you found, quote, I'll bring up the precise language you've used, that when you conducted this investigation in September, you found that while you found some non-serious GMP deficiencies to be identified as part of that inspection. Is that correct?
Correct.
Yes.
It's not uncommon for us to find deficiencies during GMP inspections, so this is quite common.
Yes. So what were the deficiencies that you identified?
I don't have the details with me at this point in time. We're still working with the manufacturers, so we've identified deficiencies, and according to based on our practice, which is consistent with most of the international regulators, we issue deficiencies. We provide an opportunity for the manufacturers to provide their corrective actions. I don't have the details with me at this point in time, but can provide that on notice.
Can you take them on notice,
Yes.
please?
So if I might just add very briefly, Senator, the process of licensing and certification, quite similarly to accreditation actions, have a risk-based approach to them. And as has been highlighted by Ms. Jin, we often find deficiencies that do not relate to safety concerns. And so in working with manufacturers, there are obviously serious deficiencies that raise to concerns and corrective actions might be required. And then there are others that are identified as quality improvement opportunities. And so there may be a number of issues or deficiencies, and as has been highlighted, we'll take on notice to provide what we're able to in that respect.
Yeah, I understand that, Professor Lauder. I think my concern is it seems to be we have a company with a systemic problem, given that on the 5 occasions it was reviewed and investigated by the FDA between 2019 and 2024, each found serious breaches that resulted in them being on the self-described red list, where it has stayed since 2022. Now, you've said in your statement that you haven't been able to find any breaches that would be consistent with the inaccurate SPF claims or the inaccurate SPF nature, the inadequate nature of the substances found in these sunscreens. I think you've said, and I'll find again the precise word so that I don't verbal you. You've said we did not identify manufacturing issues that could explain the low SPF results. Is that correct?
Correct.
Okay. Now, the question I have on my mind, and it's on the mind of a number of international experts that have looked at this, is how you have come to have such a different view than the FDA audit report, which has been uncovered by the ABC, which found, quote, serious breaches in the manufacturer's quality control processes and failures to investigate product faults that may have affected the accuracy of label claims. How is it possible that two investigations undertaken so close together in terms of timeline have come to such two different results?
Senator, I probably need to go back to some of the fundamental differences between the two agencies' regulatory framework. As I mentioned earlier, the FDA's inspection and import alert was placed on Wild Child Laboratories in October 2022. That was based on the inspection carried out in the previous site. In the context of good manufacturing practice, there are multiple requirements a manufacturer needs to comply with. One of the key things is it's site-specific. When we look at the manufacturing practice and their compliance, the facility, the equipment, and how to set up the flow of materials on site play a critical role in the manufacturer's ability to demonstrate compliance. So the import alert was placed on their work of the old facility. The company, since it's moved to the new facility, we actually took into FDA's inspection findings into account. We then conducted inspection our own, factor that into our inspection planning and inspection program. We did confirm some of the findings. We have to take the findings into the context, within the Australian context, within the Australian requirements, because TGA's primary goal is to ensure the products supplied on our market are safe, efficacious, and meet quality requirements. When we did the thorough review of the manufacturer back in 2023, when they moved to the new site, we did confirm some of the findings, but the manufacturer at the new site was able to satisfactorily address those issues. So that's point number one, that we operate on a quite different system, and our focus is about the products on our market. The second thing I want to mention, I know it's a complex matter. Looking at the regulatory framework, I think the best analogy is to look at how you have a recipe in terms of cooking. So when it comes to manufacturing, we look at the end-to-end processes. We look at the materials, the incoming materials, control of the material quality. We look at the manufacturing methodology, batch records. We look at training. We look at whether the processes are actually validated, and we look at the testing report. We look at whether the product has been made in accordance with what's been listed on the Australian Register of Therapeutic Goods. In this context, when we looked at all of that end-to-end processes, yes, we did find deficiencies, but none of those can really explain why, when you've made a product in accordance with what's listed on the ARTG, none of those could explain why the SPF result will be low. Now, the other point I want to mention is SPF is a performance of product. The good manufacturing practice is about looking at the control from a quality aspect, so that provides assurance. If a product meets quality standard, then there's assurance the performance would meet its requirement. We did not find any evidence that the product did not meet a quality standard. Therefore, we could not explain when you have a product that met the quality standard, met the formulation detail on the ARTG, and why would a perform give a low SPF result? That's where we're coming from. The inspection itself could not explain the low SPF results.
Can you, would you be able to release the audit report for us? Because, like, I hear what you're saying. However, there are a number of international experts that have looked at the statements that you've made and still have serious questions. And ultimately, this goes to the public's confidence in the TGA's ability to do work in this space. So, can you release the audit report publicly so that it can be assessed by the public?
So, Senator, thank you for that. So a couple of things. We'll take on notice to release such information as we're in a position to release. Yeah. I would also highlight that this is a fairly crowded space, that there are lots of interests in how processes are reviewed, and these are not only domestic interests but international interests in how those things, and some of those are declared and some of those are not. So it is a very crowded space.
I totally understand that, but at the end of the day, we've got a situation where the FDA's last inspection of Wild Child, which I get what you're saying about change of facility, but it occurred in 2024 and found 7 breaches of the GMP. So it's the Australian public are asking the question: how is it that in 2024 the FDA inspects the facility and finds 7 serious breaches, and then, in September of 25, the TGA undertakes a process and finds such a different outcome. Now, you may say we have different regulations here, but the American regulations and the Australian regulations in this space aren't that different. And that's not just me saying that, that's a number of experts that have given public commentary on this. So it does not make sense to the community at this point as to why these 2 investigations should have come up with such starkly different responses.
So recognise that, Senator. I would relay my earlier point that there is a lot of expert commentary and a lot of it is challenged slightly. We've undertaken to provide you with such information as we can. Yeah,
and just to be clear, Professor Lawler, what I'm asking you to do is release the audit report in full.
I understand that.
Yes, so that's what I'd like you to take on notice. And then, if you cannot do that, any additional information other than what you've publicly made available to this point.
I appreciate it. Thank you, Senator.
Thank you very much. I'll leave it there. Thank you, Chair.
Thank you, Senator Steele-John. Senator Ruston.
Thank you very much. Just finally finishing off on the National Health Reform Agreement, I'm just really keen to understand, Mr Comley, in the press release by the Prime Minister, he quite categorically says that the intention following this meeting was an agreement was reached that the Commonwealth contribution to hospital funding would be, and it says here, with at least 42.5% by 2030. You've said to me that these so-called funding caps, which are in a sense silent here, just saying that the 6.5% cap is going to be replaced by a more generous approach, including cumulative caps. So you've said the caps aren't finalised. You've said that you don't even try to know what hospital funding expenditure growth is going to be over the next 5 years. I cannot understand how the Prime Minister can walk away from a commitment he made, looking down every single camera in Australia, that said he categorically stated that Commonwealth funding to hospitals by 2030 would be at least 42.5%. I just can't understand how you can say that's not the case and that it was caveated. And quite clearly, from the communications we've seen from the states and territories, their understanding of the agreement is completely different from the one that you're putting forward, which I understand you have to, and in your role. Somebody's being misleading here. It's either the states or territories or it's the Commonwealth. Which do you contest it is? You're saying that the Commonwealth is absolutely right in terms of your interpretation, so you're saying the states and territories are completely misleading Australia?
Senator, I don't think it's really for me to get into a commentary on states and territories or Commonwealths. I just go back to the the communique from the National Cabinet, which at the end of that communique, I just note it says, this media statement has been agreed by First Ministers and serves as a record of meeting outcomes. And in the paragraph immediately after the comment about the glide path to 42.5% and 45%, it has, as I said, National Cabinet endorsed, and I quote, National Cabinet endorsed the current 6.5% funding cap being replaced by a more generous approach that applies a cumulative cap over the period 2025-2030 and includes a first-year catch-up growth premium. And of course, that's in the context of the NHRA, which committed before this that the Commonwealth would pay 45% of all additional expenditure subject to the 6.5% cap. So I don't doubt that various people are putting interpretations through at the moment, but that communique to me from 2023 is reasonably clear, and that's been a continuing basis of negotiations to discuss these figures over the last 2 years.
Well, I contest that's not the case, because why are the states and territories saying what they're saying unless you're saying the states and territories are being completely disingenuous? I would read this as saying that the National Cabinet has endorsed the removal of the 6.5% funding cap because they clearly understood that that would be insufficient to reach the 42.5%, to be replaced by a more generous approach that applied a cumulative cap. I would read that the arrangements that they were putting in place were being put in place to ensure that at least 42.5% Commonwealth funding. Somebody is quite clearly being disingenuous here. And it also doesn't say in there that those supposedly new cumulative caps supersede the previous line that says that the Commonwealth's commitment is at least 42.5% before 2030. I admire your attempts at defending the Prime Minister on this, but quite frankly, I don't think anybody could believe that the states and territories would not have thought they were getting 42.5% of hospital funding by 2030 and 45% by 2035. But I understand that you've chosen to take a different view. So can I just ask quickly some questions about neuroblastoma and DFMO? Hi, Ms Shakespeare, how are you?
Well, thank you, Senator.
Good. There was an announcement in July 2024 of a $20 million commitment to provide access to DFMO for children with neuroblastoma. I was just wondering how much of that funding had been spent to date.
I'm going to ask my colleague, Ms Herman, to answer that one.
Hi, Senator. Ariane Herman. I do believe you took this one on notice and it was tabled yesterday, but I'm happy to answer the question. So in July 2024, the Australian Government allocated up to $20 million to provide DFMO free of charge for eligible public hospital patients with high-risk neuroblastoma. A total of 7 patients were supported under this time-limited funding between the 10th of July 2024 and the 7th of October 2024, and the total expenditure was $789,490.90.
So $790,000 or thereabouts. Yep. So of the $20 million commitment, because obviously this is now moved to the states and territories for funding, is that correct?
So the commitment was made on the basis of until a sponsor company established an expanded access program or until DFMO was listed on the PBS.
So currently there is no cure for relapsed neuroblastoma in Australia. We've got in excess of $19 million underspend from the announcement, which was only just over a year ago. Has the government made any consideration or has the department provided the Minister with any advice about relocating the unspent DFMO funding to deal with treatments for children who have relapsed neuroblastoma, like accessing the emerging treatments such as CAR T cell therapy.
Senator, we have now got a PBS listing of DFMO for the indication for which the funding was previously provided. We have arrangements to support CAR T therapy for particular patient groups that have been through the highly specialised therapies assessment processes established under the National Health Reform Agreements.
What about neuroblastoma, relapsed neuroblastoma?
I don't believe that has come forward for assessment of funding under the highly specialised therapies program.
Okay, so what would be required in order for that to be instigated?
So that program is assessed through the Medical Services Advisory Committee, so there would need to be an application to MSAC.
Okay, so there is no active assessment in relation to the suitability for CAR T.
So the government,
for children with relapsed neuroblastoma.
The department would welcome applications at any time through the appropriate process. So for PBS listings, that's to the Pharmaceutical Benefits Advisory Committee. For highly specialised therapies like CAR T, that's through the Medical Services Advisory Committee.
Okay, so the $19+ million has gone where?
So, Senator, the $19 million has been returned to consolidated revenue on the basis that the original commitment was until an expanded access program was in place or a PBS listing.
Okay, so we sort of need to start the process all over again to try and see if we can get access to these little children with brain cancer.
Senator Duncan McIntyre, Technology Assessment and Access Division. The program for $20 million was available as a measure until such time as there was PBS listing. So while the funding from that program was returned to government, there is funding for the condition available through its PBS listing, and those costs are not counted against the $20 million, but they are nonetheless costs to government that are borne by the PBS. So it's not the case that the availability of the therapy has lapsed.
Okay, look, thank you very much. You can imagine this is a very emotive issue for families, so thank you for that. And just proton therapy, Adelaide? Oh, the best dressed person here every time.
Last time it was a birthday, remember?
I know. It's one of my highlights of estimates to see what you're wearing.
I take that as a compliment, Dr. Devlin.
Oh, no, absolutely. It's a compliment.
It's a pretty rare one.
No, you've got an incredible wardrobe. So, can the department confirm the South Australian government has now officially abandoned its contract with Proton?
Yes, Senator, I think we confirmed that in previous estimates.
I think there was I don't know that we actually got it confirmed. And so you've obviously were notified of that decision?
Yes, we were.
Yep. Do you have a date when it was actually abandoned?
November 2024, Senator.
Okay. All right. So in the discussions, I think at the time you said you were having ongoing discussions with the South Australian government about where to from here. So have we had any subsequent discussions with the South Australian government since we last spoke on this about what the expectation is in terms of a completion of a proton beam therapy facility? Well, first of all, in Adelaide.
Senator, so the South Australian government has written to our minister with obviously their request of what they would like to see happen in South Australia and the funding required for that. We are in continuous discussions with the South Australian government. I think it was as recent as the last fortnight. We would have met with them and SAMRI to discuss the issue.
Yep. Minister Butler indicated a few weeks ago and I think it was something along, at some point soon, frankly, we'll go to other jurisdictions in Australia for the so is it likely that the proton beam therapy facility may no longer be in Adelaide?
Senator, I am aware of the Minister's public comments about other jurisdictions, and we are being approached by other centres who believe they have alternate forms of technology that could be used. So no doubt part of our advice to the government would be make sure wherever it is built is the most efficient place in Australia to provide that therapy.
Yeah. So when is will the decision to be made as to whether it's going to be in South Australia or somewhere else? I mean, this has been going on for an awfully long time. Do you have any sense of when this matter is likely to be resolved?
Senator, I'm unable to provide a date, and I do appreciate for the Australian families affected by this. It's disheartening what has happened. So as soon as the government's ready,
a resolution would be great. And so, CoHealth, community health centres in Victoria. Poor pen. Hi, Mr. Rodham. Can you confirm that the federal government has provided $1.5 million to CoHealth?
Yes, I can confirm that, Senator, to keep operations, the general practice operations at the clinics which were foreshadowed to close, continue them through the 31st of July next year.
Did CoHealth approach the federal government for this funding?
On the 18th of September, Senator, CoHealth wrote to Minister Butler foreshadowing the closure in around 4 weeks of 4 general practice services, and at that time they sought $4 million in funding per annum to continue those operations.
The Minister's press release actually says that it was the government that had approached CoHealth board to pause its decision to close. So that's
correct, Senator.
So they advised that they were going to close, and then they asked for $4 million.
At the time that they foreshadowed closing in October, there were further discussions from then on. At the time, further down the track, the CoHealth board decided to pause the closure until the end of January, and there were discussions about funding that could keep the operations going for a longer period of time while a review of the service is undertaken, and that review was also announced in the Minister's press release.
So prior to this funding that the Minister announced in November, was the federal government providing any direct funding to CoHealth?
Yes, Senator, through aged care. There was $7.7 million provided in the 2024-25 year, with a similar amount foreshadowed in 25-26. And the CoHealth also receives funding through the Northwest Melbourne Primary Health Network, which is $2.5 million in mental health, aged care and First Nations services, which was that was in 24-25, and in 25-26 that was similar funding was to be to total $2.9 million. The Victorian government, in terms of the whole organisation, is the majority funder of CoHealth, but as I've gone through there, they do receive funding from the Commonwealth as well.
So that's for activity-based funding as opposed to the operation of the facility.
And that doesn't include MBS funding, Senator.
Yeah, okay. Which obviously they'd be eligible by virtue of the services that they provided, as they would with this other funding. So I'm just interested to understand what is the precedent in terms of the Commonwealth bailing out a series of clinics of this? Is this?
I wouldn't characterise it as bailing out, Senator. It's giving time to have a proper review of those services undertaken to see how those services may be able to continue, or whether there are alternative ways to support the clients of CoHealth. And this funding through to the 31st of July next year enables a review to be undertaken which can provide advice to government to that end.
Okay. So is there other precedents where these types of clinics are actually funded in terms of their base administrative funding, which is clearly where they've run themselves into trouble, will be coming from the Commonwealth? I understand the activity-based funding.
I wouldn't characterise this as base administrative funding, Senator. CoHealth's a diverse organisation providing a number of services to its clients. This is funding to support the continuation of general practice operations for a short period of time while this review is undertaken.
So there's no intention in the longer term for the federal government to be providing this sort of operational funding. It's just the 1.5 million is in order to pause time.
That would be a decision of government. But at this time, that funding is through to the 31st of July with a very set purpose of supporting those operations while a review is undertaken.
Yeah, just interested. We see a lot of cost shifting between the states and territories and the federal government. It's just making sure that that's not what this is.
No, it's not, Senator.
Yeah, cool. I've just got a few questions in relation to mental health and the Productivity Commission's recommendations in relation to the National Mental Health Commission.
Less than 5. Senator Pocock before the break.
Well, Senator, how long have you got, David? Because I'm quite happy to stop now because I've got a tiny block of questions if you want to cruise to the break.
Yep. You're happy with that? That's
yeah,
great.
Go for it. Yeah,
okay.
that helps you.
No worries. Thank you. Thanks, Senator Ross. And Senator Pocock.
Thank you, Chair. Thank you, Senator Ross. And I've got some questions for the NHMRC. That's all right. Professor, is it Wesseling or Vesseling?
Wesseling.
Wesseling. I've got some ideas about I've got some questions about the Ideas Grant scheme. The member for Kooyong, Dr. Monique Ryan, has passed on to me correspondence from multiple researchers who've missed out on NHMRC grants despite strong review scores. And I understand from the Association of Australian Medical Research Institutes that the NHMRC grant success rate is currently at 8.1% of submissions nationally, and even lower, like on a WA's failure rate was 96.6%. Is that correct?
I'd have to take on notice exactly the failure rate in Western Australia, but the other facts that you gave were correct, yes.
Why is the percentage of applications awarded so much lower than previous years?
So I guess what we've seen, and the Ideas Grant scheme is one of our large schemes, and we give around $250 million out each year to the Ideas Grant schemes. And that amount that we give out has essentially stayed static over time, apart from some minor indexation. But what we've seen is an increase in numbers of applications, and we've also seen an increase in the size of applications. So the amount of money that people are asking for in their grants have gone up significantly over the last few years, as has the number of applications. And interestingly, this is an international phenomenon. We talk to our other funding agencies around the world, and they've all seen decreases in success rates due to the fact that there are more applications and larger applications, and so the maths then determine a lower success rate.
Okay, thank you. And how many applications in total were received for 2025?
I would have to, again, I have that, but it'll take me a little bit of time to find it.
Sure, if you can flick through and find it, that'd be great.
Prove.
Sure. And while you're looking, if you're happy to Someone's happy to look for that. While you're looking for that, what's the total amount of funding allocated to this ideas grant round?
It's about $250 million.
$250 million. Did the NHMRC request additional funding for the grant round from the Minister, given it's so in demand?
So we get funding through the MREA, and we get about $1 billion each year through the MREA to distribute for competitive funding in Australia for health and medical research. We divide that up according to a number of our schemes, and as I mentioned, the Ideas Grants is one of our biggest schemes. The Investigator Grant, which supports salary for high-performing investigators, is our biggest scheme, I think the sector has for some time indicated that increase in the size of the MREA would be helpful.
Have you requested that?
We have not requested that, no.
Is there a reason you haven't requested that? If you're clearly getting a heap of good applications, the sector's asking for it, why haven't you asked for more money?
So we're in the process right now with the Department of developing, and chaired by Rosemary Huxtable, of developing a National Health and Medical Research Strategy. I think that as that strategy is developed, and it will be developed and finalised in the next few months, that we should be looking at the strategic goals of health and medical research and the resource required to achieve those goals. And I think it's likely that you would see within that strategy that more resource given to health and medical research would increase innovation and increase health productivity in the country, and that's where we'd like to see the argument being made around a true strategic view of health and medical research, rather than an ask for more money at a time when we're developing that strategy.
Sure, but it's been well oversubscribed for a long time now, and I'm just interested why, all the strategy stuff, we know that takes time, it's really important, but in the meantime, you've got the vast majority of researchers who put grants in being unsuccessful. Was the consideration that you didn't want to ask because you thought it may not be in line with the strategy, or...?
No, I think the sector has been clear that more resource for health and medical research would be important, and Australia has consistently performed above international standards in health and medical research, and we believe the sector would absolutely believe that more resource put into both discovery and translational research would be an advantage, absolutely. I think it's a discussion between the sector and government in regard to that is important.
And from where you sit, do you consider acceptable that more than 50% of grants assessed as excellent, scoring 6 of 7 in this ideas round, were unfunded? And maybe what advice do you give to people whose grant applications were clearly excellent, but no money?
So a couple of important points. One is that there is a range of grant processes, including the MREA and the MRFF, and a number of grant processes, including ideas, development grants, and so on. So people do have other opportunities to apply, and we are seeing people are applying to multiple opportunities across the year. So those people who weren't necessarily successful in the ideas grants may be successful in an MRFF grant or an ARC grant or some other grant. So that would be my first point. My second point is that I do acknowledge that there is a significant resource in writing grants, and that if we're expecting our sector to write a lot of grants for relatively low success rates, then that is probably, there's an inefficiency inherent in that. And I think the strategy is looking at that and looking at ways to address that.
Yeah, I mean, it's a huge concern for me, and we've heard, the Treasurer and other government ministers talk a lot about Ezra Klein and Derek Thompson's book Abundance. And one of the things they talk about is productivity in research, where you've got researchers who are top of their field and they're spending half their time filling out paperwork rather than actually working on the next breakthrough. One of the other things I was interested to find out more about is the timing. I'm hearing that there's researchers who still haven't heard back and are wondering if they've got a job next year. And I'm just wondering why it's taken so long and when you expect to notify all remaining teams of their grant application outcomes.
So all of the ideas grants have been, all the applicants for the ideas grants have been informed of those outcomes.
When were they? When was the last?
That happened on last Friday.
Last Friday. And this is for...
There was a lot of interest, which meant there a lot of people were trying to look for those results. But certainly by Friday and Monday, all of those results were assessed.
Okay.
Accessed.
But do you accept that that's still fairly late?
Late in the year, you mean? Well, that is as I said, there are a number of grant opportunities throughout the year. This was the timetable for ideas grants. And so people were aware that they would be made available later in the year. There is a significant peer review process, as you could imagine, for that many grants. And then obviously sign off by government. So that all takes time.
Okay. And as part of the, just so I understand it better, as part of the grants process, is there a set date for the release of outcomes of grants rounds?
So we give an approximate date. We don't give a definitive date.
How wide's the?
So the band? We indicated that those grant outcomes would be available in November, as an example. Again, these are large grant schemes, as I mentioned, approximately $250 million. That means there's, and as you had indicated, the success rate, so you can work out the applications, and Prue will have that. That means there's an enormous amount of peer review going on, enormous amount of quality assurance by us, peer review by the sector, quality assurance by us, and that all takes a significant amount of time to do.
Minister, maybe just to ask about our record low investment in research and development as a percent of GDP. Like, this is a genuine issue for a country that's, I think, in desperate need of diversifying our economy. And I just wanted to read out a few comments from researchers who've been part of this process. 8.1%. Imagine the thousands of hours of work going into this pointless exercise. Not just the generation of data, the hours of writing, the hours administrators spend on 91.9% of grants that were not funded. All the time the reviewers spent to do the best job they can with a system that makes it very easy to bring a grant down by one. Anyway, it goes on. How can Australia afford to waste this amount of time and talent? I only say this much. The politicians here do not care about science. They pay lip service because, in contrast to most European countries, they know that the economy here does not depend on how much, on know-how and knowledge, but on digging dirt stuff out of the ground and shipping it overseas. That's the economy of yesterday. Maybe the last one talks about the sort of rate. Despite world-class ideas and years of work on significant health issues impacting the community, this is not sustainable, it's not fair, it's not smart. And I'm just wondering, you've got, we've talked about cuts to CSIRO in a separate hearings this week, but how can we better look after these amazing researchers and scientists across the country who clearly want to do good work for the country, for communities, but there's just there's not enough investment in science and in research.
Just want to flag that after the Minister gives her
Yeah,
answer.
sure.
We are at the hard marker of the dinner break.
Very happy.
And so I will, if you've got further questions,
I've
I'll
got
invite you
nothing.
back
Thanks,
after
Chair.
dinner, but I'll just let the Minister answer this question.
Thanks, Senator. The government does care about science and we listen to scientists.
I understand that they're sort of emotive. So
No, I understand.
yeah.
I just want to put that on the record. And particularly the Minister has been listening to the sector and has heard those calls for an opportunity to look at how we can strengthen health and medical research. That's exactly why we are developing the national strategy. It is being developed by Rosemary Huxtable, who I think you'll agree is a preeminent person to be able to undertake this work. There was a consultation draft released in September, so that work is progressing, and it's a really important opportunity, I think, to get all of the views on the table, but also to make recommendations to government around how funding arrangements could be improved in the future. So we've heard those, those concerns. We certainly do care about science and scientists, and that's why we're actually undertaking this work, and that's why the Minister took the step to ask for a national strategy to be developed.
Thank you very much. Thank you, Chair.
Thank you, Senator Pocock. The committee will now suspend for the dinner break.